Наш мир не стоит на месте. Он стремительно развивается и дополняется новыми данными. За 5 лет человечество произвело информации больше, чем за всю предшествующую историю. Прямо сейчас мы становимся свидетелями развития компьютерных технологий, освоения космоса и инновационных открытий в медицине. Современный образовательный процесс требует от специалистов постоянного совершенствования, в том числе и в вопросах научно-практической квалификации. Возникает острая необходимость в независимой площадке, позволяющей специалистам иметь доступ к передовым достижениям в области терапии. Евразийская ассоциация терапевтов – это уникальный глобальный проект объединения специалистов разных стран и различных областей клиники внутренних болезней, направленный на развитие и совершенствование помощи пациентам терапевтического профиля. Это современная площадка, предоставляющая участникам Евразийского медицинского сообщества доступ к уникальной базе данных, а также возможность обмениваться мнениями и делиться опытом.
Мы объединились здесь, чтобы сложить наши усилия в борьбе за долголетие, процветание народов наших стран.
В Ташкенте открылся 4-й съезд Евразийской ассоциации терапевтов.
В Минске открылся 5-й съезд Евразийской ассоциации терапевтов.
И мы всегда с оптимизмом смотрели в будущее. Нас объединяют общие корни, общая история. И я надеюсь, нас объединяет светлое, большое будущее.
Миссия ассоциации – создание международных медицинских, исследовательских и образовательных проектов между странами Европы, Азии и СНГ. Ассоциация проводит образовательные мероприятия с участием ведущих экспертов. Съезды, конференции, телемосты, школы. Научная программа конференций подготовлена с использованием современных образовательных методик и инновационных форматов. Сегодня ассоциация уже объединяет тысячи практикующих врачей и экспертов из России, Европы, Азии и СНГ. Она помогает совершенствовать медицинские знания и опыт каждый день. Для нас важно сделать процесс медицинского образования непрерывным, современным и максимально доступным. Вступив в ассоциацию, вы становитесь частью глобального сообщества специалистов, работающих под научной и практической составляющей современной терапии.
Добрый день, уважаемые коллеги. 7 лет – это очень длинный путь.
Good afternoon, dear colleagues. 7 years is a long way, and 7 years after the establishment of the Eurasian Association of Therapists in 2013, I'm honored to open today the 10th anniversary conference, the Congress of Internal Medicine. Will have 3 full days dedicated to the inner organs, the diseases, comorbidities, association with COVID-19. And of course, we'll speak a lot about pandemics. It will be a really saturated program. It's our anniversary conference that convened speakers, over 100 speakers from 15 countries of the world. And this conference comprises specialists from Eurasia and other continents. It's a unique conference that will raise the most unique, completed, state-of-the-art, freshest data of the medicine today. I want to say that over these 7 years, the Eurasian Association of Therapists has had a long way full of bright events. And right now, I'll ask you to launch the summary video, and after that presentation, I'll tell you about the content of the conference, about what we managed to do over the 7 years and what we did together in education technologies and modern medicine. We'll watch the video now and we'll talk about the key changes, the key thresholds on this way, and the wonderful events that colored our way. Please note that Eurasian Association of Therapists exists for 7 years now. These are 7 years of research and educational projects. Eurasian Association of Therapists is a member of the National Medical Chamber since 2019. However, it doesn't eliminate the scope of cooperation. Have a look. You see a lot of structures, foundations, associations, medical societies worldwide that the association is cooperating with or is in partnership. We acknowledge very well that the Eurasian Association of Therapists has in its core a mission of modern education in medicine. What have we done over 7 years? We have conducted over 750 schools. Over 80,000 participants were present at these schools. It's a huge professional crowd. We also had conferences. We conducted 14 conferences with over 25,000 participants sitting and listening at the conference. I'm not saying of the online viewers. And of course, we have webinars. Today, in 2020, we're changing the formats. We conducted over 100 webinars and over 150,000 connections and views of our webinars. These ambitious projects came true due to our joint efforts. And of course, we not only conduct educational activity, but also scientifically. We work on the registers, and of course, it's impossible to work without registries today. And Hyperion registry that was completed in 2019 is one of the brightest examples. It comprises the patients with arterial hypertension patients. You can find here different guidelines, algorithms, calculators on different diseases, nephrology, endocrinology, calculator of cardiac risks, so on and so forth. We know very well that on the website you can always find the guidelines, algorithms of treatment, including the ones about anticoagulant therapy and comorbidities. So Hyperion registry is a bright example of our work. Look to what extent we have comprised our research base, 67 cities of Russia, 1,500 patients. This is a wonderful example of our work. This year, I want to specifically dwell upon the changes brought with pandemics. Let me tell you how the Eurasian Association of Therapists, due to our joint efforts, began the activity in education, further research in COVID-19. Despite the fact that the majority of Eurasian Association of Therapists experts began their work in the red zone, nevertheless, we continued developing educational projects and we continued the research activity. The first chapter, coronavirus, was created on our website. You could see the Brescia scare score, their guidelines and video lectures on COVID-19, statistics, news, etc. And of course, it entails a whole series of publications together with the Russian Society of Cardiology and other associations. We invited the experts who were really working in the red zone, and we have published a number of works and guidelines on a treatment of group of patients. They were published in the leading medical journals of Russia and other countries. Cardiology journal published the consolidated position of experts in springtime when it was needed the most, and it developed an algorithm of working with COVID-19 patients. This is not the end, I have to say. We went even further. Eurasian Association of Therapists began a huge to maintain a huge Eurasian registry called ActiveCov to study the Eurasian population infected with SARS-CoV-2. This international, I would say, project comprised 2 countries, 120 researchers, and over 4,200 participants enrolled. Later, I will report report on the results of the second year of this registry, I'll tell you what we know about our population by now, because it differs strongly. We went even further. Eurasian Association of Therapists became part of the Russian consortium on the study and sequencing of coronavirus genome that causes COVID-19. Together with other keynote organizations, we studied the Russian genome of the virus mutation that is present in different countries. This is another research scientific project of the Eurasian Association of Therapists that we can really be proud of. This whole work is conducted with pandemics in place and with our experts working in red area. In this way, I want to say that this is a great contribution of our experts, but it would be impossible without the support of the medical community, without your questions, without your requests to shed light on new topics. This would have been impossible. So I'd like to express the words of deep gratitude to all those who continued their education in pandemics, who worked in red zone, who helped the patients irrespective of their diagnosis, whether it was COVID-19 or not. And our joint efforts led to further research and further education to go on. Those who are connecting to us for the first time, here is the official website of our association, euat.ru. We're well represented in social media. We know that a lot of additional information is present there, interesting articles, journals. We're on Instagram, on Facebook, in Kontakte. We are present where we need to be present and where the young specialists are. At the Congress today, we are going to have a unique format. We will comprise 15 countries. These are various countries: UK, US, France, Armenia, Thailand, Serbia, UK, Slovenia, Kyrgyzia, Russia, etc. 15 countries, over 100 speakers. The conference is bilingual. It's fully bilingual. I'm going to speak, but all the sessions will be simultaneously interpreted into English and vice versa, 3 days and 15 scientific sessions. We'll have unique formats, and unique formats, for example, the session of today, the Future of Modern Medicine, Future Forum, where the representatives of 7 countries, including Russian stars of resuscitation and anesthesiology, will discuss the changing face of medicine after 2020 pandemics. What will change and what are we to anticipate in the coming years? 7 countries, diverse experience: France, Russia, Kazakhstan, Slovenia, 7 countries that face pandemics and the future of medicine today. When we are speaking about these formats, the speedy session tomorrow and day after, I'd like to draw your attention to the fact that European Association of Therapists is putting up all the efforts to make these formats interesting, to make them unique, and for us to be able to say proudly that the entire information we provide is really new, the newest. It is my pleasure to give the floor for a word of welcome to the Minister of Healthcare of Perm region, Oksana Borisovna. Oksana Borisovna, please. I do apologize. We have some technical difficulties. So while Oksana Borisovna is getting connected, I'd like to give the floor to Igor Bakulin, Doctor of Medicine, Professor, Chief Therapist of Northwestern Federal District of Russia. Igor Gennadievich, the floor is yours, please. Dear friends, dear colleagues, let me congratulate you on the opening of the 10th anniversary conference of the Eurasian Association of Therapists. The conferences that the Eurasian Association is conducting are traditional now, and due to the participation of the leading experts from Russia and worldwide, we have an opportunity to discuss the most recent and hottest topics in modern medicine, and there are various formats from clinical cases to interactive discussions. Northwestern Medical University, after Mechnikov, has always been an active participant of the Eurasian Association of Therapists. It is always a great pleasure to keep developing hand in hand with true professionals who managed to bring together different medical associations of Russia and world. Our mission, the mission of educators and scientists, is to share our best practices together. I would like to mention the Society of Gastroenterologists and Hepatologists of Northwestern region. They are also active participants within the framework of our symposium hosted by the Society of Gastroenterologists of Northwestern District. We will offer to your attention everything that can be helpful to therapists in their daily work from the perspective of gastroenterologists. And last but not least, our project called Eurasian Association of Therapists has a bright future, and all the best to you, friends. Esteemed colleagues, we have an opportunity today to speak about a huge scope of problems of modern medicine. This plenary session is filled with various and most recent data that we have for now, and these are the questions of interest for the practitioners, matters of rheumatology, rheumatological diseases, active co-Eurasian register.
Это и стратегия лечения сердечной недостаточности, это и вопросы лечения гепатита С. Пленарная сессия сегодня собрала ведущих экспертов, лидеров мнений, которые поделятся своим опытом и продемонстрируют самые последние существующих данных в области введения болезней внутренних органов. Я с огромным удовольствием передам слово в ближайшее время, сейчас подключится спикер, и я с огромным удовольствием передам слово для первого доклада Мазурову Вадиму Ивановичу, профессору, доктору медицинских наук, члену-корреспонденту Академии наук, человеку, который является одним из ведущих лидеров мнения в области ревматологии, человек, который по сути является основоположником ревматологии, человек, который поделится опытом с докладом иммуновоспалительные заболевания и проблемы коморбидности. Сейчас мне подскажут, готов ли Вадим Иванович, так как мы идем в онлайн-формате. Так как мы идем в онлайн-формате, у нас могут возникать небольшие технические задержки, но ничего страшного, мы постараемся уложиться сегодня во времени. Пока это идет, я напомню, что сегодняшняя конференция, которая будет идти 3 дня, аккредитована 15 баллами непрерывного медицинского образования. Для просмотра необходимо присутствовать зарегистрировавшимся пользователям. Тем, кто не имеет необходимости в баллах НМО, может просто присутствовать и просматривать конференцию без участия, без этой регистрации, естественно, являясь обязательно медицинским специалистом. Я хочу сказать, что в ходе этой конференции будут затронуты следующие вопросы. Сегодня из интересных это пленарная сессия. Конечно, это про versus contra.
Several interesting sessions, pro versus contra, where there will be two different opinions in the field of internal medicine. Naturally, symposia where we're going to discuss the different issues and endocrinology, thyroid gland diseases, pulmonology, etc. Tomorrow, there will be 2 symposia devoted to COVID-19, internal organs, damage in COVID-19. Experts working at the Red Zone will share their experiences, modern management of such patients. Tomorrow, there will be a special session devoted to anticoagulation therapy. Also, tomorrow, there will be an issue related to heart failure. Also, there will be interesting discussions. Vadim Ivanovich has just joined in. He is a professor of medical science and academician of the Russian Academy of Sciences, one of the leading specialists in the field of rheumatological diseases. He will be speaking on the following subjects: immune-mediated inflammatory diseases, IMIDs, and the problems of comorbidity. Please share your presentation with us. distinguished colleagues, allow me to welcome you here. And I'd like to say that we're happy that we managed to meet at this Eurasian Association of Therapists Congress. And today we'll be talking about issues which are very relevant, not only for internal medicine of Russia, but also for the entire world. So let me just focus on the major issues related to immune-mediated inflammatory diseases. That's a large group of different diseases, such as autoimmune diseases, and also these patients are more vulnerable in terms of comorbidity. Many population studies starting from 2018 have shown a twofold increase of the risk of cardiovascular diseases, ischemic heart disease, the risk of heart failure in patients with rheumatoid diseases as compared to the control group comparable by age and sex. What's the reason for this high level of comorbidity in terms of IMIDs and especially autoimmune diseases such as rheumatoid arthritis, polymyositis, and many others? First and foremost, I'd like to focus on the factor that besides the traditional risk factors shown here, an important role is attributed to inflammation factors, not just a C-reactive protein, not just active cytokines which participate in the inflammatory process, but also such things as interleukin 6, interleukin 1, interleukin 17. I should say that the specific factors which play an important role on the development of comorbidity is the duration of the inflammatory process per se, different manifestations such as destruction of joints, also vessels, and there are also additional specific factors which play an important role in the initiation and maintenance of comorbidity. The proof of that is the well-justified studies showing that the level of systemic inflammation in patients with IMIDs is quite significant. The higher the systemic inflammation, the higher the cardiovascular risk. For example, such diseases as rheumatoid arthritis, psoriatic arthritis, spondylitis. Well, you can see that C-reactive protein plays an important role in the duration of such diseases. It is accompanied by a high cardiovascular risk, moderate inflammation, which are typical for osteoarthritis, for the elderly patients. Here, we're talking about such things about as the C-reactive protein, but the activity of C-reactive protein is lower and the risk is lower as well. The lower the level of C-reactive protein, the lower the activity of the inflammatory process. So we can see all these mediators, and of course, we can add here the endothelial dysfunction, body mass index, and diabetes mellitus, which also play an important role in the onset and the maintenance of comorbidity and diseases like that. Rheumatoid and cardiovascular diseases. Cardiovascular diseases account for 40% of all cases of death. Unfortunately, we have no sound from the speaker.
Ну и что касается хронической сердечной недостаточности, она выше примерно на 87%, чем в популяции.
It is high by 70 to 80% as compared to the general population. These data are comparable with metabolic syndrome in case of diabetes mellitus and rheumatoid arthritis. Recently, we also pay a lot of attention to microvascular dysfunctions in case of autoimmune diseases, such as coronary microvascular dysfunction, often takes place together with autoimmune diseases and is related to the higher level of cardiovascular diseases and death from them. Inflammation plays an important role in pathogenesis of atherosclerosis, especially in patients who suffer from rheumatoid arthritis. And in this case, we should pay more attention to the fact that the use of immunosuppressants in such cases reduces cardiac risks. Well, this still requires serious proof, but some data already exist as part of publications. The assessments done by the international community, such as EULAR in particular, focuses on cardiovascular diseases and diseases which are very widespread and lead to disability linked to this group of diseases: rheumatoid arthritis, spondyloarthritis, connective tissue diseases, and osteoarthritis. So we focus on these issues, and as far as comorbidity is concerned, the cardiovascular diseases, acute myocardial infarction, angina, and other diseases shown here play an important role in the prognosis and the duration of such diseases. Malignant tumors and infections should also be taken into consideration. Today, when we're talking about COVID-19, this is also one of the issues that requires special attention, especially as far as patients regarding the actions of doctors and patients to avoid the contraction of COVID-19 by such patients who already have immunodeficiencies and have to take cytostatics as well as biologics. Another important issue that should be taken into account is that IMIDs often occur in patients with non-steroid patients with stomach diseases, especially those who take NSAIDs. The most often comorbidities in such diseases as rheumatoid arthritis and psoriatic arthritis are shown here. This is the data of the Australian registry showing that hypertension ranks first, and this is quite understandable because today we pay more and more attention to this group of patients. And these are patients with the poor prognosis who have a large range of image depression, GI diseases, and other diseases. These are diseases which are typical for such patients of the elderly age. Does comorbidity have an impact on the therapy conducted? That's another issue we should discuss. We can say with confidence that the answer is yes, comorbidity has an impact on the duration of IMIDs as well as therapy of immune-related inflammatory disease. For example, rheumatoid arthritis, spondylitis, psoriatic arthritis. Well, I think there is an important test, MRDCI, and if we are talking about such diseases, such as cardiovascular diseases, GI diseases, elevated BMI, diabetes, and many other diseases, which in fact determine the effect related to the reduced efficacy of the therapy. The materials prepared here are not just in the Italian publications, but also in the Russian publications, confirming the fact that if we're talking about comorbidities in case of rheumatoid arthritis, the presence of one or two comorbidities reduces significantly the efficacy of therapy conducted. And you can see here that if this index is 0, Here you can see effective therapy, which lasts for a long period of time, and that's approximately 120 months. This curve shows the drop in the efficacy of therapy when the patient has one or two comorbidities, especially those which can have a negative impact of immunoinflammatory process. In this case, the efficacy of therapy is much lower. The same is true of spondyloarthritis. You can see that Kaplan-Meier curve shows that this ratio remains basically the same as in case of rheumatoid arthritis. In case of IMIDs, we can say again and again that these things are typical. The efficacy of therapy is much worse in case of comorbidities, cardiovascular diseases, and the mortality rate in case of ankylosing spondylitis and psoriatic arthritis. These are two very important diseases which have an impact not just on efficacy of therapy per se, but also are linked to risk factors. But I have already mentioned there might be other factors involved, such as medical therapy, which has a specific impact on the cardiovascular system. Nevertheless, we still cannot give a definitive answer to the question of to what extent NSAIDs are dangerous for people with cardiovascular risk. We can say with confidence that if we are talking about specific diseases of the coronary bed, often these diseases are accompanied by the damage to vessels and the carotid vessels in particular. Well, we can say that effective therapy in this case, well, can reduce cardiovascular risk to some extent, and our experience will probably show to what extent this therapy can be effective as we treat the IMIDs and at the same time can reduce the cardiovascular risk. As for EULAR recommendations on treating patients with comorbid conditions and cardiovascular diseases, first of all, I should say that the activity of the disease should be thoroughly monitored, and the Russian Association of Rheumatologists is paying a lot of attention to this in order to minimize the risk of cardiovascular diseases in patients with IMIDs. That's an important thing to do. The assessment of cardiovascular risk is recommended for all patients, and it should be done at least once in 5 years, especially when we're talking about anti-rheumatic therapy and its control. The assessment of cardiovascular risk should be done according to national recommendations. And I should say that score scale, which is being used quite often, has the coefficients because it's 1.5 when we assess the cardiovascular risk according to the score scale. Well, general cholesterol and should be also taken into account when there is the low activity of the disease. All patients should change their lifestyle and also deal with the risk factors which have an impact not only of cardiovascular diseases but also on IMIDs in general. Particularly patients with the high risk, patients who have the need to take NSAIDs. These drugs should be administered with care only after we have all indications and contraindications and assess the risk of their use. When glucocorticoids are used for a long time, there should be a reduction of the dose in time. And these provisions, on the one hand, are easy to comply, but on the other hand, can have an impact on the reduction of cardiovascular risk. Today, we also focus on such things as those who suffer from such diseases. well, must be tested to exclude the TB or viral infection once in 6 months, including tests for latent tuberculosis. Dear colleagues, today we are in the midst of the COVID-19 pandemic, and we can make one conclusion. If the patient is on this therapy and is not infected with the COVID-19, the therapy should be continued during all this period of time. Cancellation of this therapy can be only in case of COVID-19 infection, and patient can be put on these drugs again when he or she recovers from COVID-19. That's an axiom, but we can say that biologics besides rituximab and other drugs have an impact on T lymphocytes. NSAIDs are not the additional risk factors in terms of contraction of COVID-19. Thank you so much. Vadim Ivanovich, thank you for this interesting presentation. Thanks for raising the topic of not just rheumatic diseases, but also the link between rheumatic diseases and COVID-19. Vadim Ivanovich is involved in the work on the use of anti-rheumatic drugs on COVID-19 patients in St. Petersburg, and they are publishing data on this issue. We know the role of these drugs in treatment of patients with COVID-19, but we should look at this situation from a different angle. What's the risk of infection of COVID-19 of such patients on this or that particular therapy? Thank you for this brilliant presentation. Let's continue. I should say that this conference is being held in 3 cities. At the website of the conference, you can find the program for each city: St. Petersburg, Moscow, and Perm. In each city, there is the agenda, and it is in 2 languages, and there are additional symposia, and it is full of interesting information. Let me just give the floor to myself. I'd like to present unique data obtained on the Eurasian population of patients with COVID-19. Just a minute. These are the data from our registry. Dear colleagues, what are we aware of today as far as COVID-19 is concerned? Each population is different, and we have no other way but to compile registries as a challenge to the COVID-19 pandemic. So the first data for 1,000 patients were already presented at the National Cardiology Congress. Ekaterina Trilovskaya made this presentation. Well, these are the second group of data from the registry. What kind of registry is it? First of all, I'd like to express my gratitude to different people. You can see a long list of different names. These are the researchers in different countries and cities who worked in the red zone and who provided data for this registry and continue to contribute to the study of COVID-19 on different subpopulations of the patients. The geography is very wide. The 4 countries were included, 34 healthcare facilities. The registry is closed. It is multi-center registry. We enter data who are hospitalized or who are outpatients. So there are 2 groups of data, hospitalized and outpatients. Well, let's ask the first question. What's the average age of patients included in the registry? Does it comply with the data which are global? The average age is 58 years, which is basically the same as the registry in other countries, China, Europe, the United States. As for the severity of patients, it was assessed by way of computer tomography because lab tests are available later. Right now, we can just judge on the basis of saturation and CT. If we have a breakdown by patients by CT stages, the first degree 34%, the second 45%, that's the more severe group, third one 18%, and a small group of 3% of patients CT4. But if we look and just to divide these patients into in and outpatients, you can see that the outpatient group had more patients with mild diseases, while hospitalized patients have more severe diseases, CT2, 3, and 4. An interesting thing is that if you look at how often a CT was done, at least once in 90%, that means 10% of patients didn't have access to CT. The diagnosis was based on the basis of clinical manifestation and lung X-rays. Well, as for the mortality rate, are we different in terms of mortality rate from other world registries? Well, we have the mortality rate of 3% at this point. We have analyzed 1,500 patients. That's the second group of patients. And right now, the mortality rate is at the level of 3%. If we compare it to Italy, that's not much, but if we compare the data to China and the United States, it's basically the same as in China and in the US. We correlate with the data obtained in other countries, not only in terms of patients in ICU, there the mortality rate will be higher. But let's look at the severe patients who are at the death's door. We know that these are mostly elderly patients. We also know that these are patients who have a higher degree on CT, who need a ventilator, oxygen. Well, they need some serious oxygenation. Also, patients with hypertension. That's one of the peculiarities of our registry. As for the data on the mortality rate and on hypertension, they were higher as compared to other registries. So, in fact, the hypertension in the Eurasian region is one of the major risk factors for the development of the negative scenario of COVID-19. Well, lab precursors, we always look at the situation when we get the lab data. We know that lymphopenia is negative prognosis. Of course, the higher the dimer is, the higher might be the rate of death. Well, CRP level is usually high in such patients. As for C-reactive protein, well, we must ask ourselves a question. Should CPR be higher in hospitalized patients or not? Should it be higher in patients with comorbidities? Let's look at the situation. If we divide the patients by comorbidities into two groups, younger and older than 60, we can see that the number of patients who had cytokine storm is much higher in the group of less than 60. In a group over 60, well, comorbidity did not have an impact on cytokine storm, but under 60, again, we can see 4 diseases against 1. The odds ratio is 1 to 3 for the development of the cytokine storm. The more comorbidities have a patient, the worse the prognosis we have. Let's look at some regimens, just some regimens. We cannot assess everything when we have data for the second group of patients, but some issues should be covered. In terms of C-reactive protein, in terms of cytokine storm, can statins, and this question has been debated all over the world, can statins have an impact? Well, statins had an impact on hepatitis C. Well, statins improved the outcome in treatment of hepatitis C, but we can see that patients on statins increases the probability of the lowering of C-reactive protein. Statins have the anti-inflammatory effect. As for sartan inhibitors, for example, and here the issue is very arguable. Patients over 60 who were on inhibitors had a higher probability of cytokine storm, but lower the mortality rate. So if the patient was on such inhibitors, well, in fact, the patient had hypertension, and this may be the severe cause of the disease. That's true. Patients with hypertension have a longer hospital stay. Patients with hypertension, well, have a higher rate of death, as well as chronic kidney disease leads to a higher rate of death. Untreated hypertension is a powerful negative factor for the worse prognosis of COVID-19. Patients who were treated for hypertension had a better prognosis. Those patients who took sartan inhibitors had a better prognosis. Well, since we have mentioned the word hypertension all too often, to what extent the hypertension prevalence rate is different in our region as compared to other regions? Well, you can see that we have more patients with hypertension. Well, patients with hypertension are more prevalent in Russia as compared to the United States, twice as more in Russia and as in China. So a person with hypertension is always associated with diabetes. Diabetes mellitus is another second risk factor for COVID-19. Diabetes and excessive BMI. We know that these patients have a shortness of breath. The higher the BMI, the higher the viral load. Is it really so? Well, unfortunately, we have just data related to obesity, that is BMI more than 30. Well, here the data are the same as in the United States, but we have a situation which is double in terms of complexity as compared to Spain. So you can see here that obesity cannot be just by itself. It is always accompanied by different concomitant diseases worsening the outcome. Hypertension, excessive BMI, and diabetes are the three risk factors. As for patients with diabetes mellitus, they also had the higher mortality rate, especially diabetes mellitus type 2. Well, we'll discuss this mechanism tomorrow. There will be two symposia devoted to COVID-19. Of course, many other speakers will also cover this issue in their presentations. Patients with comorbidities, diabetes, obesity, cardiovascular diseases have a higher mortality rate. Untreated hypertension worsens the prognosis of any hospitalized patient. As for diabetes mellitus, chronic kidney disease, well, these patients also have a higher mortality rate as compared to other studies. Well, you can see the data here. We can see a huge number of patients with hypertension when the prognosis is very poor. Also, we had the hypothesis of the slow formation of the immune response in patients with comorbidities. Is it really so? We assessed the dynamics of antibodies, and there is a clear correlation on IgM. As for IgG, there was no difference, but for IgM, there is a clear difference. The more severe the disease, the lower the level of IgM, and probably the worse is the full-scale immune response. We saw patients who did not recover by the time of the discharge, and there were no significant titer of IgG or IgM, telling us about the formation of the immunity. Well, we need to study this population further due to our efforts. 4,200 patients are included in this registry. That's just the second group of patients, 1,500 patients. When we get data on the dynamics of the disease, on how hypertension and diabetes changes, about how due to hypoxia we have a different prognosis regarding the ischemic heart disease, we'll be able to make better conclusions, which would be written into new recommendations. The need for such trials is quite obvious. This is one of my last slides, and compared to other registries, we had a higher number of patients. Of course, 1,500 patients are not enough to make conclusions, but we know that in Russia, as well as in Kyrgyzstan, Kazakhstan, in Armenia, who gave glucocorticosteroids to such patients, had a higher number of patients who had such drugs. Well, in Europe, they used small doses. In the countries I mentioned, they were high doses of these drugs. In the United States, they have a different population. We did not have deaths related to thromboembolic complications, so just a few deaths like that. If we look at our statistics and the Italian registry, you can see that as far as hypertension and ischemic heart disease were worse in Eurasia. That means there is room for further work. If you want to participate in adding data to this registry, please get in touch through info@ur.ru, or you can send us a message in Instagram. If you want to join this project, we'll be glad to support you, and we'll meet any initiative with open arms. The first publications are almost ready. Thank you so much for your attention. I'd like to thank all the researchers and doctors. I should say that soon we'll get new data on a larger population of patients. In this case, we can talk more about the use of anti-rheumatic drugs, hormones, and antibacterial drugs. Meanwhile, I'd like to give the floor to the next speaker. And the next presentation is devoted to the comprehensive protection of patients with atrial fibrillation in the time of COVID-19. Professor Arutyunov will make this presentation. Gregory Arutyunov will be talking about what to do in case a patient has atrial fibrillation. That's a patient who has the coronary risk. A patient with AF might have dementia, and so on and so forth. So it's a great pleasure for me to give the floor to Grigory Arutyunov. Grigory, the floor is yours. Thank you so much. I'd like to draw your attention to the issue of protection of the elderly patients. AF is becoming an important problem. Here we're talking about two things, the elderly patient and atrial fibrillation. Let's start with the postulate. The risk of bleeding is always lower than the risk of stroke. The reduction of the dose, not justified by the performance status of the kidney, is a mistake on the part of the doctor. A patient who suffers from atrial fibrillation from the elderly group dies not from arrhythmia problems, but this patient dies from MI and stroke. That is why the issue of progressive disease of the kidney is an important issue. Don't forget about compliance, which is being reduced with age due to cognitive problems. In speaking of the elderly patients, we are talking about very important actions. First of all, we should speak about the right selection of drugs to control the risk of stroke development, to reduce the risk of concomitant diseases, to enhance the compliance, to maintain the performance status of the kidney. Unfortunately, up to 1/3 of patients do not feel atrial fibrillation. That is why screening is important. Modern recommendations, which were published several years ago, stipulate that patients over 75 should be mandatory candidates for screening for AF, especially when patients have sleep apnea and patients who have abdominal fat. The second group of patients over 75 years, 9% of patients like that to have AF. So these are the largest groups of patients. What has been done in terms of registering AF? Of course, there has been a breakthrough, and here we're talking not about 12 lead ECG. We are talking about watches, about bracelets, about rings and applicators. Well, you can see one of the first results, Apple Heart Study. Well, 420,000 patients. Well, you can see that 0.5% had irregular rhythm. Huawei Heart Study, 187,000 patients. Well, you can see there has been a breakthrough. Another approach is called 4SAF. As you can see it here, first stroke. Well, there is no patient with AF who has no risk of stroke. Next is severity of symptoms. You should know what particular symptoms these are. There's a special scale to assess the symptoms. Well, you must make an assessment of such assessment. The third S is severity of AF burden. Well, will the paroxysm stop itself? How many paroxysms the person had? And the fourth S is substrate severity. The idea here is that the elderly patient is considered as a patient with several major problems. The second methodological approach is ABCA. There is no patient without anticoagulation therapy. B, we should control symptoms. C, we should control concomitant diseases. The CHA2DS2-VAS score has changed. There are new requirements here. The green field is the old scale and with aged function. Well, you can see that there might be systolic dysfunction, which was added, including asymptomatic. The second green field, atrial hypertension. Now there is the specific level for patients with atrial fibrillation. The target is 120, 129. Diabetes mellitus. Diabetes mellitus type 1 was added, the fourth green field. What do we have here in terms of new additions and geographically confirmed ischemic heart disease? And of course, this changed the risk of the development of stroke. Again, here you can see changed CHA2DS2-VAS. Again, we identified the group of patients which are candidates for treatment. Look at the second red line. We never started with the algorithm. Now we should identify patients with the low risk and look at where the arrow points to have no treatment. So I've identified a group of patients who are candidates for treatment. So you calculated the risk of bleeding. You started the oral anticoagulation therapy. For the first time, it says here, high risk is not the reason for not administering anticoagulants. That's what the changes are. In the right hand corner, again, when it's more than 2 points among men or women, you must start therapy with oral anticoagulants. Again, you can see if it's 1 point, well, you can consider anticoagulants. A final look at the red field. Let's read this together. The high risk should not have an impact on administering oral anticoagulants. Again, these are the changes in has bled this time. Let's look at the major aspects. E means elderly, well, frail, patient. Well, it's important. The patients are getting older. Again, if the patient is an alcoholic or the patient is on binge drinking, this patient has a high risk of bleeding. That is why control of concomitant therapy is also important. Amiodarone increases the concentration of the bigotran by 60%, hence the risk of bleeding, but has no impact on factor 10 inhibitors. Macrolides should not be administered to patients who is on oral anticoagulants. Otherwise, there will be a high concentration in blood and the risk of bleeding. Let's look at other drugs. That's NSAIDs. NSAIDs leads to the increased risk of bleeding, worsens the kidney function. These are the basic things. What should be known to preserve the kidney function? Well, creatinine clearance. Yes, we take into account this factor. Divide this figure by 10, and you'll have the number of months through which you should control the kidneys. The long-term administration of warfarin leads to calcification of small vessels. It's bad for kidneys and the breasts for women, so the elderly patient should be switched off to oral anticoagulants. And we can compare rivaroxaban to warfarin, and rivaroxaban compared to warfarin protects the kidney. It doubles at the level of CPR. It reduces glomerular filtration rate. Yes, it has been proven that rivaroxaban is better than warfarin in treatment of such patients. Rivaroxaban protects kidneys from acute renal failure, so you should weigh 10 times when you have an elderly patient, how the patient takes warfarin. Also ask yourself a question, why don't you elevate the plight of your patient? Factor 10 inhibitor is much better than warfarin in treating such patients. It has already been proven. Also, the reduction of the frequency of the dose of the drug is a serious mistake unless there is a kidney condition. Look at these two yellow arrows. You reduced the dose because you were afraid. Did you reduce the risk of bleeding? No, that's nonsense. Did you change the risk of the stroke development? Unfortunately, you do not have an impact on this parameter. You hurt the patient. And right now, there are strict criteria when you can reduce the dose for rivaroxaban, only creatinine clearance, for apixaban, age more than 80, weight less than 60, creatinine more than 133 micromoles per deciliter, the bigotran, age more than 80, and paraffin intake. The most biggest group of elderly patients was in the Rocket AF, 44% of patients on rivaroxaban. These are the severest patient chats, to almost 4 points, 3.7 points to be more precise. We got this result. Now we need to prevent the development of stroke. If the patient had ischemic stroke, can you resume therapy? Yes, and we call this law 13612. If it's a transitory condition, if it's the light neurological deficiency in 3 days. Well, if it's a moderate neurological deficiency, there is no hemorrhagic stroke in 8 days. The red field, severe neurological deficiency, no hemorrhagic seeping in 2 weeks. But what should we do if hemorrhagic stroke occurs? You have a dichotomy. Either you restore the therapy or you do not do it. Well, let's look at the factors in favor of cancellation of therapy. Look at the dose of the drug when bleeding occurred. If the dose was adequate or reduced, well, do not restore the therapy. If it's a very old patient, if there are multiple foci, that's against the restoration of therapy. But factors in favor of restoration of therapy: traumas, high dose. When you achieved good control, the patient has good control of hypertension, young age, of course, we can restore the therapy here. And these data are not just taken from the ceiling. There is a lot of proof As a result of Rocket AF, 52% of patients on rivaroxaban who had a history of such events. So the same is true of ischemic events in myocardium. Rivaroxaban, in all meta-analysis, has proven the ability to reduce the development of new events. Rivaroxaban also showed the positive impact on peripheral arteries disease. It reduced the number of amputations and revascularizations of low limbs. So an elderly patient is a multifaceted patient, and we need to control comorbid conditions of such patients. Thank you so much for listening to my presentation. Colleagues, Grigori, thank you very much for this interesting presentation. Grigori raised one important question, the use of antibiotics and anticoagulants. That's one of the key issues as far as the COVID-19 pandemic is concerned. Such patients have bacterial complications. They need antibacterial therapy. It's a matter of choice, it's a matter of strategy. And the second global problem Grigori covered is the increasing number of patients with atrial fibrillation. So we have more and more cases of patients with atrial fibrillation and hypertension. They are in our registry. Also, a huge number of patients with rheumatic diseases and heart pathology. We can see that cardiovascular diseases are not gone, but cardiovascular diseases, in fact, have become the foundation for the spread of different complications. Today, it is COVID-19. There might be the violation of cerebral circulation. And in speaking of the scale of cardiovascular pathology, I would like to give the floor to Oksana Drabkina, who is the chief therapist of the Russian Federation. She is a doctor of medical science. She is a correspondent member of the Russian Academy of Sciences. Thanks, Oksana, for coming here. I know that your schedule is very jammed. Oksana, the floor is yours. Distinguished chairperson, esteemed Grigory Pavlovich, dear colleagues, I'd like to welcome all of you whom I can see and whom I cannot see. Thanks for the invitation to speak at this meeting. Let me just say a few words about risk factors and cardiovascular diseases in the Russian Federation. That's the theme of my presentation. I should say that now we have epidemiological monitoring, which is well established in the Russian Federation, and our Institute of Non-Staff Therapists is participating in this monitoring. I'd like to welcome Vadim Mazurov, academician Vadim Mazurov, because we are in charge of our big army of therapists together with Vadim Mazurov. Let me just get down to the theme of my presentation concerning monitoring in our regions. There are 85 regions of Russia. They are the scope of our responsibility, primary care physicians, and Vadim Ivanovich knows that we have interdisciplinary teams which can go on schedule and monitor the situation in the primary healthcare system, as well as the situation with therapists per se. There are lots of therapists, as you can see, and of course, depending on how good the contact with the patient we're going to have, especially when we're talking about the primary care physician, especially when we are talking about other issues, it's very important. So our task is multifaceted. Today's Congress is important so that therapists could have the ability to look for the necessary information. What do we have on this slide? That's our approach. You can see 85 regions. They are divided into four groups. The upper part shows the regions where the mortality rate is higher than in the Russian Federation in general. At the bottom of the slide, the mortality rate in the regions is lower than in the Russian Federation in general. The arrows pointing up and down. Well, let me just make a brief interruption. Sorry.
Уважаемые коллеги, пока Оксана Михайловна подключится через какое-то несколько секунд.
Sorry for this technical glitch. Let me continue. So you can see that we also monitor not at the level of regions, but also at the municipal level. And in a nutshell, I'd like to say that we have our prevention continuum. We pay attention to population prevention, creating specific environmental conditions good for your health, medical prevention, and also dispensary monitoring. As for the topic of my presentation, it boils down to the epidemiological monitoring as a basis of targeted prevention. And colleagues, I will have to go quickly through my presentation because I just got an important phone call, but I will try to cover the most important aspects. What kind of average statistical patient in Russia we have? That's a man or a woman with risk factors. The prevalence rate of these risk factors are shown here. Usually it's hypertension, 44%, obesity, 29%, increased BMI, and here you can see the data of our epidemiological monitoring. You can see the prevalence rate of different factors related to food, for example, you can see people eat a lot of butter here. There is a shortage of fish, and people eat a lot of confectionaries here. Hence, the high level of prevalence rate of obesity among men, and that led to arterial hypertension. Hypertension is not just a male disease, it's also a female disease, and this is an important factor here. No matter what we do, we increased the life expectancy, and by the way, there is a 10-year difference in the um, life expectancy among men and women. You can see different ages, comparison between men and women, and you can see here that the risk factors start to manifest much faster in men, and they start having a negative impact on survival. With women, nothing happens up to 50 years, and only after 50, women start to witness a reduction in the expectation rate, but with men, this happens much earlier. Well, here you can see a prospective study, what impacts male survival. Men are under threat. Risk factors are manifested much earlier and have a negative impact on survival. The level of education plays some role, but a low level of education in men has a negative impact on survival. The income level, it looks like women should be more vulnerable because they earn less. Now it's not like that. Men are more vulnerable, although their income is higher. And look at this slide. That's the situation which is quite typical for our country. You can see that we have more and more men with increased BMI. You can see the samplings for 2013, 2017, and you can see abdominal fat, men with abdominal fat are on the rise. Thank you very much for your attention, colleagues. I will continue to participate in the conference. Dear colleagues, Oksana, thank you for your presentation. Thanks for sharing your time with us. I'd like to emphasize that what you've mentioned today, well, all these risk factors such as increased BMI, the consumption of salt, obesity, hypertension, atherosclerotic damage of the vessels, well, ischemic heart disease, sooner or later will lead to severe cardiovascular pathology, to chronic heart failure. And I should say that we have this particular order in presentations. After the spread of cardiovascular pathology in Russia, we'll be talking about chronic heart failure, because chronic heart failure has a negative impact on the life of patients. So 30% of patients with heart failure are discharged and then hospitalized again. Every third discharged patient will be hospitalized again. 40% can not self-care, and 60%, which is very sad, are people in the condition of clinical depression. They have no motivation for life. They do not want to follow the doctor's recommendations, so we can just treat them in accordance with international guidelines. And it's an honor for me to give the floor to Yuri Lopatin from Volgograd, who is one of the leading world experts in the treatment of heart failure. He is a professor. He has a PhD in medicine. Yuri, the floor is yours. Thank you, Alexander. Well, what Alexander has just said shows the difficulty in management of such patients, but we also have hope. There was hope mentioned today, and not just yesterday, but of course, heart failure is a preventable disease. It is a treatable disease. And in answer to this question, we can say that if we're talking about the treatment of heart failure, the future started today. Dear colleagues, that's a very important problem. It's an important problem for the healthcare system, for patients, and 64 million people have heart failure globally. I can say that maybe the number is even higher, but even if you look at this figure, 64 million people, it's huge. You can look at the map. Well, Russia contributes in terms of 16 million people with heart failure. These are Russian data. And I should say that this problem reflects the serious burden on the healthcare system, and therefore there is a need to find the proper ways of managing such patients. Well, Eugene Brunwald, well, everyone knows him. Eugene has had a strong impact on the development of cardiology over the last 10 years. In 2015, he published a wonderful article in Lancet, The War Against Heart Failure. The Lancet lecture were at the decisive stage in war against heart failure. If you look at the clinical trials 5 years ago, we can see that that was the period of time when the European recommendations on heart failure were made and a lot of trials were conducted. Right now, it's almost the end of 2020. We can see a huge number of trials which were concluded in 2020. Some of them are shown here, and that means we do have a real hope for the future. This is the algorithm of patient management. offered by European experts. These are 2016 guidelines, and you can see the regimens, what happens when we have a patient with the ejection fraction less than 40. Also, you can see AFP inhibitors. Well, then depending on the situation, you can use different devices. In 2016, the experts came up with the algorithm, and it is close to the Russian algorithm. In 2020, there were guidelines approved by the Ministry of Health of the Russian Federation on managing patients with heart failure. And I should say that the work is still on, and in 2020, we are expecting European recommendations. Well, by this time, there was the study completed, Paradigm HF, valsartan, and sacubitril, and this drug was approved for patients with heart failure. Well, and I'd like to draw your attention to several aspects. There is an important factor compared to APF inhibitors. Well, this particular drug reduced the risk of death and hospitalization due to heart failure, and also there was a reduction of risk of death from all causes. That is why this drug gave very good results in the global study, and now valsartan and sacubitril is used for patients with heart failure. In 2020, we also got interesting information which expanded our opportunities. First and foremost, I'd like to pay your attention to the need to initiate therapy with valsartan sacubitril at the hospital stage. Pioneer HF study demonstrated the reduction in the proBNP level. You can see valsartan salmeterol and AFP inhibitors is the blue line. You can see the primary endpoint is lower on this combination. Also, AFP inhibitors, and then the switch over to valsartan salmeterol after 12 weeks, and you can see it is quite feasible to start valsartan sacubitril at the early stage, which is very important. What else was mentioned in proof AF? This drug can remodel the left, reduces the remodeling of left ventricle. You can see in one of the analyses, and this is a proof HF, showed that when the systolic pressure reduces and proBNP is lower, the risk of heart failure is also reduced and quite significantly. So that is why we know that the ejection fraction goes up in this case, and now we can have the reverse remodeling of left ventricle, and in this case we can reduce the number of deaths. Another interesting trial I'd like to draw your attention to, well, that's a PRIME trial. The goal was to see what happens with patients with mitral regurgitation which have left ventricle dysfunction. Colleagues, you encounter such patients all too often. You know how difficult to manage such patients. The authors analyzed what happens with the regurgitation area, orifice, and if valsartan sacubitril, as compared to valsartan, this can reduce the area of the orifice and the volume of regurgitation, which are important characteristics for the good outcome. If we ask ourselves why this happens, you can see the mechanism is shown here. The positive impact is due to the reduction of the diastolic volume, and there are closing forces, and the tethering forces go up, and the area of regurgitation is reduced, hence the pressure on myocardium is reduced, and these are very interesting data. Well, the valvular fibrosis is also being reduced in this case. So what do we have in 2020, dear colleagues? We have an understanding that myocardial dilatation is a marker of the poor prognosis. That is what we know. But as for the progression of remodeling, it is associated with unfavorable clinical outcomes. And we have an instrument that can help us prevent this remodulation. Another important characteristic, colleagues, is our understanding that the assessment of the left ventricle function needs understanding one very important thing. There might be not just three forms like low ejection fraction, intermediate ejection fraction, but it can switch from one category to another. For example, right now, 40-49, well, are patients with the moderate to insignificant reduction of the left ventricle function. That's an important factor, colleagues. In 2020, we now have a clear understanding that not only for patients with the indicator of less than 40%, but also for patients less than 50 or 55%, it makes sense to use beta and blockers, valsartan and sacubitril in such cases. Well, what else is important to understand what we're going to deal with in the near future is first and foremost the emergence of new drugs, which have already shown their efficacy in treatment of patients with heart failure. That means that in the algorithm of managing such patients with HF, there will be other drugs. Let's look at the chronological order, what we already have. Well, that's Periciguan, which improves the endothelial function, leads to vasodilatation. It showed the positive effect in severe patients who were hospitalized for heart failure or who needed intravenous diuretics. The risk of death was reduced, and first of all, due to proper hospitalization, and that means we have another drug that works in patients with severe heart failure. Of course, we are talking about SGLT2 drugs. In 2015, DAPA-HF study was conducted. You can see that the primary aid was reduced by 26%, and that was very important. You can see how the curves depart quickly, and that was a new thing for us because the motivation for this publication by Dr. Eugene Braunwald was the following thing: that was a significant victory in the war against heart failure, and dapagliflozin contributed to this in patients with diabetes mellitus and without it. Well, you can see that the sugar-reducing drug is used to treat patients with cardiovascular disease. Well, as for SGLT inhibitors, they can reduce the number of hospitalizations, but they can also impact other parameters. Everything started with EMPA-REG, with empagliflozin. You can see the number of cardiovascular events reduced. Also, Vertis CV study with empagliflozin, and this gives us food for thought about class-specific effects and the need to use such drugs. The European Congress of Cardiology, which was virtual this year due to specific reasons, showed other positive data. Data with empagliflozin in patients with heart failure, ejection fraction less than 40, and this effect was positive in patients with diabetes mellitus and also in patients without diabetes mellitus. well, you can see the risk was reduced by 25%. We had two studies and a meta-analysis. It's 1A level of evidence. When we look at these two studies, Emperor and DAPR-HF, we can look at differences and the similarities. Well, I can say that these two studies add up because using two drugs, we can cover a wide population of patients with heart failure. Naturally, the analysis of any new trial should be conducted depending on the basic drugs used on these patients. And you can see the analysis conducted. Well, you can see from study to study, the number of such drugs increased. Well, as you can see, Emperor reduced, DAPR-HF, and regardless whether we had SGLT, whether when SGLT2 was administered, people got very good effects. For example, you can see it here, patients who got ARNI, those who did not get, but again, the basic therapy will be important in any case. For any new drug to become a base drug should be part of the recommendations. That's very important. Look at the analysis in May 2020, the results of studies Emphasis HF, these are corticoid receptors, and Paradigm HF and DAPA HF SGLT2. You can see that the combination of these four drugs, ARNI, BB, and SGLT2, showed the best results in terms of longer life expectancy. Dear colleagues, if we start treating patients who are over 55, we can prolong his life by more than 8 years, as you can see it here. If the patient is 65 years old, we can add 6 more years. And now people are talking about the new standard. That's our future, which starts today. Beta blockers, mineralocorticoid receptors, SGL2 inhibitors. And again, it was announced, that's new information, that another study, which is myosin activator, the drug which improves the systolic function of the left ventricle, showed a positive impact on cardiovascular death or events related to heart failure. It was shown that the primary endpoint was achieved. The reduction of risk was 8%, 87% in patients who were hospitalized, NT-proBNP almost 2,000, ejection fraction 27% on good basic therapy. In case of SGLT2 inhibitors and amicabtine, all regulatory bodies such as FDA, European Medicines Agency would like to take a faster track to approve this drug because the results are very positive in patients with heart failure. And we've been waiting for a new class of drugs for many years. That is why, dear colleagues, traditional approach to heart failure has been transformed. Now we can see a different situation. These are APF inhibitors, these ARNI beta blockers, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. So those 6 or 8 years we can give to our patients were achieved on this group of patients. And in Russian recommendations, ARNI is considered not as the additional drug, but as the main drug. And I think that AFP inhibitors' role will be reduced, but these four drugs will play the most important role, including beta blockers, including SGLT2 inhibitors. Thank you very much for your attention. Thank you for this comprehensive presentation indeed. And those who just joined in, I should say that there was an interesting presentation on managing patients with heart failure. The peculiarity of heart failure is that this disease manifests itself too early and it worsens the quality of life, shortens the quality of life, and it requires enormous efforts on the part of cardiologists and family doctors. And of course, right now, I'd like to introduce another presenter related to silent threats. And these are not just infectious diseases. I'm talking about non-communicable diseases. First of all, the problem of atherosclerosis. There will be the presentation of Yana Orlova on this issue, but right now I'd like to give the floor to Igor Nikitin, the treatment of viral hepatitis C. We do have a huge number of patients with viral hepatitis C, but we have changed our attitudes toward treatment. Now we have a better chance to eliminate the virus and to improve the prognosis. Igor, the floor is yours. Thank you very much, Alexander. Distinguished colleagues, I'd like to thank you for the invitation. The format of this webinar is significant. When I looked at the broadcast, I thought I was watching channel 1 or channel 2 of the Russian television. Everything is very well organized. I'm glad to see all of you. Well, even in this format, Vadim Mazarov started his presentation by outlining this important vector of interaction of specialists in different fields, bringing to bear comorbid conditions of our patients. We can see now that patients have started living longer, their life expectancy is on the rise, and what the Ministry of Health does, as well as departments of health in Russian regions, everything is aimed at achieving the national development goals, including healthcare goals such as increasing the life expectancy. And of course, that means we need to change our attitude toward the management of our patients. The doctor should change his behavior. And of course, well, chronic hepatitis C is of paramount importance. Right now, we have about 70 million people infected with chronic hepatitis C globally. How important is this problem for the Russian Federation? Russia is one of the countries which contribute a lot to the prevalence rate of virus hepatitis C because, as you know, viral hepatitis C can lead to liver cirrhosis and hepatocellular carcinoma, which would mean a bigger burden on the health care and the need to use specific drugs. The prevalence rate of chronic hepatitis C is not equal, but there are countries with a huge prevalence which require specific response of the healthcare systems. In the Russian Federation, well, the cure rate is rather high because we use modern drugs, modern antiviral drugs, such as drugs which do not require polymorphism detection like interleukin gene 28 as a predictor of the outcome of treatment of chronic viral hepatitis. These drugs do not require the determination of viral load. They do not require the determination of genotype. Well, you can use a fixed combination, well, one pill per day, and there are no side effects, at least the manifested side effects. It looks like the situation is very simple, but as we extrapolate this problem to the problem of comorbidity or patient's age, we understand that right now the most important thing is compliance to treatment, comorbid conditions, and drug-drug interactions. So we should pay attention to the main drugs used for treatment of this disease today. Chronic hepatitis C is more widespread in specific age groups, as well as with specific diseases such as chronic hepatitis C in Spain study. Well, hepatitis C is more widespread in patients with cardiovascular diseases, with dyslipidemia, obesity, and diabetes mellitus, as you can see it here, as well as depression in 24% of cases. Can we administer antiviral therapy in this population? Today, several studies have been published. REVEAL is one of them, showing that viral hepatitis C increases the risk of death from somatic diseases, in particular chronic renal diseases, cardiovascular diseases, diabetes, neoplasms, and other reasons. You can see the average age of our patients with chronic viral hepatitis C who first present to the doctor, and the age increased. Now we have more patients at the age from 50 and above. Viral hepatitis C today is associated with an increase in the number of somatic diseases. Here you can see patients, and these are data which were published way back in 2012, and comorbid conditions here are 31 diseases. And well, that's a bit strange. Sometimes patients who were treated in foreign clinics plus arterial hypertension, abscess of the right buttock. Well, sometimes this is considered to be a separate diagnosis, and but these are separate diseases. I was surprised that our Western colleagues did not put it all together. 31 clinical diagnoses, concomitant diagnosis, and I think that some of these diseases are not very widespread, but they are included into the medical documentation. I am an internist, and sometimes it's difficult for me to see that one person can have 31 concomitant diseases, but nevertheless, our Western colleagues show that there might be patients who can have 31 concomitant diseases with chronic viral hepatitis. Well, VHC increases the risk of terminal kidney disease, and of course, the survival of the transplant, chronic hepatitis C, the cumulative 5-year rate of the development of this pathology with viral hepatitis C is much higher as compared to patients without this kind of infection. Another interesting study showed the impact of concomitant diseases and background therapy on survival and the expenditures of the system of health in patients with the VHC. Charlson Comorbidity Index, if it is higher, then the healthcare system must invest more resources in the treatment of chronic hepatitis C. So, what can we say about the current situation right now? Together with chronic viral hepatitis C, we'll have to treat several other diseases which should not be delayed. While in some cases we can just adjust the doses or use the less aggressive therapy, but in most cases the treatment should start right away. The number of drugs administered to patients with viral hepatitis C has increased and quite significantly of late, hence the higher risk of potential drug-drug interaction with the main therapy using antiviral drugs. And you can see that almost 62% of patients aged 70 and above, and when we make a decision to treat hepatitis C by using antiviral drugs, have the highest risk of drug-drug interactions. Well, as for polypharmacy, it is an important question because we have to combine different drugs due to different diseases, and you can see a table and the class of drugs such as PI inhibitors, selective beta blockers, aldosterone antagonists, antagonists of angiotensin 2, and so on and so forth. Also, the narrow therapeutic index drugs and GIs, and you can see that NTI drugs can lead to the failure of the treatment of the main disease due to the adverse events. That is why the combination of these drugs with antiviral drugs to treat hepatitis C requires a very cautious approach, very weighted approach, because most patients like that are in the risk group of significant drug-drug interactions. Most patients with chronic viral hepatitis C who are on this wonderful therapy with fixed dose combinations, well, like the same is used to treat HIV infection. Even the pill becomes small by size, and it's very convenient in terms of take in, but nevertheless, you should be very cautious here, especially when we're talking about patients that can take statins, PI inhibitors, antistatins, beta-2 agonists, adrenal receptors, and additional alternative drugs. Here, there is a need of an individual decision on each case, what particular therapy should be administered here together with antiviral drugs to treat chronic viral hepatitis C. You can see the registered combinations of these drugs with direct antiviral activity. You can see different drugs here, RNA dependable polymerase, SOF, SIM, DCV, PTV, OBV, LDV, VEL, EBR, which is very widespread in the Russian Federation. And you can see that not all combinations have the same profile of drug-drug interactions. And of course, in this case, I should say that Elbasvir EBR with Grazoprevir is the most widespread with the inhibitor of serine protease and RNA-dependable polymerase. The risk of development of clinically important drug-drug interactions in percentage is shown here. It is different depending on the combination. The lowest probability of drug-drug interactions is when hepatitis C is treated with comorbid conditions on EBR and Grazoprevir. Well, I should say that drug interaction risk in patients with chronic hepatitis C showed even some contraindicators for treatment of chronic hepatitis C with this group of drugs. Sometimes this percentage, although it's not high, but it can be 3.5%. These are important essential drugs shown here, like statins and also other essential drugs. 96, 97% well is the efficacy of treatment, and I'd like to refer you to this link. That's Liverpool, University of Liverpool data, and the University of Liverpool updates all the data related to drug-drug interaction risks on patients that get therapy to treat comorbid conditions. You can see the major indices depending on the drugs. You can see a huge number of specialists are interested in drug-drug interactions in patients who are on therapy using antiviral drugs. And I think soon maybe it will be an automated resource, or there will be a table like this that will define possible drug combinations, possible or impossible, or the ones acquiring adjustment. And these are EASL recommendations and EASL guidelines. I'd like to draw your attention to study risks of drug-drug interactions in patients with the high risk of comorbidity when antiviral drugs are to be administered. Just in a nutshell, I know that my time is up, but to make specific conclusions, chronic hepatitis C is the disease requiring an individual approach to the patient. It's the disease when the issues of comorbidity and polypharmacy are becoming very important. These are patients who have a high risk of drug-drug interaction. Different regimens of antiviral treatment can be used, hence a different drug-drug interaction, and drug-drug interaction is one of the major factors determining the management of patients and the selection of the right antiviral drug. Thank you so much. Thank you, dear colleagues. Igor, thank you for your interesting presentation. I should say that was the presentation devoted to viral hepatitis C. What is the state of the problem? What are the opportunities of internal medicine? Let's continue, and in talking about the silent threats such as hepatitis C, let's talk about non-infectious silent threats. And of course, any practitioner would agree atherosclerosis is a serious problem. It's a global problem. It's a problem requiring special consideration because people present too late. The tactic and strategy of the use of hypolipidemic drugs will be covered by Yana Orlova. Yana, the floor is yours. Thank you very much, Alexander. Well, today I'm going to talk about ischemic heart disease, the residual risk treatment. This is the conflict of my interest. Ischemic heart disease is a serious problem for the Russian Federation. We have more than 4.6 million people in Russia suffering from coronary heart disease. You can see the mortality rate is rather high as compared to other countries. But even in those countries where the situation is more favorable as compared to the Russian Federation, in recent years, the absolute number of deaths from heart and heart failure in particular, and ischemic heart disease, first and foremost, has increased. You can see that this is, first of all, due to the fact that there are more patients who suffer from ischemic heart disease at the older age. Dear colleagues, even in those populations where we can treat the patients with all the existing recommendations, administering aspirin, statins in the necessary dosage, the residual risk is quite significant, despite the fact that statins and aspirin was a colossal breakthrough in improving the prognosis of patients with ischemic heart disease. But nevertheless, we understand that this is not enough. How can we help our patients? We put a lot of hope on the invasive strategy. There were studies which didn't give us positive results, but left hope that the invasive strategy in proper selection of patients can improve the outcome. Unfortunately, the last well, how would I say it better? The ischemia trial ruined all our hopes as far as the invasive strategy is concerned. It was designed bringing to bear all the mistakes made in the previous trials. People with stable ischemic heart disease and the proven myocardial ischemia were included here, but the invasive strategy did not have advantages over medical therapy in terms of non-focal myocardial infarction and other endpoints. Maybe the change in the lifestyle can change the situation here. There is a lot of proof saying that changing the behavioral factors can significantly reduce the probability of development of cardiovascular complications in patients with ischemic heart disease. But unfortunately, population studies have shown that not more than 1% of patients can change their lifestyle and make it healthy according to the guidelines. That is why most experts consider the main factors allowing us to risk the residual risk with ischemic heart disease is impacting lipids, coagulation, and chronic inflammation. The topic of chronic inflammation is important, and it has been discussed for 3 centuries in a row. And several years ago, it got clinical proof. The CANTOS trial, when canakinumab was used, that's interleukin-1 beta inhibitor, which blocks interleukin-6 cascade of inflammation. Well, and it reduced the risk of development of cardiovascular complications in patients with atherosclerosis, but it was not registered accepted by FDA due to the poor ratio of cost efficacy. And you can see that a new drug appeared, colchicine. Last year, the study ended. The colchicine improves the survival rate of patients with myocardial infarction. This year, the European Congress the data were presented showing that colchicine in the dose of 0.5 milligrams per day in patients with stable coronary heart disease reduced the primary endpoint of the risk of development of cardiovascular diseases by 30%. What about patients in real clinical practice who need these additional efforts? For patients with significant residual risk, according to randomized clinical trials, about 60% of patients do not reach the low-density lipoproteins levels, or C-reactive protein is less than 2 milligrams per liter, as you can see it here. But real clinical data show even poorer picture. Only 14% of patients with ischemic heart disease do not have a residual risk. All resources aimed at reducing the risk, like lipid profile, the level of inflammation, have already been used, and 85% need new approaches. Well, last year, ESC guidelines were published several months ago. Well, there were recommendations on the ischemic heart disease approved by the Ministry of Health of the Russian Federation. And colleagues, how can we help our patients with ischemic heart disease based on the existing guidelines? Some significant progress has been made in terms of reduction of the risk of thrombosis. The European guidelines suggest that we administer the second antithrombotic drug on top of aspirin, or maybe some other combination can be used of these antithrombotic drugs if the risk of the development of thrombosis is very high and there are multi-vessel disease. Also, as for risks related to inflammation, the results are not quite good here. Canakinumab will probably won't be approved and won't be written into the guidelines. So colchicine is still at the stage of studying. It's not part of the guidelines. Well, maybe there might be some impact on the lipid spectrum, and here some capabilities can be expanded if we cannot reach the target level of low-density lipoproteins. When we administer statins, so we can use the drugs shown here, such as the inhibitors. But I think that I would like to draw attention to underused conditions such as omega-3 polyunsaturated fatty acids. Well, some time ago, we were scared by the negative results of the combination of hemofibradil and that the fibrate existed on the market together with statins. The risk of myopathy increased, and this was due to the fact that hemofibrazil inhibits, or rather, I would say, changes of the metabolism and pharmacokinetics of statins. Now we have no drug like that on the market. We have only fenofibrate, which showed that it was neutral in terms of the statin kinetics. In some studies, it showed its high safety in combination with statins. Fenofibrates and statins as a combination led to the improvement, such as the reduction of triglyceride levels, but also the entire lipid spectrum. And more patients who want combination of fenofibrate plus statin had not just triglyceride reduced, but also reached the targeted level of low-density lipoproteins. So right now, there is a consensus document, the European document, also supported by Russian experts about hypolipidemic drugs for patients with mixed dyslipidemia. Well, of course, if there are no contraindications, statins should be administered if the target level of low-density lipoproteins is not achieved. Maybe we should change statins, add the dasatinib, maybe add new drugs if PCSK9, for example, inhibitor can be added. And in this case, we can think about administering omega-3 polyunsaturated fatty acids. At the European Congress, there were the results of 141,000 patients with diabetes mellitus, follow-up 5.5 years. So the survival rate was much better when fenofibrate or omega-3 polyunsaturated fatty acids were added to the main therapy. And I should say that as for omega-3 fatty acids, this is the REDUCE IT study, which was finished in 2018. 8,000 patients with the high risk, the administration of 4 grams of EPA reduced cardiovascular events. And colleagues, I'd like to say that the cardiovascular death dropped by 20% as compared to placebo, and the reduction in death did not directly correlate to the level of triglycerides. This fact led to different discussions. What are the modes of actions when omega-3 polyunsaturated acids can have a positive impact on the reduction of death in patients with high and very high risk? We know that there have been several studies conducted showing that omega-3 fatty acids have an impact not on the lipid spectrum, not on the level of anti-glycerides, but also have anti-thrombotic effect and reduce the level of chronic inflammation. Last year at the European Congress of Cardiologists, when people met person to person, there were heated debates devoted to this subject, how omega-3 reduce the risk of cardiovascular complications in patients with ischemic heart disease, especially high-risk patients. The European experts came to the conclusion that 1/3 of the success is due to the lipid effects of omega-3, 1/3 to antithrombotic effect, 1/6 effect of the reduction of the arterial pressure, and the rest due to anti-arrhythmic effects and anti-inflammatory effects. Well, I'm not going to comment on the opinion of European experts. So let me just show you this table. When REDUCE IT came to an end, the level of triglycerides in the group on omega-3 was lower as compared to placebo, but only lower by 14%. Low-density lipoproteins, there was a difference between the groups, but you can see the difference is by 7%, and you can see high sensitive CRP was lower by almost 37%. Well, colleagues, at the last European Congress, the evaporate-4 data were presented, and I think this is probably so because arteriosclerotic plaques can be evaporated here. 4 grams of EPA over an 18 months reduced the number of plugs. Well, colleagues, polyunsaturated efforts in fenofibrate are included in all guidelines. It can be administered when triglycerides is more than 2 or 3 millimoles per liter, depending on the risk, high or low. Omega-3 polyunsaturated acids can be administered to high-risk patients when triglycerides are more than 1.5 millimoles per liter. Colleagues, right now there are still discussions about whether EPA can be used for this, or maybe a combination of EPA plus DHA can be used, which we used in some other studies, or maybe the dose of 4 grams per day or 2 grams per day of EPA plus DHA can be also effective. For right now, there are 3 major randomized trials. 2 will come to an end of this year, and I assume that soon we'll have a definitive answer to this question, or at least that the situation will be more clarified. But right now, I'd like to draw your attention to AHA Science Advisory published last year, which says that using 4 grams of any of the existing forms of omega-3 polyunsaturated fatty acid is an effective treatment and can be safely used with statins. And of course, there are a lot of supplements on the market containing a lower dosage of omega-3, not very standardized. Well, like this happens with over-the-counter drugs or supplements. So if you make a decision to administer omega-3 polyunsaturated fatty acids, I'm sure we should use only prescription drugs. In Russia, we do have such presentations, hopefully, but it's only one. That's omega-3 polyunsaturated fatty acid in the form of ethyls, and this Amacor drug, which we use all too often. That's all I wanted to say, dear colleagues. Thank you so much for your kind attention. Well, dear colleagues, let's continue. I should say that we got a huge number of questions for all the presenters. And in fact, the conference is organized in such a way that there is a presentation at the plenary session, and there will be the workshop, and there will be the Q&A time reserved, and there will be also time reserved for questions and answers with all the speakers. Right now, let's move on according to the schedule. Now, there will be the discussion called pro and contra, pro versus contra, 2 different opinions. Whether people will come to terms or not, we do not know, but this discussion will raise important questions of treatment of patients with comorbidities. Then 2 more platforms will start working, St. Petersburg and Perm. You can join either those platforms or stay here. Everything goes online. This broadcast is being done in 3 cities, and then we'll get together again, and then there will be 7 people from different countries, and they will cover such questions as what COVID-19 has done with medicine, what are the expectations of a practicing physician, how the healthcare system is going to change. Right now, I'd like to invite 2 persons, Grigory Aramovich. Grigory Aramovich will be talking about the management of patients in terms of modifying the lifestyle. The discussion sounds as follows: what to do for a patient with excessive BMI, with comorbidities, change the lifestyle, started taking drugs, what to do? Well, can you say, yes, you should change your lifestyle? The patient will do it. It will be an interesting discussion. So, Grigory Aramovich, please, the floor is yours. Thank you, Alexander. Good afternoon, distinguished colleagues. Pro versus contra. Well, changing a lifestyle and I'll be talking about this issue. We'll be discussing the medical treatment. I would like to thank you for joining in. I'd like to thank the organizers of the Eurasian Association of Therapists, and I'd like to thank my opponent, Mr. Galstyan, who will be speaking after this. He was my first teacher, by the way, and today I am his discussant, his opponent, and this topic is very relevant. Well, I should say that the prevalence rate of prediabetes is very high. Well, the nation study showed that in Russia we have more than 20 million patients with prediabetes, and globally this figure exceeds 352 million people. As compared to diabetes, we have 463,000 patients. We forget about prediabetes, and it's very important to raise this subject. The problem is not just the high prevalence rate, but the problem is we don't have a unified consensus on how to diagnose this problem. In Russia, we have the Association of Endocrinologists. They recommend we make a diagnosis on the OGTT when it's 7 to 11, the indicator is 7 to 11, when the tolerance to glucose is violated. Well, in the United States, the American Association of Diabetes indicates that the diagnosis is based on the oral glucose test and on the basis of glycated hemoglobin 5.7, 6.4, and on the basis of OGTT. So as you can see, the criteria are different in terms of making a diagnosis. If we used the oral glucose test, well, the number of patients would be much higher. And nevertheless, you can see glycated hemoglobin when it's up to 6.4. We should be very cautious about such patients, since this problem is very interesting, and a lot of trials were conducted in Finland, in Japan, but I would like to concentrate on the DPP study, well, to prevent diabetes mellitus and the DPP-OF. The point of the study was to divide patients into 3 groups. The first group was on metformin, the second group on placebo, and the third group changed the lifestyle, and as a result of it, after 3 years, we got the following results, where the lifestyle change, conversion from prediabetes to diabetes, occurred in 58% of cases. And that's a very interesting result. And in metformin, it was only 31% of cases, and we looked what happened next. We prolonged the study for 12 years. The results of a 15-year study were not quite interesting. And in the group where lifestyle changed, it was 27%. In metformin group, the indicator was even lower. So the results of this study show that in the long-term perspective, we should have a clear understanding that patients who change their lifestyle, well, cannot follow these recommendations for a long time, but nevertheless, well, when they quit smoking, alcohol, when they reduce weight, which is also important, increase the physical activity by more than 150 minutes per week, all these recommendations lead to improving the quality of life of our patients. Can we extrapolate these results of DPP-OS on our patients? I would say probably no, because DPP-OS study was designed in such a way that patients within the first half a year, patients where the lifestyle was changed, they met with dietologists, physical activity specialists, psychologists, and during the entire month, they were accompanied by specialists who helped to maintain motivation, to keep the weight, who helped them keep the obtained results. Is it possible in our conditions? Probably no. That's the ideal condition in the trial of DPP-OS. It's impossible to reproduce such conditions in real life. So despite the concept of pro versus contra, I should say that, well, I should not be just pro changing lifestyle, or I should not be just a pro or contra metformin, but a combination of these forms can reduce the risk of diabetes. We can achieve some synergy, we can get some better results when the patient can change the lifestyle, and we can add metformin to a changed lifestyle, and together we'll have a better result. Let's look at a different point of view. I'd like to give the floor to Guy Kradevich, and he will express his view whether metformin should be given to such patients or not. And at the end, we'll have 2 minutes for discussion, and maybe we'll be able to come to some consensus. Guy Kradevich, the floor is yours. Well, good afternoon. It's also a pleasure to be your opponent, and I'd like to say that, of course, I agree with many items you raised. First of all, I should say, and I agree with you, that this problem is very relevant. Well, everyone will agree with you that the number of people today with pre-diabetes is quite large. According to the Nation trial, it's 19%. Well, anyway, I'd like also to make a caveat by saying that the diagnostic criteria are also of paramount importance, and later I will tell you which patients should be candidates for pharmacotherapy for drugs. So any epidemiological study, the study you've mentioned, DPP-OS and DPP, well, should be considered not just from the point of view of patients included, but also the results obtained. And in my clinical practice, I usually recommend patients with pre-diabetes follow the path which has already been tested. What I mean here is that that's the path when we can reduce the probability of a mistake, the probability of an error. First of all, find a risk questionnaire should be filled in by a patient. Find risk will determine the probability of diabetes development. It's a very simple calculator. Well, you can do it on a cell phone, on an iPad. You can just download this questionnaire, 11 questions, so you can get a specific point. If it's more than 15, close to 20, the probability of the development of diabetes is 33%. It's intermediate risk within the next 10 years. If it's more than 20%, that means more than 50% in the next 10 years. So that's a totally different story. In this case, I would recommend either glucose tolerant test, if it's possible, or I would recommend at least the measurement of fasting glucose or glycated hemoglobin. And here we can have different diagnostic criteria. In the US, they consider this group with prediabetes widely from 5.6 to 6.4. If we're talking about glycated hemoglobin 5.7 to 6.4, well, you can see that's a very wide range, and within this range, there might be different options when the level of glycemia is closer to diabetic 6.0 to 6.9. In this case, the development of diabetes is more than 80%. And of course, these patients will be different from those who have lesser HbA1c levels. So again, this particular questionnaire or measuring fasting glucose and HbA1c allows us to identify the cohort of people with prediabetes when the probability of development of diabetes can be higher. For these patients, preemptive actions are important. Preemptive actions not only in terms of changing a lifestyle, and you made the conclusion that in real clinical practice, we cannot achieve the results as for DPP study. Well, patients dropped weight, and due to this drop in weight, this success was achieved. Well, in real clinical practice, it would be much harder to do. Well, I doubt our patients would follow all these recommendations, and of course, medical therapy can be of great importance. And right now, we have a fantastic drug which has been on the market for more than 50 years, such as metformin. And right now, there are presentations which can minimize GI adverse events. Well, I am talking about depot metformin. Metformin is not very expensive, and here I'd like to draw an analogy. Well, we can say about anti-hypertension drugs or anti-lipidemic therapy. Anti-lipidemic therapy, as soon as you cancel the drug, you will go back to square one. And here, I would say that metformin allows us to minimize the onset of the development of diabetes, because I should say that the diagnosis of diabetes is made when diabetes exists for 3 to 8 years. There might be macro and microvascular complications by this time. So the delay in the development of the disease and the use of metformin, in this case, in terms of prediabetes, is very important, especially in young patients from 50 to 55 years. Just imagine diabetes developed at 55 or at 65. That's a totally different story. If you manage to delay the development of diabetes mellitus type 2 by 10 years, well, this is worth a lot. You can gain a lot of advantages here because you won't have to treat diabetes for 10 years. That's my stand. And there should be a personalized approach, and drug therapy is more justifiable in this case. Thank you so much. Well, it looks like we have the same view. One cannot work without the other. Well, there should be a combination of actions. Change in the lifestyle, the drug therapy should be rationalized, and the approach of the Russian Association of Endocrinology is more closer to me, 5.5, 5.6, are not associated with such high risk as cardiovascular complications and the conversion from pre-diabetes to diabetes. That is why I think it is more rational to use the existing guidelines to change the lifestyle. And I invite you to the St. Petersburg room where we'll be talking about the change in the lifestyle. I'll be talking about changing the lifestyle and recommendations on nutrition for patients with diabetes. And basically, they are the same as for patients with pre-diabetes. I'd like to thank you for this opportunity to participate in our session. Thank you very much. Maybe I would like to say a few concluding words. Yes, thank you so much. I am not against changing the lifestyle. I am for it with both my hands. And it's nice that you are going to talk about the proper nutrition. That's very important for all of us. That is why here our position is absolutely the same. I am glad that we reached consensus. Thank you so much. Thank you. Well, dear colleagues, thank you so much. Well, your discussion was not quite aggressive. You reached consensus. That's what discussions are all about. Well, truth comes out in an argument. And as for this argument, well, we can say that we'll have a further discussion, and right now we have two endocrinologists here. I'd like to ask some questions, and there are lots of questions. Here is a question that well, we need our opponent on the screen because this is a question for both endocrinologists. Well, several questions, a lot of questions about triglyceride level. What should be done? What should be the dose of omega-3 fatty acids? Or maybe a different therapy should be administered here. If we look at different studies, omega-3 fatty acids 2 to 3 grams per day. That was a high dose, and many refer to the Japanese study where the dose of 8 grams was used, but this is a very high dose for European patients. Well, many people may not tolerate it. They might have diarrhea. So since our endocrinologists are here, well, what's your take on that? Triglycerides, are they really dangerous for such patients? Well, triglycerides, of course, are important, but in speaking of diabetes mellitus, well, can you hear me? Yes, you are on there. In speaking of diabetes mellitus, triglyceride and glycemia are related. So in endocrinology, before we administer drugs which may have an impact on triglyceride level, try to improve glycemic control. Improvement of glycemic control allows us to significantly improve the level of triglycerides, and then statins will be administered. Well, first line statins, and I should say, frankly speaking, I do not recommend the fibrates to our patients, only to those patients who have high triglyceride levels and have additional cardiovascular risks. In this case, there might be a combination of triglycerides plus statins. As for omega-3 fatty acids, yes, recently we've accumulated more and more evidence, but again, we should use a personalized approach. We should take into account additional factors, and as I have already mentioned, if there is a decompensation, if HbA1c is high, well, our actions to improve the situation with the triglycerides cannot be effective. Glycemic control should be restored, and then we can add well, statins to control lipids. So that's my stand. Thank you very much for your time. And before we get down to the next symposium, Grigory, you also wanted to say something. I subscribe to the point of view of Gary Karadovich. We should normalize the glycemia first and foremost.
Конкретного пациента, и если с помощью статинов нам не удается достигнуть целевого уровня триглицеридов, меньше 2,3 в данном случае мы будем рассматривать, больше 2,3 как нецелевой, в этом случае мы можем присоединять, либо это препараты будут действительно омега-3 кислоты, либо это будут препараты фенфибраты по мере необходимости у каждого конкретного пациента. Это действительно оправдано, особенно у пациентов с сахарным диабетом.
И спасибо большое, Григорий Арамович. Огромное спасибо за ваше время. И прежде чем мы резюмируем и перейдем к следующему симпозиуму, потому что у нас начинается распределение по залам и начинаются другие симпозиумы, я бы хотел сказать, что на примерно 30-40 вопросов, которые поступили, можно ответить так. Просто диетой снизить уже высокие значения дислепидемии маловероятно. Статин всегда является первым препаратом, который должен быть назначен таким больным. И на самом деле для тех, кто подключился позже, я вкратце скажу о том, что нас ждет в дальнейшем, какая программа. Сейчас начинается активная работа в 3 залах. Это зал Москва, который вы видите на экране. Это зал Санкт-Петербург и зал Пермь. Во всех 3 городах есть ведущие. В Перми это Наталья Андреевна Козиолова, профессор, доктор медицинских наук, эксперт в области кардиологии и терапии. В зале Санкт-Петербург это Владимир Владимирович Саухов. Это один из ведущих экспертов в области эндокринологии. И, соответственно, в каждом из залов будут идти симпозиумы. Я останусь модерировать в этом зале, но, ознакомившись с программой, возможно, вы захотите перейти в зал Санкт-Петербург, то есть я уверен, что вы захотите, или в зал Пермь, потому что это не
agenda, you might choose to go to some other halls, for example, to Perm or others. Please go through the program. No matter in which hall you are, you will still get your scores. So please choose the hall for your further presence. And it is my great pleasure to give the floor to the next speakers. We'll have now here in this Moscow hall a symposium dedicated to the practical advice from cardiologist to a neurologist and the choice of new anticoagulant for atrial fibrillation patients. There will be a discussion of a therapist, cardiologist, and a neurologist. We'll take an, let's say, multilateral look at the patient from the real clinical practice. This is a very important topic. In fact, anticoagulants and atrial fibrillation are broadly discussed at the moment, especially given COVID. We think what to do. And in fact, we're working with the whole range. Today we have heard that as diagnosis is getting better, we diagnose more and more patients of this kind, and in the coming years we'll have waves of atrial fibrillation patients, just waves of them, and we will have to assess the patients from the perspective of modified or non-modified hemorrhages, choose the tactics and strategy of treatment, and we will be in permanent search of choice. So this symposium will satisfy your answers. We're ready to give the floor for the participants of the symposium. And the first speaker is Tatiana Adasheva. Tatiana Adasheva is a professor, doctor of medicine, one of the experts in internal medicine, therapy, and cardiology. The floor is yours. Thank you very much. Alexander Grigorievich, thank you for your kind introduction. Let's on this very complicated topic, the problem of managing a patient with atrial fibrillation. I'd like to show you the updated European guidelines on atrial fibrillation. This year, there was the first digital experience of the ESC digitally. It was a successful event indeed. And the guidelines were adopted. Of course, the main guidelines, the most important ones that are quoted and actively researched are the ones on atrial fibrillation. So what has changed? No revolution happened, no outlining of some updated or radical changes of therapeutic and diagnostic strategies. This is not a revolution. This is simply an evolution of our notions on atrial fibrillation management. And I'd like to give you the highlights of it, and then we'll speak about the choice of anticoagulants. So, prevalence of atrial fibrillation globally is over 43.6 million patients worldwide. European experts calculated that in the European population, the risk of developing atrial fibrillation is in one person out of three after the age of 55. For that particular reason, the focus on in the updated guidelines is on the early diagnosis of atrial fibrillation. There have been presented different methods of diagnostics for atrial fibrillation, their sensitivity and specificity, like automated monitors for arterial pressure, classic multi-channel ECG, smartphones, watches, different other devices, and the asymptomatic or little symptomatic atrial fibrillation is a very dangerous condition. For that reason, we need to actively detect atrial fibrillation. Asymptomatic fibrillation is often encountered in clinical practice, up to 40% of cases. It is associated with elderly age, high comorbidity, etc., and mortality in asymptomatic cases is higher. Another research describing a symptomatic debut of atrial fibrillation. Asymptomatic AF brings to a higher risk of stroke, cardiovascular death, and overall mortality rate 3 times higher. So early detection, early diagnostics, and early therapeutic strategies deployed must be there. So to confirm fibrillation, again, the golden standard is we can suspect her by using different systems or devices, but we confirm that 12-channel ECG is a golden standard, and unregular sinus rhythm during 30 seconds and above are the prerequisites for diagnosis. After that, we need to describe the patient with atrial fibrillation and classify. It's a principle of 4S. We need to assess the stroke risk, and we'll talk about it. We need to assess the gravity of symptoms to define if it's the severe symptoms, mild symptoms, etc. The quality of life questionnaires are helpful here to assess the burden of this disease, the length of episode, severity, and the duration of these episodes during 24 hours. Is there a spontaneous rhythm restoration? What therapeutic strategies were deployed? All this should be analyzed. And the last S is comorbidity, when we need to assess the factors of cardiovascular risk and comorbidity to visualize the atrial loss and the core causes of atrial fibrillation. This is the scale suggested by the European experts. Then from detection and description of atrial fibrillation, we go to the management, and where we have ABC strategy in place. Why did the experts do so? This ABC strategy was proposed by Gregory Lipp to simplify the approach. It's a pragmatic and yet an integrated approach. We need to go through this algorithm and consider everything: anticoagulation, symptoms, comorbidities, factors of cardiovascular risk. Anticoagulants are number one, and administering anticoagulants We'll speak about it later. Let's talk about control of symptoms first. What do we need to assess? Quality of life and preferences of the patient. What do we want to control? Rhythm or frequency of cardiovascular contractions. These are the former recommendations, guidelines of 2016. Back then, we were saying that our strategy on rhythm control, whether it's ablation or antiarrhythmic therapy, they don't influence the mortality rate of cardiovascular diseases. They can only reduce the risk of hospitalization. Remember, wonderful AFFIRM study, which said that it doesn't really make a difference among elderly patients. We choose whatever prolongs their life. What has changed? Have been changed. These guidelines were published after. This study was published after the guidelines. Debut of AF. First group are the patients that got antiarrhythmics, etc., routine ablation, and the second group was just monitored. The active monitoring group, antiarrhythmics, ablation, etc., and in routine control group, we didn't have these drugs, we didn't use these therapeutic strategies. So what was the result? The curves of the primary endpoints went apart. In average, the reduction of risk in the group of early intensive rhythm control went down by more than 20%. This is the primary endpoint, cardiovascular death, hospitalization, etc., because of OSC and heart failure. The same was in radio RF ablation. Yes, in the beginning, there was a research showing that using RF ablation in comparison with antiarrhythmic therapy gives an improvement of life and mitigates the symptoms. But the next researches showed that the primary endpoints of cardiovascular hospitalization also differ statistically in the group of catheter ablation as compared with antiarrhythmic therapy. And the last study in a very specific clinical group, symptoms of heart failure and fibrillation. Here we see a significant reduction of primary endpoints and all the cases of worsening in cardiovascular group are in ablation group as compared with antiarrhythmic therapy. This enabled us to change slightly our ideas about the role and place of ablation in the management of AF patients. What are the indications for lengthy therapy and rhythm control? They remain the same. Choice of drug is the same. If there are morphological changes, we use only the third class of antiarrhythmics. Minimal structural changes. In here, we may use the first group product, comorbidity. What do we do with comorbidity? How do we evaluate the cardiovascular factors? This is the natural story of the debut and progression of AF. Risk factors, different triggers, first episode, then paroxysmal, etc. And it is accompanied with morphological changes of atria. These are all the risks, modified or non-modified. We need to work with all the possible modified and non-modified risk factors. One of the studies dedicated to how to manage the patient with AF, dated to 2018, it was presented at the Congress back then. So there was an AF patient. This group was managed intensively, and the second one was just routinely observed. Intense treatment is statins, rehabilitation strategies, etc. And in a year, a 7-day Holter, and then they compared the results. In intense treatment group, the antagonisms of mineralocorticoid receptors were used much more frequently as compared with statins, and the number of drugs blocking went up. So in a year, the 7-day Holter in intense control group and upstream therapy shows that patients preserved their sinus rhythm in 12% more of cases. And this was simply by managing the patient in a correct way. For that particular reason, the guidelines on modifying the lifestyle and correcting the factors in modern guidelines sound like this. We are correlating all the factors of risk and concomitant diseases, modification of unhealthy lifestyle, and reaching the target level of arterial pressure. Otherwise, we won't be able to control the patient. We reduce the weight and control other metabolistic factors. We administer therapy and we consult on saying no to alcohol, cardiorespiratory fitness, no intense physical loads, treatment of apnoea, obstructive apnoea, this way, so on and so forth. Then we have anticoagulants, reduction of stroke incidence. Any changes here that prolong life and reduce the number of cardiovascular events, especially cardiobolic stroke in AF patients? What do? We identify the low-risk patients who do not need anticoagulants. We calculate the Hasbled CHA2DS2-VASc scores. We assess the bleeding, hemorrhage risk, and we choose the drug. Everything is the same, but the European experts are paying attention to the patients of low risk who are not going for anticoagulant therapy. In 3-4 months, we need to reclassify the risks because the patients are not getting younger. They have debut of diabetes, arterial hypertension, and in 3-4 months, they might have this one factor in CHA2DS2-VASc score that will make us administer anticoagulants. The scale hasn't changed much. They included here cardiomyopathy. They specify that it's first and second type diabetes. Coronary heart disease should be angiographically proven, but the score itself is the same. This table hasn't undergone big changes, although something has been added. Hasbled is calculated, and if the hemorrhage risk in a patient is high, it doesn't mean that we won't administer anticoagulants. We consider the modified risk factors and we monitor the patient closely, and the high risk of hemorrhage shouldn't be used as a reason of not administering oral anticoagulants. Then we also calculate the scores. The scores are the same. Then we administer direct anticoagulant drugs. They are recommended as a first-line therapy in comparison with warfarin. An absolute counterindication is a mechanical prosthesis of the heart valve, mild or severe mitral stenosis, recent stroke, thrombopenia, less than 50,000, severe anemia. Very often they ask, can we administer anticoagulants in case of anemia? Yes, if it's mild or light anemia, and it's not associated with post-hemorrhage, which develops with ulcer of gastrointestinal tract or tumor. That's why severe anemia is when we administer anticoagulants. And then we work with the hemorrhagic risk factors. They are still classified as non-modified, potentially modified, modified risk factors. And the potentially modified ones are the ones we are working with. We can correct anemia. We can see why thrombocytopenia and lipethia develop, we can correct it. We might influence the infiltration speed. Warfarin therapy is another factor for hemorrhagic risk, especially in intracranial hemorrhages. We may modify this therapy as well by administering the DOACs to the patients. Definitely, the hemorrhagic risk factors are pretty much the same. We added some dangerous hobbies and professions. Heparin as the bridge therapy. And what is really important, the modified risk factors are the correctly chosen anticoagulants and the dosage, and especially the dose. And if we don't increase the optimal dose, it increases the patient's risks. And we know this very well. So we start from anticoagulant therapy. And we need to consider many things. Kidney function. We need to balance the efficacy and safety of the drugs. Different clinical situations from hemorrhagic risk factors, etc., should be considered. Drug-to-drug resistance, etc. It should be considered. And no matter what kind of drug we administer, dear colleagues, this is a high-risk therapy. For that reason, we need to accompany our patient. We need to support him on this road of life. While the patient, different things may happen to him. Small surgeries, big surgeries, PCIs. Some things from this list will be considered today. So we always compare, we always try to assess and compare DOACs. We know very well that there have been no direct comparative studies and there won't be any, but all these drugs have been compared with warfarin, and all these tablets and arrows with figures are comparisons with warfarin. And if we look at the balance between efficacy and safety, we'll see that dabigatran has a very good balance of efficacy and safety. The intracranial hemorrhages, large-scale hemorrhages are going down significantly. The gastrointestinal hemorrhages are the same as with warfarin. What are the advantages that we get when we administer the full dose of dabigatran? This is the only drug that superseded warfarin in reducing the risk of ischemic stroke in patients with atrial fibrillation. Other drugs and doses were comparable with warfarin. This is a fact, and we acknowledge it very well, and we consider it when choosing the DOAC in patients with atrial fibrillation to prevent cardioembolic stroke. Thus, products, the reduction of cardiovascular embolism, cardiovascular mortality. This parameter was good on dabigatran, large hemorrhages, life-threatening hemorrhages, and significant reduction of risk, all compared with warfarin. Significant reduction of the risk of intracranial hemorrhages. For that reason, in official instruction of dabigatran, it is written not only prevention of embolism, but also reduction of cardiovascular mortality among AF patients. Dosages should be administered accurately because that's the key to the success. And since in RELY study on dabigatran, both dosages have been studied in 6,000 patients, and this was a randomization. That is to say, there were absolutely similar groups were enrolled for dosages 110 and 150. That's why these instructions are generated on the basis of an absolute study. A patient above 68 years old, 110 twice a day. Younger, 150 twice daily. When do we reduce? When the patient is in gray area from 75 to 80 years old and he has some other risk factor, for example, reduction of creatinine clearance, drug-to-drug conflict, the deployment of anticoagulants, gastrointestinal hemorrhages. As the kidney function reduces, the hemorrhagic risks are not growing in comparison with warfarin and the dabigatran 110, 150. They are either lower or comparable with warfarin. How often do we use the reduced dosages of DOACs in real clinical practice? These are our data. Reduced doses, 42% of the patients with the non-valve fibrillation. On the dabigatran, it was slightly lower, but in 6% of cases, rivaroxaban was administered in the patients, not in the dosages that were studied for the prevention of stroke. Let's look at AF and PCI. Earlier, we were based on these guidelines. In August, we were reading lectures and we were treating these guidelines, while now we have new guidelines on managing the patients with OSC without ST elevation, and we have new guidelines on AF. And even before the AF guidelines were published, there were lots of reviews, systemic meta-analysis that showed that choosing double or triple therapy after PCI, regarding this, it was shown that there is no difference in the frequency of stroke. It is not a reliable trend of increased MI or overall mortality. This is the group of double therapy compared with triple therapy. The only thing that the researchers found was the increase of the stent thrombosis. Let's look at the three oral anticoagulants and their action in PCI. The first study that was completed was ReDuo PCI, the simplest, most transparent and clinically applicable study. Double with dabigatran and clopidogrel. The full dosage of dabigatran was used and the reduced one was dosed in comparison with triple therapy with warfarin. It was a blind randomization done in this study, and it was found out in comparison of double to triple therapy, twice the frequency of hemorrhages went down in a full dosage, dabigatran, and in partial dose. The frequency of intracranial hemorrhages went down by 10 times in double therapy. What about ischemic risk? If we take a look at general the picture 110, 150, you will see quite a balanced picture. Revascularization, thromboembolism, etc. But if you look at the table, it's quite interesting. Double compared with Dabi, 110 compared with warfarin, we see that the stent thrombosis with dabigatran is higher. But if we look at the dabigatran 150 with dual therapy, they are the same as the triple with warfarin, and ischemic risks are the same. The conclusion is simple. If we have a patient with high hemorrhagic risk, yes, we have to sacrifice. We can choose the double therapy with reduced dosage. And if we have a patient with balanced risks or prevailing ischemic risk, we give in double therapy dabigatran 150, and we get absolutely the same figures on ischemic risks, strokes, revascularization, and stent thrombosis. This design of all studies on double and triple therapy with NOACs. This green line is a very simple design, double, triple, with dosages on dabigatran. Now, the pioneer with rivaroxaban is a more complex design. What are the, let's say, claims to this study by many experts? They use the dosages of rivaroxaban that haven't been tested for the prevention of AF, although globally triple with warfarin or rivaroxaban-based double therapy are to less extent On rivaroxaban, the hemorrhages risk was less. And Augustus. Augustus has a more complex design. I'll go back to it. This blue line is the design of Augustus, where everything was compared to everything. The therapy was based on warfarin, was compared with apixaban, and with apixaban, the risk of hemorrhage was lower. Double was compared with triple, and in this particular study, when double and triple therapies were compared, it has been shown that there's a growing risk of thrombosis, stent thrombosis, which hasn't been the case with the Dabigatran 150 dosage. So when we choose a therapy in a patient after PCI, it's simple to use the results of REDUO PCI study. What is said in the guidelines? These are the guidelines on managing the patients with OSC or with non-STEMI. By default, triple therapy, 1 week at discharge, double therapy, 1 year after that, and then dual therapy, half a year. High ischemic risk, here we can use triple therapy during 1 month. This is absolutely acceptable. The guidelines on AF, the same, but there's a horizontal diagram. OSC, PCI, after PCI, aspirin during 1 week, and then we see the aspirin is getting pale. Most often we use double strategy by default. If it was OSC without PCI, we can definitely give antiplatelet therapy, and there's the same approach to revascularization when we have chronic coronary symptoms, traumatic risk factors, hemorrhagic risk factors. We look at them, we'll calculate them. These risk factors are shown in the guidelines. What is written here literally? Patients with OSC and non-complicated PCI are recommended to have an early interruption of aspirin, and in case the thrombosis stent risk is low and the hemorrhage risk is not prevailing. If it's vice versa, there is a hemorrhage risk and thrombosis of stent, then we choose triple therapy, and this is true for OCS and for the patients with OCS and PCI. What else can happen to our patients? The worst things are some emergency surgeries, some sudden disasters, ischemic stroke, trauma, hemorrhage. Of course, here the advantage is given to oral anticoagulants with a specific antagonist. Who is Dabigatran most suitable for patients with active lifestyle, high risk of falling, high risk of stroke, planned surgeries, hemorrhages. And this intervention can be a planned surgery, cardiac or non-cardiac surgery. And this is one of the studies. The patient had 237 cases of falling among the patients of 68 years old had a lethal outcome. So these patients have an advantage. Praxbind is available in 96 institutions, medical institutions of Russia, and if previously we were relying on European clinical cases with Praxbind, now we have our cases too. So we do have this drug, it's broadly used. So the advantages of Dabigatran are reduction of ischemic stroke risk, intracranial hemorrhages. This is the only drug that shows reduction of cardiovascular disease risk, and there's a neutralizer of this effect in an emergency situation. A few words about COVID. We have to speak about it. Failure of hemostasis and thrombosis. is the pathogenesis of coronavirus infection. What can be the scenarios? How do we manage the patients? How do we administer anticoagulants? I can outline three scenarios here. One is when the patient has already been taking anticoagulants, and if his COVID is mild, he continues taking it. If it's severe, he is hospitalized, he goes on heparin, and at discharge, he goes back to the therapy. If possible, we change warfarin by other oral anticoagulants. Another clinical situation, quite simple. The first event, thrombotic event and debut of AF during coronavirus. Here we use heparins, depending on clinical situation, and at discharge, we take the patient to DOACs. And in this situation, of course, warfarin is hard to manage, and direct anticoagulants are of preference. The most difficult situation is when the patient doesn't have indications for anticoagulants. He has severe COVID disease, and then we give him heparin at discharge. Very often he still feels bad. We have to leave anticoagulants up to 35-40 days in case the risk factors persist. There was a global consensus of the experts who discussed these challenges. Yes, there are no studies, but nevertheless, if it's a pre-hospital stage and we want at the pre-hospital stage to administer it, we can use any NOAC in relevant doses for the prevention of platelet formation. And at discharge, up to 45 days, we can use the NOACs. And at the same time, we will have advantages in the specific antagonist drugs. And to conclude, I'd like to remind you, dear colleagues, we can administer Pradaxa in our cardio program. If the patient had a cardiovascular event, infarction, stroke, CABG, catheter ablation, etc., a neurologist, cardiologist, a therapist in the outpatient unit can administer dabigatran for up to 1 year. And this is a free administration. Thank you so much for your attention. Administration of DOACs. Thank you very much for your presentation. Thank you for specifically mentioning COVID. Indeed, we face a large number of patients in the hospitals who are already taking DOACs or the ones that are naive to it. And with this, we are facing myocarditis, failure of myocardium that we know is typical for SARS-CoV-2, and new paroxysmal events. Very often the patients have disturbed rhythm, and we need to have some algorithms in place. So international consensus is the only way out. But this was a position of a cardiologist and a therapist. Today's symposium tells us we need to listen to a neurologist as well. And the key thing here is, what should a practitioner do? Because he needs to see his patient, to recognize the AF patient from all the sides. It's not just a look at a cardiologist and the therapist. The neurologist should also take a look, because different things should be considered. A great pleasure to give the floor to Denis Yerevich. He's a neurologist, expert of neurology, and he's an expert of administering anticoagulant therapy. The floor is yours. Hello, dear colleagues. I hope you can hear me well. With great pleasure, I want to continue the topic of preventing cardioembolic complications in atrial fibrillation. From the perspective of a neurologist, I want to discuss the following. Can a stroke happen in a patient despite taking oral anticoagulants? If it happens, why is it happening and what to do? We'll discuss the tactics of treatment and management in case a patient has a stroke despite taking oral anticoagulants. Let me remind you that stroke is the most frequent cardioembolic complication in AF patients, and the frequency of stroke is 9 times higher than the frequency of other complications in AF patients. Cardioembolic stroke is one of the most difficult forms of ischemic stroke, and as we know, this version of the stroke is accompanied with a bad outcome, larger scale infarction of brain, high level of in-hospital death, and low rate of functional independence at the discharge of hospital. If we compare it with the lethal outcome, with the lethal outcomes in thrombotic stroke, we'll see that cardioembolic stroke gives 1.5 to 2 times higher death rate than all other types of stroke. The overwhelming majority of the most severe patients have failure of conscience, failure of vital signs, and they are on heart-lung machine. These patients are the ones who had AF and they undergone stroke, ischemic stroke. The second reason for the severe condition of these patients, the second most frequent one, is hemorrhagic stroke. From early 90s, there have been studies conducted on the possibilities of the vitamin K antagonist to prevent stroke in AF patients. For example, this is one of the studies to show that warfarin together with salicylic acid gives us a lower risk of stroke. And if we take the patients with the highest cardioembolic risk, these are the patients who already had ischemic stroke and transitory ischemic attack, you'll see that with warfarin, the risk of repetition was more than twice as compared with a group of patients taking aspirin. With aspirin, it doesn't work. Despite taking aspirin, the frequency of complications in these patients is 12 times more frequently. Warfarin has many other disadvantages, such as narrow therapeutic window, need to frequently monitor, a lot of drug-to-drug contradiction. If we take 3 new anticoagulants that are represented in Russia, the NOACs, they are as good in efficiency as warfarin, but only 2 of them, the dabigatran and apixaban, according to the third phase clinical study about patients with atrial fibrillation, showed advantages compared with warfarin in terms of ischemic stroke rate and antiembolism. Besides, for all NOACs as a class of drugs, there is a typical thing, positive thing. All these drugs are almost double the times in average better than warfarin in terms of developing the most difficult hemorrhagic risk associated with NOACs. It's the intracranial hemorrhage. Warfarin, as the previous speaker mentioned, is less superior than the NOACs. Not only all NOACs, but also only the dabigatran. Only the dabigatran gives a 24% reduction as compared with warfarin. It reduces ischemic stroke. It reduces the cardiac mortality risk by 20%, and there's a significant reduction of intracranial hemorrhage rate. It's very important that this particular drug in Russia today has a possibility to neutralize its anticoagulant action in case the patient has an emergency situation. Do the patients have strokes despite the NOACs and good management? Yes, it happens. And according to RELY study, you can see that dabigatran in its both dosages was at least as good as warfarin in its preventive dosage 110 twice daily, and for 150 twice a day it was even superseding warfarin, but it was still associated with the risk of ischemic stroke and systemic embolism at the frequency rate 115%. Every 100th percent was bringing bringing to these complications. Why does it happen, especially in NOAC such as dabigatran? First of all, AF patient is of course a comorbid patient, and apart from AF, he has other risk factors and cardiovascular diseases. And these patients often have atherosclerosis, including the ones in the arteries of brain, and this may lead to traumatic stroke. Traditionally, these are extracranial platelets that cause stenosis of cranial arteries in 50% of cases. But not only this is not the only reason of stroke. There can be platelets that are causing less stenosis, but they are unstable. These atheromas are also associated with significantly increased stroke risk. There can be platelets of intracranial or the platelets on the aortic arch that can lead to the arterial embolism of distal branches of the cranial arteries, and this leads to stroke. Besides, patients who have arterial hypertension and in addition diabetes, they might have the lacunar stroke with these kind of small infarctions in the subcortex area, and it is associated with the primary failure of small vessel walls in brain. And unfortunately, oral anticoagulants are not always capable of preventing it. There are some other reasons for stroke, vasculitis, dissection of cranial artery, etc., and other types of arteriopathy. This is a classical clinical case, a patient with AF. He was taking NOACs in different versions. Despite this, he developed secondary transitory ischemic attacks in the left carotid basin. Extracranial values were not detected, but the patient had a CT, contrast angiography of cranial arteries, and we defined the reason for these recessive strokes. The reason was intracranial atheroma, two segments of the median cranial artery. You can see an occlusion of lower branch of the median cranial artery, and the upper branch as well was affected. This changed the tactics of management of this patient, and well, this was another example of a clinical case of an AF patient. What can be the reason for failure of anticoagulant therapy success in AF? It's very important to maintain the compliance. As far as you know, the patient compliance in Russia and even in Europe is far from being perfect. So you need to always clarify, did the patient really take the NOACs? Did he have pauses or not? And always ask a question, when was the last time he took his drug? Very often, the relatives of an elderly patient believe that he is taking the drug, but the patient for 1 week or two stopped taking it, and because of that, he had a stroke. Second question is, did the patient comply with the dosage recommended? Very often, maybe because of an attempt to economize, the patients take dabigatran not twice daily, but once daily. This can be a reason for ischemic stroke. Because of this, dabigatran has a very important advantage. For example, there are affordable laboratory methods that can give us a qualitative assessment of anticoagulation of the patient by dabigatran. There's a sensitivity analysis and thrombine time test method. Second thing that we need to always be clear about, if the patient developed a stroke, was the dosage administered to the patient accurate? If the patient is under 80 years old, he had a reduced dose of dabigatran 110 mg twice daily, how justified was that? I want to remind you again that patients in the age up to 80 years old, and those who have creatinine clearance up to 3 milli per minute, the recommended standard dosage of dabigatran is 150 mg twice daily. This is efficient. And only in some clinical cases, in the patients with high hemorrhagic risk and in the age from 75 to 85, we may consider using a reduced dose 110 mg twice daily. I want to show you very interesting data that were recently published. The data of Gloria register, where you see AF patients and their compliance was assessed in taking dabigatran, and the results of the unjustified cancellation of dabigatran in these patients. This was a big registry, 4,500 patients, and the frequency of stopping taking dabigatran was about 30%. And if we assess the situation in different regions, we'll see that mainly dabigatran was stopped being taken in Latin America, Middle East countries, and the highest compliance level was in Asia, North America, and Europe. The reasons for cancellations were adverse events only in third of the cases. In the rest of the cases, there were other reasons. So what was the result? If the patient stopped taking dabigatran and he didn't take any other NOAC, his risk of developing ischemic stroke during 2 years was going up by 76%. The risk of cardiovascular death grew significantly. All-cause mortality grew twice. The patients who were compliant to the therapy for at least during 1 year in the future had more than 90% of probability of its continuation. The authors of this study conclude on the importance of focusing attention and efforts on being compliant to the therapy in the beginning of the therapy. The purpose being maintain the good compliance in the patient onwards. And to achieve this goal, to help achieving this goal, we have a federal program on the patients with cardiovascular diseases. There is an edict of the Ministry of Healthcare of Russia dated to 9th of January this year, according to which patients with cardiovascular risks have to get during 1 year after diagnosis a number of drugs, and dabigatran and Taxilat in both dosages is in this list. In this way, patients of the relevant category must get this drug. It should be prescribed. If we are talking about Altai region, where I am, according to the regional Ministry of Healthcare, the first recipe for these drugs is prescribed in the department where acute patients are. Dabigatran and Taxilat can be prescribed without doctoral commission for 6 months ahead. This facilitates the situation for the patient, improves the compliance, as I believe it's especially important now with the pandemics and with the existing difficulties in getting outpatient help support. What is important? When we start the anticoagulant therapy, there are several things to keep in mind. It should be an efficient drug, which is efficient in preventing stroke, and it has a low hemorrhage risk. There's another important argumentation in this chain of reasons, is the possibility to neutralize anticoagulant effect of the drug, and throughout life it can play an important role in for the patient. And Pradaxa is that particular drug to comply with all criteria. And this drug, among other things, is the only NOAC in Russia that today has efficient, safe, available specific antagonism called idarucizumab. It's a monoclonal antibody to dabigatran. It has a very high level of similarity to the dabigatran molecule. It's 350 times higher than the similarity of dabigatran to thrombine, and this brings to the irreversible binding of this molecule to the dabigatran. Idarucizumab is intravenous, and after 2 injections of 2.5 mg, it starts an immediate effect. It doesn't have any anticoagulant activity, as different from other drugs that are used in case of hemorrhage. In this way, ricochet thrombosis is not something we expect in idarucizumab case. There's a result of a large research, Reverse AD, that showed the efficacy of idarucizumab. As it is injected, the dabigatran's action is momentarily stopped. This effect was very resilient. It was preserved for 24 hours, and this enabled to efficiently cope with all emergency situations, as a result of which idarucizumab was injected. Yes, there are lots of patients who will benefit from Pradaxa or some other drug because they may have a risk of emergency surgeries, a risk of hemorrhages, fallings, traumas, etc. Here we include the patients with high-level risk of ischemic stroke, where by an efficient anticoagulation can be an obstacle in using some efficient methods of treating ischemic stroke in case it develops. One of the most efficient methods of treating ischemic stroke is systemic thrombolytic therapy by using alteplase. Alteplase. There exists a large number of large randomized trials and data of clinical registries that confirm the high efficacy of alteplase among the patients, and according to them, the probability of favorable outcome for the patient, such as no death, no disability, goes up by 60% compared with the standard patient management. But if the patient is already taking an oral anticoagulant, in official instruction of Actelisa drug, there's an important counterindication. It's the simultaneous treatment with perioral anticoagulants. In case of warfarin, it should be 1.3, the maximum dosage. Colleagues, we have national clinical guideline, reperfusion of ischemic stroke. It was published in 2013, and one of the parts of this guideline is dedicated to this problem, thrombolysis among the patients that take NOAC. If we definitely know that the last dose the patient was taking was more than 12 hours ago, and the kidney function is preserved, the thrombolysis can be done immediately. If the last dosage was taken in the window 12 to 48 hours ago, then dabigatran approxilate, if that was what the patient was taking, then thrombine time should be assessed, and if it hasn't been exceeded, then thrombolytic therapy can be administered. If it was not prolonged, then the patient can get the thrombolytic therapy only in case idarucizumab has been injected. For patients who took the 10th A factor antagonist, if there's no activity, we can conduct thrombolysis. In the majority of centers in our country, this test is not conducted. In this way, these patients, in case they develop stroke, they can't get systemic thrombolysis. If the last dosage was taken of NOAC was taken more than 12 hours ago, for dabigatran, the only way to conduct thrombolysis is to inject idarucizumab. But 10th factor, you simply can't have it. In this way, if the patient takes dabigatran and he has an ischemic stroke, and we have clear evidence of the absence of anticoagulant effect because the last dosage was taken 48 hours ago, or the prolonged time is not detected in anticoagulation test, then a thrombolysis can be conducted. In all the other cases, thrombolysis is also possible if we inject idarucizumab. The commercial name is Raspine. If we definitely know that the last dosage of NOAC was 48 hours ago, or if we can assess the antidicity activity and it's not there, we can do thrombolysis. In other cases, no. In this way, the choice of NOAC in patients with AF defines the possibilities of conducting or non-conducting of thrombolysis in the future. And these data that have been demonstrated by Tatiana Vladimirovna also illustrate that in our country we have a lot of patients who got systemic thrombolytic therapy despite taking the dabigatran and because there was Proxbind in the center. If these patients had taken other oral anticoagulants, they wouldn't go for thrombolysis and they wouldn't have a good improvement, clinical in fact, no death, no disability. This is a very interesting overview, dear colleagues. It includes 55 large studies and series of observations over multi-center cohorts. Over 500 patients included in this survey. Those who took NOACs had stroke and they were going for thrombolysis. Of course, these patients who got rivaroxaban or apixaban, they didn't have specific antagonisms, and just based on the clinical picture, they had thrombolysis. While dabigatran patients, they were split into two groups. The dabigatran group that had thrombolysis with injection of idarosuzumab and those who didn't have Proxbind. Injection of idarosuzumab enabled to reduce double the times the symptoms of intracranial hemorrhage, 3 times reduction of death rate, and double the times increase of favorable outcome probability in these patients. It demonstrates explicitly the efficacy of idarosuzumab in case of thrombolysis. Another infrequent problem that we encounter as we administer antithrombotic drugs is the risk of developing intracranial hemorrhages. In fact, even the spirit that many think is a harmless drug increases the risk of hemorrhagic stroke by 40%. Warfarin increases it by 200%, and intracranial hemorrhages can happen not only in subtherapeutic but also clinical cases of the intracranial hemorrhages. The frequency of intracranial hemorrhages in therapy of with warfarin in patients with atrial fibrillation amounted to 1%. Very often the stroke was much harder than in the patients who didn't have anticoagulant therapies, and there's a high lethal outcome in this group of patients. I have to say that all direct anticoagulants are much better than warfarin in terms of risk of hemorrhagic stroke. But please note that dabigatran, especially the dosage 110 mg twice a day, has the highest difference with warfarin in terms of hemorrhagic stroke frequency, double the times. Hemorrhagic stroke is a very prevalent condition. 1 million people worldwide have this disease. And the prognosis and outcome of the disease in these patients is defined by the initial volume of hematoma, and secondly, which is important, by the growth of intracranial hematoma during the first day, 24 hours. INTERACT-2 and TOUCH-2 important studies show that every 4th patient with hemorrhagic stroke has a significant increase of hematoma during 24 hours. The majority of these patients didn't take anticoagulants. We have to understand that those who were taking anticoagulants might have a much higher percentage of hematoma. A TOUCH-2 study showed that even the extremely tough control of arterial pressure after the first hours of developing hemorrhagic stroke, unfortunately, cannot prevent the growth of intracranial hematoma. In 2019, the new guidelines of the European Stroke Society have been published on the tactics of managing the patients who developed hemorrhagic stroke as they were taking oral anticoagulants. And please note that in case of dabigatran, it was written that as the patient takes dabigatran and he develops intracranial hemorrhage, he is recommended to take trastuzumab to mitigate the risk of a growing hematoma. In the medical literature, there are lots of cases described by now, and one of the largest series is the one I'm showing to you now. It was published by German researchers, 120 patients with different types of stroke as they were taking the dabigatran. 80% had ischemic stroke. They got daratumumab for thrombolytic therapy. The effect was good. Almost 80% of the patients showed significant clinical improvement, 7 scores or NH scale, and none of these patients developed clinically relevant hemorrhagic complications, nor did they have thrombotic events after hospitalization. Also, we had 40% of patients with intracranial hemorrhages, and more than 60% of the patients had significant clinical improvement in the end of treatment, and only 10% of the patients after hemorrhagic stroke and injection of daratumumab had a growing hematoma, which is much less than it usually happens in this population, in this cohort. The next question I wanted to discuss is the further strategy with these patients. When an AF patient had a stroke, and the question is, what is the timeline whereby we can administer anticoagulants in these patients? In the updated European guidelines on AF, there's a chapter on this which says that the secondary prevention of stroke and systemic embolism after stroke associated with IF includes the early prevention of stroke after the first event and further prevention in the future. If there are no strict contraindications, then a long-term stroke prevention is recommended with NOACs as a preferential method if they are not contraindicated, as compared with vitamin K antagonists. This has the highest class of recommendation and evidence base. As for the time of cranial hemorrhages, it's not known, but it should be postponed till the end of the acute period of hemorrhagic stroke to at least 4 weeks. In some cases, and I think mechanic heart valves are included here, in some cases for 2 weeks. Patients who have AF and high risk of repetitive PCI, occlusion of ALP should be considered. Together with neurologists, administration of oral anticoagulants should be done. NOACs are of more preference than the vitamin K antagonists, if it's acceptable. In case of traumatic and spontaneous intracranial hemorrhages. But before that, thorough assessment of risk and benefit should be conducted. If there are high risk factors of hemorrhagic stroke repetition, and there are scales such as CHA2-VASc score that help us to assess thromboembolic risk. These risks should be evaluated, and a decision should be made on renewing the oral anticoagulant therapy or its cancellation. There are some other guidelines, neurological guidelines of the European Stroke Society back in 2019. They were focused on secondary prevention of the non-valvular atrial fibrillation patients. It says here that the disaggregant antiplatelet therapy is not recommended at all. Vitamin K antagonists are more of advantage than anticoagulants, but NOACs are of more preference than vitamin K antagonists. Unfortunately, we don't have the data of randomized clinical trials saying what is the timeline during which we can renew or initiate the NOAC therapy in these patients, depending on the degree of severity they have. But the opinion expressed by the majority of experts who made these guidelines says that before anticoagulants, the disaggregant therapy should be conducted. In case of mild stroke and development of infarction, therapy should be initiated on day 3-4 with mid-size cranial infarction on second day and large day 14. These guidelines are very coherent with DINER law 3-6-12 for stroke, and in this case it's 3-7-14 days. There's another important thing. The bridge therapy, according to the experts, by injection anticoagulants shouldn't be used in stroke patients before they are administered NOACs. The reason is the high therapeutic doses of injection anticoagulant significantly increase the risk of hemorrhagic transformations and complications, whereas they don't have any proofs in preventing the recession of cardioembolism of cranial vessels. Unfortunately, we have to admit that very often, especially in our country, patients with AF and high risk do take aspirin. This takes place in the primary chain of medicine, and very often therapists do so. Why is it happening? I think this, first of all, happens because the doctors believe aspirin is very safe, as different from oral anticoagulants, and it's affordable. In fact, is aspirin that safe? In association with this, I want to show you the data of large meta-analysis published 1 year ago. It's about using aspirin in primary prevention. Please note that the risk of all intracranial hemorrhages with aspirin compared with a control group is going up by 40%, while the risk of subdural and epidural hematomas was going up by 53%. We see in our center a lot of hemorrhagic strokes that developed as a result of unduly administered aspirin. Because of the state-of-the-art guidelines on the primary prevention of cardiovascular diseases have narrowed down the place and role of aspirin, especially for those above 75 years old. We have direct comparative data within the framework of randomized study. It's RESPECT study where aspirin and dabigatran are researched to prevent the repetitive stroke. A group was administered warfarin and another one dabigatran, aspirin. And you can see that the frequency of bleedings was absolutely the same in both groups. I mean, intracranial hemorrhages, gastrointestinal and life-threatening bleedings, patients taking standard dosage of aspirin, and those who took the maximum, most efficient dosage of state-of-the-art anticoagulants, such as dabigatran, the same risk. So if a patient with high risk of, with AF and high risk is administered aspirin, not only the risks are not going down, on the contrary, hemorrhagic stroke probability is still there, and it's still that high. To conclude, I think that non-administration of oral anticoagulant or a replacement of administering disaggregant therapy, it's a significant doctoral mistake that brings severe consequences for the life and health of the patient. The choice of oral anticoagulant and dosage should be based on the combination of efficacy and safety with consideration of patient profile. Dabigatran is one of the safest options from the perspective of efficacy and safety, and it is the only drug to have a specific antagonist in Russia. Administering dabigatran in the future helps to provide a more efficient aid to the patient in case he develops ischemic and hemorrhagic stroke, bleedings, or other acute situations of traumas. In the end, I want to show you these quotes that I found very interesting. Famous Canadian neurologist, great expert in stroke studies, Charles Miller Fisher, about 20 years ago said that if you are treating with anticoagulants at least one patient in your practice, you won't have a good night's sleep, and at least once a week you will wake up sweating cold. 10 years after, a Brazilian neurologist, Francisco Diaz, responded to Charles Miller Fisher, saying that we don't wake up in the middle of the night sweating cold, because a new era of efficient and safe reversive agents for oral anticoagulants is already there. This opinion is expressed in his article on idarosuzumab for reperfusion therapy in stroke patients taking dabigatran. No more cold sweat. Thank you so much for your attention, colleagues. Thank you very much, Denis Yurevich, for your comprehensive overview of neurologist position. We have a few questions. Let me group them up. We have lots of questions on a very interesting aspect. The first set of questions, and I'm going to ask both of you this question, is the use of DOACs and use antidotes, using of their antidotes in case of thrombocytopenia. I know what the reason of this question is, because COVID-19 very often leads to thrombocytopenia. What to do in this situation? Let's put aside the fact that a person might have COVID-19, we don't know it. Thrombocytopenia, do you have POAC tactics and antidote? Any experience? Yes, I'll try to take this question because partially I spoke about it. Thrombocytopenia, at least 50,000, is a counterindication for the usage of any anticoagulants. Alarming level from 50 to 100,000. We need to tackle this clinical picture. In the real clinical practice, we may have a very simple situation, peer analysis, and automated analyzer puts down aggregated figure for thrombocytes, and then the platelet figure is not realistic. We need to do the blood test again. Sometimes there is an immune thrombocytopenia, and in these patients, we have to be very cautious about administering anticoagulants. We administer less dosages, and maybe it's a consumption thrombopathy. If it's so, then we give a different treatment. So it's an individual approach in every case, from a lab mistake to severe clinical conditions. Thank you. Understood. Thank you for your answer. And one more addition to this question. This additional disaggregant therapy in these patients, do you think we should first of all give up disaggregants and then anticoagulants, or vice versa, to give up both groups of drugs if we are dealing with a low level of thrombocytes? The level indicated is 60. You said the alarming level is from 50 to 100. Yes, we need to look at the specific clinical situation and the reason why the patient is taking disaggregant therapy. If it's stenting, or 1 month after, or at least 3 months after stenting, no matter if it's drug-eluted stent or bare metal stent, the high risk of stent thrombosis is there, and we will probably leave this antiplatelet drug. Although with this level of platelets, it makes not much sense to give an antiplatelet drug. We need to take a specific look and understand why antiplatelet drug, why anticoagulant, what are the indications, dosages, combination. In general, it's really hard to respond to this question. So managing hemorrhagic risks with thrombocytopenia is a very complicated problem, which requires an individual approach. Without a clinical case, it's hard to make a decision. I can only agree, because I think in the same way, I think we need to look at a specific clinical situation, no universal recipe for all patients. The second series of questions, inevitably on COVID-19, idaruximab and COVID-19. We understand that the risk of thrombosis is growing with COVID-19, and we're fighting against these risks. But here is the question: do you have any experience of idaruximab in COVID patients? I haven't come across these kind of publications. We didn't have analysis of these kinds so far. Maybe Dennis Yurevich knows something, but I can't tell anything. Although clinical situations for use also can be ischemic stroke. I haven't encountered any information on this, but we have to say that the ischemic stroke itself often develops with COVID-19, and according to some data, the risk of stroke is 7 times higher. But these patients require a temporary cancellation of dabigatran depending on severity of ischemic stroke with subsequent renewal a few days later. Okay, thank you so much. Well, these were two key series of questions, a lot of questions on thrombocytopenia, understandably, because of COVID-19. Thank you for your time. Thank you for your presentations. No more questions. If you don't mind, we will move on. Thank you very much again, dear speakers, for these comprehensive presentations. Many thanks to the audience. And for those who got newly connected to us, let me announce what's going to happen then. According to the program, we have a break now. After the break, we will continue our symposia. Let me say that the symposia are conducted in parallel in 3 halls: Moscow, St. Petersburg, and Perm. If you step into Moscow Hall after the break, we'll have a big symposium on managing the patients with combined cardiovascular pathology, classical cardiovascular comorbidity, ischemic heart disease, fixed combinations, and arterial hypertension patients. In St. Petersburg Hall, we'll have a symposium on managing frail elderly patients. We know very well that the notion of frailty of the patient is becoming very trendy. In fact, being a frail patient is a big problem. It reduces the quality of life. And experts, including the ones from St. Pete University after Mechnikov, will share a series of really interesting presentations on this. In Perm Hall, we'll have a symposium on the breakthrough of anticoagulants in ischemic heart disease. Just like it was forecasted 10 years ago by some experts, anticoagulants will gradually squeeze out these aggregants for ischemic heart disease treatment. We live in these times, and a large symposium explaining what to do with anticoagulants. Well, we are used to giving anticoagulants in case of AF, but what to do with the patients with ischemic heart disease? This is the topic of symposium in Perm Hall. Thank you so much for your continued support and attention. We have a short break, and in 40 minutes at 2 o'clock sharply, we'll go back again with a series of our symposia, and the day will be over. It will culminate in a large section called Future Forum. 7 countries, 7 experts working with COVID, anesthesiology, resuscitation, pulmonology, etc. These experts are going to share their experience on what we're going to face. Red zone, not red zone, doesn't matter, but what is the future, depending on our specialty. Thank you so much for your attention.
В ваших руках возможность замедлить прогрессирование хронической сердечной недостаточности. Какова цена промедления?
Артериальная гипертензия. Одно из самых распространенных заболеваний сердечно-сосудистой системы. Периодическое или стойкое повышение артериального давления приводит к патологическим изменениям в органах мишени. В первую очередь страдают сердце, головной мозг и почки. Одной из главных мишеней заболевания становится сердце. Нарушение кровоснабжения вызывает развитие стенокардии и прогрессирующие коронарные болезни. Конкор АМ – комбинированное гипотензивное средство, включающее два высокоэффективных компонента – амлодипин и бисопролол. Компоненты дополняют друг друга, воздействуя на разные, но комплементарные механизмы. Амлодипин блокирует кальциевые каналы и снижает концентрацию ионов кальция в гладкомышечных клетках, что приводит к расширению кровеносных сосудов и снижению артериального давления. Бисопролол блокирует бета-1 адренорецепторы в сердце. Блокада рецепторов снижает частоту сердечных сокращений, уменьшает потребление кислорода миокардом, нормализует ударный объем и продолжительность диастол. Бисопролол также блокирует бета-1 адренорецепторы юкстогломерулярного аппарата почки. При этом уменьшается выработка ренина и, соответственно, снижаются эффекты ренин-ангиотензин-альдостероновой системы. Компоненты Конкор АМ усиливают антигипертензивные действия друг друга и хорошо переносятся пациентами. Препарат Конкор АМ принимается в комфортном режиме, один раз в день по одной таблетке. Широкая линейка дозировок позволяет легко выбрать оптимальную дозировку для каждого пациента. Конкор АМ. Одна таблетка, две молекулы, тройной механизм действия.
Colleagues, allow me to welcome those who have just hooked up. We continue our scientific program simultaneously. We have three platforms, three halls, Moscow. Here we start the symposium on the strategy of management of patients with atrial hypertension and ischemic heart disease. So we'll be talking about a cardiac comorbid patient, which we see everyday. Experts will offer different approaches to the treatment of such patients. Simultaneously, in St. Petersburg, they'll be talking about management of frail elderly patients. That's very important because we must know how to deal with such patients, to know additional risks, and simultaneously in PERM, there will be a discussion about how anticoagulants can change the prognosis of patients with coronary heart disease. We know that the forecasts made 10 years ago are very relevant right now. Anticoagulants are elbowing out antiplatelets. Well, we are in the Moscow hall. I'd like to welcome you at this symposium, Arterial Hypertension, Management of Patients with Concomitant Cardiovascular Pathology. Let me just say that, in fact, this symposium allows us to have a broad view on cardiac comorbid pathology that our patients have. A person with hypertension usually has arteriosclerosis and ischemic heart disease. On top of that, he will have other complications and other outcomes such as atrial fibrillation, stroke, acute coronary event, or probably violation of cerebral circulation. But anyway, when we detect this cardiac pathology, hypertension and ischemic heart disease requires a thorough approach using the motivation of the patient from the point of view of the combination strategy of treatment, from the point of view of optimal regimens for such patients. We know that recent recommendations on management of patients with hypertension stipulate combination therapy. The selection of the right pill is just half of the business. The second half is to motivate the patient to take in combination drugs first and foremost. And it's a pleasure for me to give the floor to Grigory Artyunov, beta blockers in the therapy of atrial hypertension with the focus on hypersympathicatonia. Well, welcome everyone. Let's get started with this word, hypersympathicatonia. To what extent do you relate to this question? Let's just have a minor test. I'd like to ask you to put your left hand on the wrist and calculate the heartbeat, the heart rate, and I will mark the time on 3. 1, 2, 3, go. Let's say 10 seconds. Multiply by 6 those who have another figure than 70 heart rate. Well, I think 40% of people will have a different rate. It's an important presentation. That's not a Martian syndrome, which never occurs in real life. This occurs everywhere. And if this happens in people with hypertension or coronary heart disease, the outcome might be much worse. We try to determine hypersympathicatonia by the heart rate, but look at my hands. If the heart rate is 80, the diastole is very short. If it's 60, it is longer. The essence of the problem boils down to the fact that the myocardium gets blood from diastole. If the diastole is short, there is a situation when there is a progression or maintained the myocardial ischemia. This is unacceptable for our patients. Let's look from this point of view to new risk factors which have emerged recently. Why it's a psychosocial problem and is considered to be the risk factors for ischemic heart disease. Why are we talking about the different level of education and poor social life? One of the mechanisms is the systemic impact on the sympathetic system. It's activation, constant tachycardia when the diastole is constantly short. So the philosophical pathophysiological concept is transformed into a clinical concept. Well, poor life, psychosomatic problems as the risk factor for ischemic heart disease, and we can see that this leads to constant tachycardia. There are a lot of psychological risk factors. Well, broken families, insomnia or poor sleep, that's very important. Problems at work, these are the facets of the same problem, hyperactivation of the sympathetic nervous system. But there are other factors, simple obesity. Well, you can see that in this case, fat in the abdominal cavity can lead to systemic inflammation and to the activation of the sympathetic system. First and foremost, this is central visceral obesity when the man's waist is more than 94 centimeters and in women more than 80 centimeters. You should make the right conclusion. There is a lot of fat in the abdominal cavity. It has an impact on the systemic inflammation through the hyperactivation of the sympathetic system. What are the therapeutic boundaries of the patient whose picture you can see? The red lines show how you should not waste, how we should not measure the waist. That's a mistake. We should have the oblique line going through the umbilicus. Well, of course, this man has a very big waist, and obviously, you can see that this person has high intra-abdominal pressure. When this person goes to bed, well, what is going to happen with the area where the gas exchange happens? And this, as you can see, will lead to the sleep apnoea in this patient. Sleep apnoea is the direct way to hyperactivation of the sympathetic system. Snoring while sleeping, etc. That means constant tachycardia, and of course, this big abdomen can make you think about atherosclerosis. Let's talk about fat from a different point of view. Well, you can see the vertical structure of the patient, and you can see the pink color. Where is fat in the abdomen part? Well, omentum, adipose fat. You can see the CT. You can see the white triangles. That's the unique location of the fat along the great vessels, along the pericardium area. That's very untypical places for adipose fat. Why is this fat so important? It's because of this fat leads to systemic inflammation. Systemic inflammation will support the hyperactivation of the sympathetic system. Another fact of real life, you can see the black line in this women. It can be everywhere in the armpits, etc. And you can detect such signs of insulin resistance. And there is another criteria that we should pay attention, the metabolic syndrome. You can look at the red part of the slide, the waist ratio 94 in men, 80 in women. That's not the metabolic syndrome. But here you can see the pressure and 3 parameters of the lipid profile. The yellow color shows the 3 parameters of the glucose level, glucose tolerance test, and glycated hemoglobin. Any 2 items from the white text and any 2 from the yellow text, and we have the metabolic syndrome. Here you can see people with hyperactivated sympathetic system. Look at the red color. Well, the blue actually box shows glucose, fasting glucose. If it's more than 6, the patient has pre-diabetes, the hyperactivation of the sympathetic system. Well, of course, a lot of people smoke, regular smoking that we should measure in terms of pack years, and of course, the number of cigarettes smoked and the duration of smoking. It will be 20 in the denominator. As soon as the indicator more than 10, the hyperactivation starts. It can happen also at lower indicators. So smoking, abdominal obesity, poor sleep, metabolic syndrome are the factors leading to constant hyperactivation. Here you can see the risk factors plus poor social conditions, hypertension, and coronary heart disease. And you can see a lot of people when the sympathetic system is hyperactivated. The first figure is here. If the heart rate is more than 80 beats per minute, the patient has the serious factor of cardiovascular risk. Another interesting approach is shown here. An increase by the heart rate by 10 beats increases by 60% the risk of cardiovascular disease. And recently, medical workers started to talk about sympathetic overdrive. Sympathetic overdrive is not just tachycardia, but that's also the change in the lipid profile, an acceleration in the development of atherosclerosis, intensification of major risk factors. So the simple procedure, you count the heart rate at rest, and as a therapist, of course, I can talk about other reasons such as anemia, etc., but probably it's a sympathetic overdrive, the hyperactivation of the sympathetic nervous system. What is going to happen with the vessel endothelium? You can see blood going at high speed, and it goes not as a monolith, but in 6 layers. This layer sliding the endothelium starts to damage it. The higher higher the speed, the more damage is done to the great vessels. The more the vessel is damaged, the older the patient is. I mean, the biological age. Here are the data of the Russian registry, Hyperion, prepared by the Russian Association of Therapists. You can see the age group, and you can see the biological age is ahead of the passport age in patients who have constant tachycardia, uncontrolled hypertension. And by the way, as for the heart rate, remember the biological law that stipulates the number of heart rates in any patient or mammal is 3.5 billion. So the higher the tachycardia is, the faster your reserve expires. You can see the short diastole of the myocardial ischemia increases the probability of sudden heart death. Another aspect, and it's a very good proof, 1 hour prior to the heart attack, Holter monitored an increase in the heart rate or a short diastole. This is a very interesting study, 7,000 patients, 23 years of the follow-up. The red bars shows the probability of sudden heart death, which increases with the increase of the heart rate. The most severe group of patients are those who have a left ventricle hypertrophy and constant tachycardia. And we should control it. How can we control this situation? Well, we can control the heart rate by beta blockers. Of course, you can use hydropyridine or calcium channel blockers, but the main class is beta adrenal blockers. Well, their history is unique. At the beginning of the 20th century, it turned out that chemicals can have an impact on the heart rate. It was a beta 2 agonist. As for beta blocker story, everything started in the 1950s when for the first time Black suggested to reduce the heart rate by beta blockers. In 1967, beta 1 and beta 2 adrenal receptors were discovered, and then the Nobel Prize was given for that. Now there are criteria regarding who should get beta blockers. If there is the chronic coronary syndrome, or the person had MI, paroxysmal AF, constant paroxysmal AF, there are 6 parameters for administration of beta blockers. But what about real clinical data? We monitor such patients in real practice. The doctor administers beta blockers. So does the doctor know what is going to happen? Look at different yellow and red lines. 57% of the reduction of the risk of death when beta blockers are administered to patients with stable ischemic disease. The patients have been followed up for 20 years. We should follow these recommendations and stop arguing. Beta blockers reduce overall mortality from all causes, and patients who had PCI, for example, one group is on beta blockers, another is not on beta blockers. You can see that the red and green lines begin to depart. The length of the diastole is different. The length of the diastole regulated by beta blockers plays an important role. And the question is, what is the frequency rate of the administration? There are beta blockers who work for 6 hours. There are beta blockers who work for 24 hours. Or almost 24 hours, 16 to 24 hours. I'd like to show you 2 different beta blockers, atenolone and bisoprolol. Atenolone works for 6 hours. Well, bisoprolol is from 16 to 24 hours. That's its half-life. So the question is, how long can you control the heart rate. I wouldn't like to go into the algorithm, but let me just draw attention to the bottom of the slide. When do you administer beta blockers? At any stage of treatment of hypertension, when there are indicators that I have mentioned. Well, angina, myocardial infarction, AF, pregnancy, or planning of pregnancy. In this case, you administer beta blockers. Another interesting study of bisoprolol. Before that, other beta blockers had been used, but there was a big group of bisoprolol. The number of cardiovascular events and deaths. Patients with hypertension who were on bisoprolol or other beta blockers, well, you can see the difference between the curves. Beta blockers increase the length of the diastole and prevent death and other events. Bisoprolol is a powerful drug, reducing the risk of sudden death in patients with chronic heart failure. Here is the study. More than 109,000 patients on beta blockers. Their comparison, you can see the curves depart. Well, the follow-up 10-year period, and bisoprolol leads to the reduction of the risk of death in those patients on bisoprolol. And also, you can see at the white line. The white line shows bisoprolol's impact on the number of ischemic events. Patients already had a stable angina, and it's a simple procedure, as I said. Well, count your pulse. Well, look at the length of the diastole, look at the factors hyperactivating the sympathetic system. Maybe you need a beta blockers who can act for a long time to enhance compliance. Here is another situation. 400 days bisoprolol in patients with stable angina, and you can see the outcomes of cardiovascular diseases. The yellow and white line depart at the early stage. So bisoprolol had a lesser number of cardiac events. Well, you can see EKG. At the top is the normal fiber. At the bottom, patients with ischemic heart disease, with coronary heart disease. Well, you can see the fibers are damaged, and it's difficult to affect them. You can only increase the length of the diastole to enhance the filling. And here you can see the titration is right. We start with the minimum dose of such severe patients. Then we titrate, we increase the dose. This is the maximum dose. And here is what we have. The higher the dose of the beta blocker, the better the tolerability, and the better is the clinical effect. You can see the blue and the red line. They departed at the rate of 46%. That's a drop in the risk of sudden death during the first year of treatment. That's an important question, and we understand that beta blockers do not just have some particular effect on the sympathetic nervous system. Beta blockers protect people from different clinical events, reduce the risk of sudden death, overall mortality of patients with coronary heart disease and hypertension, reduce the number of cardiovascular events. So beta blockers have an important role in treating such patients. Remember about that to provide care for patients with coronary heart disease and poor circulation. The simple method is count the heart rate, make the differential diagnosis, exclude other reasons such as tachycardia. If you excluded other reasons, remember sympathetic overdrive requires the administration of beta blockers to control the situation. Thank you very much for your attention. Distinguished colleagues, Grigory, thank you very much for your presentation. Actually, you raised an important problem. We've got a lot of questions in our web chat. That's control over the heart rate in the studies conducted over the last 15 years, abnormal heart rate led to poor prognosis, no matter whether these were patients with coronary heart disease or like in the American, French, Japanese study, these were healthy men who had very high heart rate. Such patients should be examined and followed up. As for ischemic heart disease, I'd like to give the floor to Oksana Andreeva, who will be speaking on hypertension and coronary heart disease. Oksana, the floor is yours. Distinguished colleagues, in this part of our symposium, we'll be talking about coronary heart disease and hypertension. In fact, despite the fact that in recent years we've learned a lot and we've done a lot in terms of adequate, optimal treatment of patients with coronary heart disease, nevertheless, this disease continues to be one of the leading causes of death in different countries, like in the European countries. As you can see it here, the recent data showing that the mortality rate from coronary heart disease is very high, 19% in men, 20% in women, and the mortality rate is going down. Anyway, you can see that the mortality rate from cardiovascular diseases in men in Europe is 40%, in women 49%. Although quite recently the figures were higher. I should say that if we look at the countries of the European Union, the data show that the situation is even better as compared to the entire Europe. You can see that the share of deaths from coronary heart diseases in men, 34%, in women, 14%, despite the fact that these figures are quite good because there is a positive dynamic here. Nevertheless, coronary heart disease in the structure of the diseases and the structure of deaths is unfortunately one of the most important. In Russia, we can see that patients with coronary heart disease, acute coronary heart disease, stable disease are quite a lot. And you can see some figures here, and that means that we must solve our questions and issues on the basis of existing guidelines to treat such patients. As for the range of clinical forms of coronary heart disease, it is shown here, and you are very well aware of it. We're talking about acute coronary syndrome. This term has been in use for a long time. It's part of the medical vernacular. We know that there is a stable coronary syndrome and different options of this stable disease that we encounter in everyday life. There are also asymptomatic coronary heart disease. But compared to 2013, there have been drastic changes here. And these changes mostly occurred last year because at the European Congress of Cardiologists, new guidelines were adopted called Guidelines for Diagnosis and the Treatment of so-called chronic coronary syndromes. Here we have asymptomatic patients and the symptomatic patients such as angina, but also there are some conditions that we traditionally do not refer to stable coronary heart disease. For example, patients with the acute coronary syndrome, which develops within a year, or patients with revascularization. These patients were considered to be patients who should be treated after acute coronary syndrome is dealt with. Nevertheless, these are the new forms written into guidelines, and they define the group of patients who come to us as outpatients. In some cases, we just monitor them. In some cases, they are hospitalized. And as far as these patients are concerned, it is important to find the link with hypertension. Patients with chronic coronary syndrome are those patients who in 80% of cases have hypertension. And although these are data of the REACH registry of 2006, the situation has practically not changed. The REACH register is being updated on a regular basis, and this figure is right. About 80% of patients with coronary heart disease or chronic coronary syndrome, as we call them, have hypertension. Bringing to bear, it is important to solve such issues as what are the targeted indicators of pressure of patients with hypertension, what the combination drugs should be administered to such patients, which combination drugs are more optimal in this case, and should be indicated on the basis of different studies. If we start with the question of office pressure, they are written into European and Russian guidelines, in Europe in 2018, in Russia 2019 guidelines. You can see that the differences in case of coronary disease just boil down to the factor of age. If the patient is younger than 65, under 65, the systolic pressure should be under 130, but if it is well tolerated, then you can work with this pressure and try to lower it, but not lower than 120. If patients are over 65, then it should be less than 140, but not less than 130. As for diastolic pressure, it is the same for all groups. As for the antihypertensive therapy regimens, and these are new algorithms that have become part and parcel of our life since 2018. On the basis of this algorithm shown here, which is applicable to most patients with arterial hypertension, a medical therapy algorithm was developed for those 80% of patients who have hypertension and coronary heart disease. If you look at these algorithms, you can see the differences here. The previous algorithm showed that the initial therapy are renin-angiotensin system blockers in combination with calcium antagonists or diuretics. And as for arterial hypertension and ischemic heart disease, an important place is attributed to beta blockers, although I should say that calcium antagonists and diuretics can be used in combination with renin-angiotensin system blockers, but in fact, after the use of antihypertensive drugs, especially combined drugs, so first renin-angiotensin system blockers, number one, and then beta blockers rank number two. And these are the major differences that we should take into account when we administer drugs to patients with hypertension. If we look at the guidelines referring to coronary syndromes, not hypertension, we can come across the same principle. All drugs are divided into those which impact the quality of life, having anti-ischemic properties, and those which improve the prognosis and prevent cardiovascular events. And here is what we have on the platter. That's a very clear algorithm of using anti-ischemic drugs as far as the improvement of the quality of life is concerned and diminishing symptoms. Well, just look here. All patients with chronic coronary syndromes can be divided into 5 groups. The main group is the one that uses standard therapy. There is also a group with the high frequency of high heart rate, also a group with the heart rate less than 50, and another group which is also important is the one, and by the way, that's one of the new positions of determining one of the chronic coronary syndromes. That's the group that has heart failure and left ventricle dysfunction. So all these 4 groups are those in which the arterial hypertension is very high. There is only one group which do not have arterial hypertension, is the group with low pressure. If we look at the steps that we should take in this case to reduce the symptoms, anti-ischemic therapy, and of course this will have a contribution to reducing blood pressure. Well, of course, you can see that here, beta blockers should be administered in most cases. In such situations, beta blockers are used in high doses, in standard doses. They can also be used in low doses. They can be titrated. Everything depends on a particular situation and the decision of a doctor. But the need of use of beta blockers at stage 1 and stage 2 is quite definite. Let me also draw your attention to another combination. That's step 2 in the standard group. That's beta blockers and dihydropyridine blockers of calcium channels. This therapy, and it's quite obvious for us, will have a stronger impact on blood pressure. Of course, one of the most important functions that beta blockers play in patients with coronary heart disease is the control over the heart rate, because patients with the coronary heart disease have a higher frequency rate, higher heart rate, and that's an independent predictor of death. And here it is quite obvious that there is a need to control the heart rate in patients with coronary heart disease. Let me also just draw your attention to this very interesting analysis of different studies which compared how heart rate control and blood pressure control have an impact on the cardiovascular risk. It turned out that the situation when we have high heart rate and uncontrolled blood pressure is the worst. The best situation is when the patient has low heart rate and well-controlled blood pressure. But it is also important that in this analysis, we have shown that the high heart rate and well-controlled blood pressure leads to the situation when we have the worst position, let's put it this way, when we control nothing. In fact, we see that there is a need to control the heart rate, and of course it should be done not in patients with coronary heart disease. We've been doing this for a long time, but also in patients with blood pressure. But when we with high blood pressure, but when the question is what should be used for this control, of course our choice should boil down to beta blockers, because, and Gregory has already mentioned it, naturally the impact of beta blockers on the heart rate is quite favorable, and of course this can be done through impacting hypersympathicatonia. Hypersympathicatonia plays an important role in all pathological processes happening in case of coronary heart disease or hypertension. Of course, we should opt for highly selective beta blockers such as Concor, bisoprolol. Concor is good because it has a very good ratio of the end peak index, and it can allow us to control pressure and the heart rate within a 24-hour period, and it does it quite evenly. We have a lot of data testifying that the severity of ischemia goes down. Episodes of ischemia are reduced in patients with stable ischemic heart disease, and also there are data showing the change in the ischemic depression, which is being improved. So bisoprolol is a wonderful anti-ischemic drug. At the same time, the drug acts as a hypertensive medicine. That's also important when we're talking about patients who have both coronary heart disease and hypertension. And the second stage is shown here, standard therapy, when there is a need to use beta blockers and dihydropyridine calcium antagonists. And of course, here, COR-IM can be very attractive. The drug has shown good results in terms of lowering blood pressure. At the same time, this can trigger antihypertensive mechanism as well as anti-ischemic, which is also important. And this combination, besides control over pressure, has a good action as a cardioprotector. And the last question is the one related to the place of beta blockers in current guidelines on chronic coronary syndrome. They are not limited just to their anti-ischemic effects, but it is quite clearly stated in new guidelines that beta blockers in some cases, and there are lots of cases like that, are also drugs improving pressure. And once again, here we're talking about selective beta blockers, sympathomimetic activity, and you can see the results of different studies allowing us to say that yes, beta blockers have a positive impact on cardiovascular risk. And in conclusion of my presentation, I would like once again to draw your attention to this group of drugs. They're not just hypertensive, but beta blockers can be applicable in other situations, and they are a must in patients with coronary heart disease, in patients with hypertension, when these conditions are separate, but when there is a combination of such conditions. Beta blockers are the most important class of drugs for treatment of our patients. Thank you for your attention. Oksana, thank you so much for this detailed approach to the use of beta blockers in such patients. We keep getting questions. We'll have them answered later. Now I'd like to give the floor to Olga Ostroumova. Fixed combinations of beta blockers and a clinical case. Despite the fact that all recommendations stipulate we should use fixed combinations because patients have a better compliance, anti-hypertensive effect is much better here. Not always such fixed combinations are used in clinical practice, so we need to share our experiences, and of course the fixed combinations are our future. So Olga, now the floor is yours. Well, good afternoon, distinguished colleagues. I am Professor Olga Ostroumova. I represent the Russian Medical Academy of Continuous Medical Education. Welcome to my presentation. Today I have a clinical case of a patient with hypertension and coronary heart disease. But before we get down to the clinical case, I should say with sorrow, much to my chagrin, that despite all our efforts and despite our achievements over the last several years, coronary heart disease continues to be number one reason for deaths. It is ahead of a stroke, which is number two, and as you can see it here, and it is ahead of diseases in the third and fourth place, such as the infection of lower respiratory tract. Well, hypertension is one of the comorbidities in patients with coronary heart disease. I should say that I represent the first department of Russia, the Department of Polymorphism and Pathology, and our academy has made a major step forward because, as Mikhail Yurovich said, this patient usually is polymorbid patient, and that is why we're not surprised that in more than 80% of patients with coronary heart disease have hypertension accompanying CHD. And in fact, 20% of risk of myocardial infarction is due to hypertension. If all risk factors are 100%, then 20% of all risk factors are due to hypertension. Now I'd like to draw your attention to our patient, a man, 56 years of age. During the last 10 years, he's had arterial hypertension. Right now, his blood pressure up to 150/95, which is grade 1. well, and when the blood pressure was measured in the doctor's room, it was the same, 150 over 95, and the patient has crushing pain in the left chest, especially when he walks up the stairwell to the third floor and when he walks quickly on the street. So it was coronary heart disease, which was diagnosed several years ago. Met profit moral contract was administered, double antihypertensive therapy. It looks like it's right because the patient is of high risk, but later I will go into details. Atorvastatin 10 milligrams, Activin was not administered, and the dose of metoprolol contract is not tightened. The pulse is 84, angina persists. So as you can see it here, this patient, due to the fact that the glomerular filtration rate is a bit low, 58, well, you can see it here, has this kind of pressure, 155 over 96, plus he has obesity grade 1. Well, if we have a patient with hypertension, but which is not complicated, but the patient has comorbidities, we must start with combination therapy. Moreover, as you know, in recommendations, it is stipulated that it should be a fixed combination, but at the bottom there is a caveat saying that the administration of beta blockers should be considered at any stage if there are specific indications for that. One of them is coronary heart disease. That is why here there is a mistake in the selection of a drug. On the one hand, the beta blockers are administered the right way, but on the other hand, bringing to bear that the patient has angina, we should have chosen a different regimen for first-line therapy. Why do guidelines stipulate fixed dose combinations? That's a very serious step forward. In Europe, taken in 2018, also in 2020, Russian recommendations appeared under the auspices of the Ministry of Health on managing patients with hypertension. I also participated in the development of such guidelines, also meta-analysis, and one of them is in front of you, have shown that compliance is higher in case of fixed dose combinations. That means the pressure is lower and the cardiovascular risk is lower. In recommendations of arterial hypertension and ischemic heart disease, you can see the clinical recommendations which were published in 2020 under the auspices of the Ministry of Health. Here we're talking about the targeted level. Yes, our patient is under 65, but he has chronic kidney disease. The glomerular filtration rate is 58, and of course the target level 36, it has here 55 over 95. 155 over 95 is his blood pressure. Also, patients with hypertension and angina symptoms are recommended to have beta blockers or calcium agonists administered. Beta blockers cannot be combined with calcium agonists. They lead to AV block and bradycardia. So as plus, sorry, only hydroperidine plus calcium antagonists, hydroperidine and non-hydroperidine have good atherosclerotic effect, vasoprotective effect, which is important for such patients. Yes, they are on statins, no one argues about that, but nevertheless, these patients also must get drugs which have a positive effect on lipid metabolism. Similar guidelines exist in Europe, especially the European guidelines of 2019, as far as coronary heart syndrome is concerned. Most patients with angina should get beta blockers or calcium channel blockers. That's step number one. Step number two, like in our case, beta adrenal blockers with dihydropyridine, calcium antagonists. Then second line drugs will be added. Well, this is applicable to patients with the high heart rate and other patients as well. Well, we can see that there is a hypersympathetic tenia in our patients. Well, the heart rate is more than 80 at rest. It's a very simple but also a reliable system of hyperactivation of the sympathetic nervous system, and this hyperactivation leads to the higher risk of major cardiovascular events in patients with the ischemic heart disease, such as a stroke, MI, and death. And this has been shown in the retrospective TNT analysis with 9,000 patients included. They were divided into two subgroups, heart rate 70 and more and less than 80, and treatment of coronary heart disease. In this case, there were lesser levels of heart rate, also an increase of heart rate by 10 beats per minute increases the risk of MACE by 8%, and vice versa. A reduction of the heart rate has a cardioprotective effect. If the heart rate is elevated, the diastolic filling time is reduced, myocardium has more pressure, there might be heart murmurs and angina. When beta blockers are administered in adequate dosage, we reduce the risk of heart death, coronary death, all-cause mortality, as well as the number of relapses of non-fatal MI is reduced due to beta blockers. And, well, we can see that the reduction of the heart rate by 10 beats reduces by 30% the relative risk of death from coronary events in patients after MI. Also, you can see some other publications on this slide, and these are patients with stable coronary heart disease, ambulatory monitoring for 48 hours, hypersympathetic tonia predicts the acute ischemic event, because an hour before an acute ischemic disease, there was a significant increase of the heart rate, which has been shown in this study. The statistically important hyperactivation of the sympathetic nervous system increases the risk of death from cardiovascular disease and all-cause mortality. Another study is the long-term follow-up of patients within one big registry of surgery on coronary vessels, 25,000 patients who have been monitored for 15 years on average. You can see that with an increase of the heart rate, the overall mortality increases, as well as mortality from cardiovascular diseases, especially when it is over 80 beats per minute. Here it's 83 and higher, but it should be not more than 80. 81 beats per minute is already a lot, but that's the maximum in patients with stable coronary heart disease should have a lower heart rate by way of beta blockers. Well, just in case, in this study, the prognostic value of the heart heart rate at rest did not depend on hypertension, on smoking, on the left ventricle ejection fraction. So this is an independent risk factor. We understand it perfectly well that in China is the leading symptom of coronary heart disease, and of course the reduction of the number of angina can be very important, and beta blockers play an important role here. Beta blockers reduce the risk of cardiovascular death in this group of patients with stable coronary heart disease. There was a prospective multi-center study with the inclusion of more than 4,000 patients. These were patients with stable coronary heart disease. They had a history of MI or a revascularization a year ago, or they had the obstructive damage of at least one coronary artery. You can see that those patients who were put on beta blockers had a reduction by almost 60% of the risk of death from cardiovascular diseases. And naturally, it was shown that beta blockers are very effective in reducing the frequency rate of cardiovascular diseases, especially after MI performed by using PCI. Maybe in case of PCI, beta blockers may not be administered. It's a stumbling block, but the answer is no. Beta blockers can be administered also after PCI, and you can see the analysis is showing that where beta blockers were used, the mortality rate was lower. Our patient didn't have a function yet, but anyway, another study showing that the reduction of sympathetic hyperactivation by using beta blockers reduces the frequency of heart death. These are the meta-analysis of 17 randomized studies, and not just reduces the frequency of non-fatal MI, but also reduces the frequency rate of sudden death. This is not a very well-studied problem. I mean, the problem of sudden death among patients with coronary heart disease. Men are in the risk group in this case after MI, and it was shown in the Russian registry that every third patient with coronary heart disease dies from sudden death. Well, here you can see modern beta blockers, highly selective, metabolically neutral, contributes to the slow down of atherosclerosis in coronary arteries. The thing is, and this work was done way back in the 1970s and 1980s, sympathetic hyperactivation is not just increasing the heart rate and the pressure, it's hyperactivation of platelets and the quick progression of atherosclerosis. No wonder that beta blockers lead to the situation when the progression of atherosclerosis in such patients slows down. Although, of course, no one says that statins should not be administered. It's quite the opposite. Thus, we can say that beta blockers have a prognostic positive impact on patients with coronary heart disease due to pleiotropic effect. These are drugs with multimodal mode of action. A sympathetic tone should be taken into account, and to sum up, I should say that such things as the atherosclerotic plaque, the reduction of recurrent infarction, while increasing the threshold for AF, and that's modern scourge, reduction of platelets, reduction of the demand of of oxygen by myocardium and issues related to impacting diastolic filling. Also, there is a reduction in arrhythmogenic fatty acids, which leads to a better redistribution of coronary blood flow. And here, bisoprolol can reduce the heart rate and also the frequency rate of ischemia in patients with angina. Here you can see patients with stable coronary heart disease, which were on bisoprolol once a day, 10 milligrams. There was a reduction by 30% of ischemic episode and reduced the duration and the severity of such episodes. There were comparative studies of nifedipine, calcium antagonist. You can see that both drugs are first-line drugs according to modern guidelines on managing patients with coronary heart disease. But nevertheless, the reduction was much more significant in the group on bisoprolol, from 8.1, the number of episodes over 24-hour period of myocardial ischemia, from 8 to 3, 2.3, bisoprolol 3.3, nifedipine to 8.6, to 2.6, sorry. So the difference was twice as much. Although this was nifedipine, long depot nifedipine, but we can see that bisoprolol protected the patient thoroughly during a 24-hour period. As for nifedipine, the effects were quite different. Naturally, when we looked at long-term outcomes, you can see that the frequency of adverse events was higher in the nifedipine, depot nifedipine, 32 as compared to 22% in patients on bisoprolol. These are statistically reliable data. Colleagues, I've shown you this study so that you could see the power of the anti-ischemic effect of bisoprolol. The optimal is a combination of beta blockers with high pyridine calcium antagonist. It's better to administer one pill a day so that we could achieve the maximum effect. Here is another interesting study. Well, newly diagnosed coronary heart disease in patients. They were divided into two groups. One was put on bisoprolol, others on beta blockers, but a different type, and the third group got other antihypertensive drugs. And here is the death rate. Bisoprolol has specific advantages. They were preserved during the 10-year period. Moreover, this primary endpoint was reliable as compared to other drugs and as compared to other beta blockers. Moreover, in the first 2 years of therapy, there was a reduction by 80% of this risk in patients on bisoprolol compared to other beta blockers, and by 60% as compared to other types of antihypertensive drugs during the first 5 years. Moreover, in time, there was a clear reduction of the arrhythmia in patients with bisoprolol as compared to other beta blockers and as compared to other antihypertensive drugs. There has been a significant reduction in the number of angina cases, like in this case, in the bisoprolol group as compared to other beta blockers and compared to other classes of antihypertensive drugs. That's a wonderful study showing that beta blockers are leaders in this class, and bisoprolol is the best. The patient has a myocardial hypertrophy, long, depot hydropyridine can be administered here. Diuretics and beta blockers, they do not have this kind of effect. Bisoprolol, in fact, had a good impact on the myocardial mass. It was equal to enalapril, and it reduced myocardial mass index than enalapril. But on the other side, this difference was not statistically significant, so we can make the conclusion that both drugs were equal. But at the same time, beta blocker is the same as ACE inhibitor. And of course, it's due to the fact that beta blocker is very lipophilic. Hypersympathetic atonia is one of the mechanisms of myocardial fibrosis, and antihypertensive therapy based on bisoprolol, these are our data, in fact, improves the parameters of the stiffness of myocardial of the left atrium, the strain of left ventricle, you can see it here, and this means that our patients, when bisoprolol is administered, will be protected from the development of heart failure, and that's important for us. Hypertension and coronary heart disease are the most widespread things in patients with heart failure. And finally, I would like to remind you that we have wonderful fixed combination, Concord AF, and of course, it's important to administer this to our patients with hypertension and coronary heart disease. There was a study on more than 10,000 patients. They were converted from free combination to fixed combination. In most cases, the dose remained the same. The fixed combination was Concord AF, and as you can see it here, compliance increased. 84% of patients who were switched from free to fixed combination didn't have to change the dose, but 98% out of 10,000 patients, when fixed doses were administered, showed very good adherence to therapy. Adherence or compliance was the main goal of this study. So you can see Concord AF reduced the pressure, pulse pressure, which means that the vessel wall becomes more elastic, and also you can see it reduced the heart rate. All the parameters were achieved, and of course we had control trials in 3 and 6 months of therapy. What about adverse events? They occurred only in 0.7% of cases, and bisoprolol is the leader in its class, and bringing to bear that the patient has obesity, allodypin, and bisoprolol should be the best drugs. In this case, Concord AM was chosen for our patient, thus allowing to achieve the target level of hypertension, and the patient became more tolerant to physical overload. Thank you very much. Olga, thank you very much for your presentation. We just have some time for questions and answers. Let me voice some questions. I know, Grigory, you have to switch over to the next room, but I'd like to ask Gregory the first question. Gregory? Yes, I am all ears. Gregory, well, the question is for you. If the patient is switched over from one beta blocker to another beta blocker, should we start titration with small doses so we can switch the patient to high doses right away? Or when beta blockers are changed, we should start with small doses? I think we should start with equivalent dose, see what might happen when you stop one drug and then resume with small doses. Beta-1 receptors, if we're talking about selective blockers, well, the sympathetic nervous system can be agitated and you will have a tachycardia. So small doses are inadmissible. You should start with the equivalent dose and pay attention to another important question, the half-life of your drugs. What drug the patient had before and what drug you'd like to put him on. Hopefully you do it with the drug with the short half-life and you switch a patient to bisoprolol, for example, once a day. It has the longest half-life, one of the longest half-lives. So you should take all these two aspects when you switch over the patient from one drug to another. And ask yourself a question. Why do you replace one beta blocker with another one? Low tolerance, poor effect, maybe the dose should be changed. Well, usually it's, well, not a good idea to switch drugs. You should think 100 times. Well, there is another question concerning why should we do it. We're talking about the choice between bisoprolol and nebivolol stimulating the synthesis of nitrogen, vasodilating effect. Can it be a pretext to change beta blockers in case of hypersympathicotania? Bisoprolol is a wonderful drug. It was studied on 2 cohorts of patients with hypertension, and it increases the level of nitrogen oxide. It improves the function of the endothelium, and there is stimulation of beta-3 receptors. Patients with obesity, with abdominal fat, the stimulation of beta-3 receptors is very important. In this case, white fat turns into brown fat. That's very important when we are talking about this. It will be quite reasonable to switch drugs. Also, patients with preserved ejection fraction and the drug also showed good results here, but bisoprolol showed the highest percentage of reduction of the risk of death in patients, of sudden death in patients with poor circulation, 46% improvement. So I wouldn't change drugs unless I don't understand that particular niche where I can get a result. If we want to combat sudden death, bisoprolol. If we want to have some effects of beta blockers, nebivolol would be the best option here. If there are other niches, again, weigh pros and cons. What is better for you? All beta blockers have a similar effect, improving the endothelial function and reduces the effect of the sliding blood along the walls of the vessels. So once again, weigh all the pros and cons. If the patient has ischemic heart disease, there is a higher probability of death. Thank you, Gregory. You can go. I guess you should go to the next symposium. A question for Oksana. The question is administration of beta blockers to patients with heart failure in patients with low ejection fraction when blood pressure goes down and patients have a less tolerance to physical exercise. The pressure can go down. What should you do in this situation? Well, Oksana is not online right now. I'll try to answer this question myself. The thing is that when we are talking about the administration of beta blockers to patients with heart failure, представим, что к нам пришел наивный пациент. Пациент, не получавший ранее бета-блокатор. Мы должны его дать, потому что это снижение риска внезапной смерти. Об этом сегодня много говорилось. Но мы должны обязательно учитывать месяц, период,
когда произойдет снижение, любой бета-блокатор обладает отрицательным инотропным эффектом, и в течение месяца будет происходить снижение фракции выброса за счет отрицательного инотропного действия. Именно эти эффекты могут спровоцировать, например, возрастающее число госпитализаций на фоне старта терапии бета-блокатором у пациентов с ХСН и низкой фракцией выброса, могут спровоцировать снижение цифр артериального давления и даже могут спровоцировать какие-то субъективные ощущения слабости и чего-то подобного. Но мы должны очень хорошо понимать, что если мы этот месяц аккуратной титрацией, ни в коем случае не резкой, аккуратной титрацией преодолеем этот месяц, то выгода от назначения бета-блокатора будет очень значима. Мы достоверно снизим значимый процент, значимый риск внезапной смерти этого пациента, имеющего ишемический генез повреждения миокарда. И это показано в серии больших исследований СИБИС, Комет и так далее. Здесь интересный момент. Один из субанализов исследования Комет показывает нам, что если мы попытаемся, даже если произошло это ухудшение, если на фоне этого ухудшения была госпитализация, и мы попытаемся отменить бета-блокатор, то такой пациент...
with that, and we try to cancel the beta blocker, this patient during hospitalization will have the most negative outcome. But the best outcome will be the patient who, despite hospitalization, kept his beta blocker, although slightly reduced. Of course, if in this matter they were talking about kleptoids conditions, given the sharp reductions of arterial pressure, it's a matter of corrective therapy. And not only that, but concomitant therapy as well. If we're talking about classical inotropic effect that is caused by beta blocker at the onset of its use, it's an expected good effect, and largely speaking, the doctor should be ready when he administers this beta blocker to the patient with heart failure. Well, in fact, we should be confident that these administrations are justified, and in chronic heart failure, we can't deal without beta blocker despite this monthly interval when there's a negative inotropic effect. We'll have 10-15 minutes of a break now until 3:30 Moscow time, and after that, we'll go back to the symposium. Before we interrupt for the break, let me announce what we are going to have. In Moscow Hall, we'll have a symposium on anti-hypertension therapy. Moscow is this particular hall. We'll still cover hypertension, and we'll talk about the obese hypertensive patient and protection, etc. In St. Petersburg Hall, innovative technologies in treating rheumatic diseases. It's a symposium by academician Mazurov, and he will convey a number of complex issues that any therapist is encountering in his practice, like Schenlanger disease, development of fibromyalgia symptoms and treatment. In fact, this is the paramount of the differential diagnosis any practitioner would face as he works in inpatient or outpatient units. And last but not least, in Perm, there will be an interesting symposium. Interesting in the context of our days, treatment of infection and lessons learned from pandemics, antibacterial multi-component treatment for severe patients will be spoken about, and a COVID infection presentation will be made. Infections of urinary tract, we should keep it in mind because the patient might have a powerful reduction of immune response, and he might have urinary infection. And last but not least, coronavirus realia from the perspective of antibacterial therapy. The question is what is going to happen with antimicrobial resistance, AMR. In St. Petersburg, we're going to speak about complex differential diagnosis. Break, see you at 3:30.
ваших руках возможность замедлить прогрессирование хронической сердечной недостаточности. Какова цена промедления?
день, уважаемые коллеги. Для всех мы продолжаем наш эфир. Для всех, кто к нам
Hello, dear colleagues. We would like to continue our broadcast. This is Moscow Hall. We'll be speaking about hypertension symptoms, course, metabolistic syndrome, concomitant pathologies. In St. Petersburg Hall, there's a symposium on complex issues of rheumatological diseases, and in Perm, we'll have a large symposium on the lessons learned from AMR and antibacterial therapy given COVID-19 pandemics. What is the AMR we're likely to face? Let's now turn to Moscow Hall and the symposium we're having at the moment. We'll be speaking about different aspects of arterial hypertension. In my introduction, I reminded that among the large scientific research conducted by Eurasian Association of Therapists, there was a Hyperion registry, which among other things studied the state, the condition, modern condition of the disease and who is that patient that we're facing today. We'll be speaking about it, and the word for the first presentation is given to Grigory Arutyunov. He'll be speaking about the most recent guidelines on the treatment of arterial hypertension. The floor is yours, Dr. Arutyunov. Thank you so much. I'd like to note that the recommendations have changed the methodological approach of a therapist who is trying to rethink his therapy of an arterial hypertension patient. There is a notion of corridor. Green corridor is a young hypertension patient. For him, the target desirable pressure is up to 120. The key word is highlighted in yellow in this green corridor, if he tolerates. The overwhelming majority of the patients will not be tolerating because they developed critical or subcritical stenosis of carotid arteries, and we may worsen their condition. Red corridor is an elderly hypertension patient, 65 to 79 years old. The desired pressure is at least 140, but not below 130. Critical condition is if he tolerates. The key changes in the line below, the light blue line, the level of diastolic pressure, 70 to 80 to 70 millimeters mercury bar. The vertical bar shows the phenotype of the patient. It's arterial hypertension plus diabetes plus renal failure, a transitory ischemic stroke, coronary heart disease. This is important to say that in almost all situations, we see the desirable levels of arterial pressure. This is the first approach. Second important approach is the understanding of the fact that a patient with uncontrolled hypertension or poorly controlled hypertension has, as a rule, two ages. And we have two ages, basically, biological age and our age by passport. But a patient with AH is biologically older than his passport figures. This is very important. He has accelerated aging, and treatment of arterial hypertension is aiming at active longevity. Third question, if we have this notion of active longevity, can we describe it by symptoms? Yes. And they introduced the EVE syndrome, early vascular aging. Early vascular aging defines the biological age. We need to clearly understand how far you have gone in aging biologically in comparison with your passport. Unfortunately, hypertension patient is usually older than his passport age. Why is this happening? Let's look at these curves. On the right, you see the arrows showing the flow of blood in aorta. The big arrow shows the pulse wave reaching the aortic bifurcation, hits it and reflects. Part of the energy reflects and goes back. Let's hear this. It goes back along the vascular wall back to the aortic arch. The thicker the wall is, the sooner this pulse wave returns. So when it returns, what is it going to do when it is back to the aortic arch? If it returned early because of angina, it will join the flowing aortic arch, and there will be an augmentation of flow there, and there will be a spasm of coronary and cranial arteries, and it may cause rupture. If it goes back to the normal rate of heart contractions, that is a norm. But it's very important to understand that this is a hazardous combination of two things: angina and a rigid, a stiff vessel. You are as old as thick your vascular walls are. I mean, the main lesions, of course. I want to show you this slide for you to understand the scale of the program. At the initial systolic pressure 160 to 180 of an uncontrolled arterial pressure, your biological age is 20 years older than you actually are. So when unfortunately a 50-year-old person with uncontrolled pressure dies, we say, oh, he died so early, he didn't live that long. But keep in mind, he wasn't 50. Passport-wise, he was 50, but he was much older. He was 70 years old. And there's a first strategic question here. If we understand the role and scale of AH, 43 million people worldwide have elevated arterial pressure. What should be done? How do we treat it? What is a changing lifestyle to this patient? The first thing we should tackle is losing weight. We have to normalize patients' weight. Please try to take obesity as pathology, because excessive body mass and fat in non-traditional places of its deposition, pericardium along main lesions, it changes the prognosis of a patient. We'll have three slides, green, red, and yellow. In green, we should give a recommendation to the patient. If you tell him eat less, walk more, he will never come back to you. What is the number of calories for men and women? It differs by age, by sex. You should calculate this main parameter. The blue slide, find out who your patient is, where is he working. Number 3 is, for example, he's doing a heavy physical job, multiply by 1.5. If he's working moderately, multiply by 1. If it's a housewife, don't multiply. Out of these 3 slides, you can calculate the figure of daily spend of energy. Let's see how the number of calories can be reduced. The patient will not remember this. 1 gram of fat, any fat, is 9 kilocalories, whether it's oil, vegetable oil, or pig fat. 1 gram of carbohydrate is 4.4 kilocalories. Give simple notions of, for the patient, a piece of yellow cheese contains 12 grams of fat. Multiply by 9 is more than 100 kilocalories. It's a small bit of cheese that he ate. So we need to train the patient to reduce the calories. Give him simple examples. A tin of beer, 280 calories. Tin of Coke, 300 calories. Another counter argument is Snickers, 550 kilocalories. A military officer with his ammunition weighing 20 kilos walks 80 steps per minute, and he is spending 250 kilocalories. So the first thing is to reduce calories. In the beginning, the weight is lost easily. This is wonderful. First 3 months, he's losing weight, then he slows down. By month 6, you need to make a strategic decision to explain that if you lost 10% of your body mass, you need to retain it. If you didn't lose 10%, let's worsen the quality of life now to have a better and longer life in the future. Second advice, what should the patient eat? There are 2 proven diets, Mediterranean and DASH diet. The notion of Mediterranean diet, the point of it is not the red wine as they used to say. It's only 1 glass of red wine. There are 3 key things. Source of fat is vegetable oil. Try to understand. Make the patient understand that it should be olive oil in the dark bottle. Second, it's the non-refined flour, and fruits and vegetables. Why fruits and vegetables? Because there's an inflammatory index of food. Red meat and fat is one maximal pole. Fruits and vegetables is the minimal pole. The higher the inflammatory index of food is, the higher the inflammatory index is. The diet itself is aiming at reducing the risk of atherosclerosis. Second diet is DASH diet, when salt consumption is controlled, not more than 6 grams of salt daily. But the main source of salt in our life are industrially manufactured products. Even 3 bits of pieces of black bread contain 30% of the daily norm of salt. So the advice is controlled salt consumption, switch to homemade food. This is a patient with excessive body mass. Just imagine, what will this excessive fat do to him? Just imagine that you are drawing the domes of diaphragm. Diaphragm went up, and if he lies down, he will have apnoea, sleep apnoea, and he might die in his sleep. And this is a bad prognosis. He will have proliferated atherosclerosis. Probability for 40% he has hairless feet. It's a sign of multifocal atherosclerosis. When you look at this patient, put down waist and hip sizes, divide these both, waist by hips, and if the ratio is higher than 0.85 or 0.9, imagine the type of fruit you have. If your patient and his body reminds an apple, or apple is a morbid obesity. If your hypertension patient reminds an apple, he needs to lose weight. Look for black acanthosis. This is a 100% manifestation of insulin resistance. Continue analyzing the phenotype of a hypertension patient. A hypertension patient with metabolistic syndrome, big waist, failed lipid metabolism, arterial pressure failure, glucose level. All these are problems, and until you correct them, they will support hypertension. Go back to fat. Look, vertical cross-section shows you the fat of abdomen. Well, normally there should be omentum and the interintestinal space. In capsula adiposa, we have excessive fat. It squeezes kidney and it disturbs the venous outflow, pericardium. The mid-size on CT cross-section shows you white triangles. This is the fat along the main lesions. In capsula adiposa, the fat is just suppressing the kidneys. It supports a high level of renin-angiotensin testosterone system. And the biggest challenge is to achieve the reduction of this fat, either by thermogenesis or to reduce calories and consume this fat. But this is the challenge, not a medication problem. First of all, it's a correction of excessive fat located in wrong places. Red line is pre-diabetes. If glucose is 6.1 in the morning, it's very high. Until you normalize it, it will be hard to control pressure. This is the fourth innovation in the last guidelines, is the algorithm of patient management. The principle is 1 tablet and 3 steps. We are in, look at green bar. We always start the treatment from combined drugs. Next to it, there's a blueberry color bar, which shows monotherapy. For whom? For the patients who are considered to be frail. You may give a mono drug to avoid orthostatic reaction. Doesn't matter what you gave, inhibitor or sartan plus calcium antagonist plus diuretic, etc. You give this combination, you didn't yield an effect in 10 days, you go to step 2, you keep 1 tablet. It's Philippine. It contains 3 active components: sartan inhibitor, calcium antagonist, and diuretic. 10 days later, no effect, you think it's a resistant arterial hypertension, and you need to add the fourth drug. Fourth drug may be any diuretic or alpha blocker or central action drug or alpha blocker. So in this way, you cover the maximum number of patients and you treat their arterial hypertension. So three main steps. The principle of one tablet, and on the third step, one tablet plus one more drug. A few words about drug classes. All antioxide diuretics were synthesized in middle of 20th century. They are all metabolized through kidneys. Look at the white arrows. They all eject a lot of calcium. And so the main conclusion is to not deviate the standard doses, because the excessive metabolism of potassium is endangering the patient. Hydrochlorothiazide, it's mainly used as a drug that influences the control of arterial pressure. In recent years, we had the notion of a high cumulative dose. This is higher than 50,000 milligrams of total cumulative dose. It takes long years of regular administration of hydrochlorothiazide. It's one of the most powerful drugs. It increases photosensibilization. It may bring to non-melanoma cancer and skin changes. Don't scare the patient. Nothing bad will happen to him. Just warn him that he doesn't need excessive insulation. He needs to use the sun creams, etc. And if he sees any changes on the skin, he'd better not to neglect it and go to the doctor. Indopamine and clopelodone proved their impact on the cardiovascular outcome, and this is very important for us. But all these diuretics, thiazide diuretics, shouldn't be administered if creatinine level is above 1.5 milligrams per deciliter. Second class of drugs are sartans and AGF inhibitors. They control the activity of renin testosterone system. 30 years ago, the research began in this area, and they led to the notion of a renin testosterone system. I want to say that out of these three small bars, it converted into this complicated scheme. But look at the key things. Look at the light blue rectangular APF, APF2. This is the key player of this system. And this is an angiotensin transforming enzyme. If you give this ACE, angiotensin 1 doesn't convert to angiotensin 2, and then it means that there is no hypertensive action. If you give a sartan, sartan works on the level of receptor. It blocks T1 receptor, and even when angiotensin 2 is synthesized, it cannot bind with this receptor. When you administer an inhibitor, you can't say you treat with an inhibitor. You need to understand which particular inhibitor are you treating with. Only two of them have 16 and 24 hours of metabolization. Not all of them have the same capacity to penetrate the tissue and work with tissue. In a red rectangle, only 5 molecules with high penetration capability. If you are working with sartan, you need to know its properties. At the moment, there are 8 sartans that are realistically used. These are most frequently administered ones. First thing to keep in mind, they all impact the deformed myocardium, more or less, but they are more effective than other classes of hypertensive drugs. They are metabolized in liver, and this is something to be considered when we discuss the patient and discuss his conditions and liver metabolism. MPVS and sartans shouldn't be administered together because it takes away 20% of sartans activity. I'm talking about uncontrolled administration and taking of the drugs, especially among elderly patients who want to kill the pain. Keep in mind that all these drugs can increase the concentration of digoxin in blood. The choice of drugs is based on the key notion. Look at the last column, two figures. First figure shows you the time of the amount that's metabolized through liver, and the second figure is metabolization through kidneys. You need to know if the liver function is okay, kidney function condition, and then you need to decide the drug. If both kidney and liver are fine, then you choose the drugs with 50-50 break of metabolism. If you choose sartan, keep in mind that it has the same effect as enalapril. The patients who do not tolerate inhibitors, sartans give a reduction of MI and stroke. Sartans all have can prevent the development of terminal renal failure, and they can reduce proteinuria. Look at my hands. Microalbuminuria. It's a disease. Proteinuria. This is a disease. What if the patients don't have the microalbuminuria? Can we impact these patients? This study was conducted. It's called Roadmap. It enrolled the patients with diabetes mellitus, but they didn't have microalbuminuria. Look at the idea of this study: to do everything to avoid the development of microalbuminuria in this patient. It was very hard to enroll the patients in this study. At least one risk factor had to be considered, diabetes, etc., and to confirm no protein in urine. The patients were randomized in two groups. One got 40 milligrams of the drug, second group got placebo. 40 mg is quite a big dosage. It was given to the patients. And then the target was to reach the controlled arterial pressure of at least 138. They were looking at the time in both groups before microalbuminuria appears. It's a unique group of patients. There are so many patients with diabetes with no protein in urine. Can this disease be avoided? The group that got alomisartan had a reduced risk of microalbuminuria by 20%. Look at the red line, how early it differs from the yellow line. It's a unique finding for our patients. Look at the discrepancy between the 2 days, two groups, and we actually won about 4 months in emergence of microalbuminuria. This is the average figure. Some had even longer. So albumisartan is so far the only sartan that proved the possibility to avoid microalbuminuria, to prevent it. You may say that you know renal, IRMA, IDNT studies that also studied sartan, and they didn't give an improved forecast for kidneys. It's true. But these were the patients who already had protein in their urine. But I said that in that study that I mentioned, there was no protein in urine. For this reason, it was unique. And we proved the efficacy and reduction of arterial pressure. Look at the starting dose of this drug. Unfortunately, in this study, I have to say that we had 15 versus 3 cardiovascular lethal events. And when they calculated who are these 15 patients who died in the group that got a sartan, we found out that 11 out of these patients were patients with severe ischemic heart disease. So I would like to ask you, when you start treating with this drug, please note that this drug indeed prevents microalbuminuria, but you need to cautiously choose starting dosage. High dose has side effects, of course. Apparently, the excessive reduction of arterial pressure in dose led to these negative events. So the starting dose should be titrated, and it should start from 20 mg. The drug that we're talking about, olmesartan, has its biological features. Look at the blue field. It's the period of metabolization, 10 to 12 hours, 50-50 metabolization through kidneys and liver. And so the patient with no pathologies of kidney and liver can choose this. For him, you can choose this drug. Olmesartan is in top 3 drugs by its semi by its half-life period. Is there a critical period? It's the night time. In night time, the drug taken once should control arterial pressure. If you achieve this control, of course, you achieve success. Olmesartan indeed controls pressure in night time. That is to say, the idea is not only in a powerful reduction, but a smooth 24-hour control of arterial pressure. Olmesartan is also described by a number of other effects that are hard to be explained, but were observed in all studies. In particular, highly sensitive tumor necrosis factor, and once they reduce, the pressure goes down. Most probably, it's the effect of endothelium level. You open periphery, you reduce the load on left ventricle and myocardium. But the second effect that was observed in 2 studies is the impact on the platelet size. There were no unanimous explanations. There were several explanations. When you normalize the arterial cavity, you improve endothelium function and it becomes less prone to inflammation. So the platelet is more robust and the core is squeezing by shrinking in volume, and it decreases the risk of rupture. Today they speak a lot about combined drugs, and the first drug that was combined with inhibitors was amlodipine. It was a very interesting step. The amlodipine, does it increase the heart rhythm frequency? No, but nevertheless, amlodipine was chosen because it had a proven efficacy in slowing down the atherosclerosis of lesions, of cranial lesions, and it reduces the probability of cardiovascular events. 42%, 31% reduction of cardiovascular diseases and mortality. The study that served as a basis to include this drug in the combined drugs, look, atenolol, beta blocker, adenosine, amlodipine, and perindopril. This study led not only to the reduction of systolic and diastolic pressure and reduction of new cases, it led to more significant things, to the changes of the central blood pressure. I started my lecture by saying that in the new guidelines, we have the notion of biological age in our patients. Biological age is the rigidity of your lesions. As soon as you change the rigidity of your lesions, you reduce the reflection wave, and it means that you stop increasing the pressure in the aortic arch. It reduces significantly the cases of strokes and infarctions among our patients. What is the percentage to which we cause the effect? Overall mortality, minus 11%. 16 years after this study, amlodipine proved its influence by reducing the cardiovascular death by 16%. Please pay attention to the inflammatory markers. We were talking about the unique unique capacity of the drugs to reduce the systemic inflammatory response. Once we reduce it, what do? We don't measure it every time, yes? We need to understand that reduction of systemic inflammation slows down the development of atherosclerosis. Two ideologies are facing each other in a direct study. The upper part is amlodipine and olmesartan are administered. Second part is hydrochlorothiazide. It's an important combination of two ideologies here. Look at the result. Approximately similar reduction of arterial pressure. But here you see slightly different things. At which particular week you achieve expressed nephroprotective effect. Nephroprotective effect means that you stop the loss of protein double the times when you combine olmesartan. You reduce double the times the loss of protein, and the longer the treatment goes on, the more proliferated the clinical nephroprotective effect is, and definitely the relevance of olmesartan is in reduced inflammatory response. Keep in mind that the main niche for this drug several years ago were patients with diabetes mellitus, with expressed systemic inflammation. It's an impact on central systolic pressure. I explained many times today how important it is to reduce this soaring pressure in aortic arch. It impacts the rate of infarctions and strokes in our patients. Olmesartan and amlodipine, or peridapril and amlodipine, give a significantly different clinical effect. And yes, olmesartan gives a significant reduction of blood pressure. The concept pump, pipes, filter. This idea means you shouldn't treat one thing. You need to give a drug that impacts the myocardium. For example, it relieves the load. You need to improve the lesions, endothelium functions, reduce inflammation, nephroprotective effect, save the kidney, protect from the loss of albumin. So pump filter is a good concept to be mentioned here. This is a SERVE study. Many therapists with different views about different drugs, and 8,000 patients get a combination of olmesartan and amlodipine. Look at the right side. You always achieve, in real clinical practice, you always achieve reduction of arterial pressure. Even patients with isolated systolic hypertension have reduction of arterial pressure level. And it is very good that the difference between systole and diastole is less than 60 millimeters. 60 millimeters mercury bar, aorta is not capable of stretching during systole, and it's not capable of shrinking during diastole. You don't have that blood outflow that is determined by evolution. You have a pulse type movement, and it increases the spasm of peripheral lesions. So the proven effect among these patients is quite relevant. Calcium antagonists and sartans, there can be many combinations of these drugs. I want to warn therapists, don't say this is better, this is worse. This is not true. All combinations are perfect, and for each combination you should find a niche of its own. Try to find a niche for telmisartan and amlodipine. The length of telmisartan action is up to 16 hours. For losartan, we have the most powerful impact on the hypertrophy of left ventricle. For valsartan, it works well for the multiple failure of organs. Irbesartan is good for the patients with initial patients with renal deformation. For olmesartan, there's a wonderful niche, patients with norm albuminuria. We want to prevent them from going to albuminuria. This is a big mission because microalbuminuria, which is really hard to detect, and you need to look by Stripe method or any other, it changes the life scenario. It's not a lab parameter, it's a parameter of quality of life and its duration. Microalbuminuria by 200% probability will increase the rate of cardiovascular disease. So the longer you preserve active life of your patient, the longer you prevent protein in kidney, and filters should be damaged for it to appear in kidney, basal membranes, etc. They all should be failed. These are big, serious failures of kidney. So by preventing these events, keep in mind the niche that is available for this particular drug, olmesartan. You can see the red combination with amlodipine, and this is a situation that has its application among the patients with arterial hypertension. Thank you for time and honor. Thank you for listening to me. Good afternoon again, dear colleagues. We would like to continue the symposium on arterial hypertension and comorbidities. I'd like to ask you to turn on my presentation. I'll make my speech, and during this speech, I'd like to dwell upon I'd like to describe a typical portrait of a Russian hypertension patient that we got during research registries in real clinical practice from Hyperion Register. Let's try to describe our patient. We are talking about not just a patient with elevated pressure. The hypertension patient is not just the one with high blood pressure. That's the approach. They believe that you reduce the pressure, it's all right. Unfortunately, this approach leads to the underestimation of the patient's severity and to a huge gap between our commitment to help this patient and to simply reduce his blood pressure. I want to speak about the principles and tactics of treatment for the patients with comorbidities. But let's go step by step, and let's try to take a multilateral approach to this problem. Let's try and speak about what we can do for our hypertension patient, who he is, and where is the critical mistake of underestimation of his severity. Statistics shows us, the figure is in green, but it should be red. 47% of deaths is associated with cardiovascular pathologies in Russia. If you break this down, you'll see that most of these patients began their pathological way as hypertension, simply increased elevated pressure. Later, atherosclerosis, ischemic heart disease developed, and then the patient goes to one of the cardiovascular outcomes, heart failure, stroke, acute coronary syndrome. We don't know what exactly may happen, maybe none, and the patient will end up in dementia, but we definitely know that he began his way as a hypertension patient, which means that hypertension is most often the first cardiovascular pathology which will drag as a locomotive the entire chain of cardiovascular events. This is the map that I've already shown you in the beginning of the day. It covers 67 cities of Russian registry of Hyperion. It's 1,500 patients randomly included in the registry in 67 cities of Russia. It allowed us to find out that there are no hypertension patients without comorbidities. If we want to find them, they amount only 10% of the cohort. Only 10% of hypertension patients don't have any other diseases. In 9 cases out of 10, they have atherosclerosis, some concomitant diseases. Second thing, these patients don't have a good lipid profile. We need to understand that if our hypertension patient lived in the tribes by the Amazon River, it would be different, but we live in modern civilization. Professor Metelska's study shows that even by the age of 35, patients have abnormal, healthy people have abnormal LDLP level. There was the third and most important discovery. There is no hypertension patient with normal body weight. BMI calculation of 1,500 patients showed that none of them had BMI less than 25. I'm not exaggerating. There were no patients with normal body mass. Let's try to figure it out. We said the entire country, we said a lot. Let's narrow it down to a normal patient and try to understand how he became a hypertension. How did he get hypertension? If we go deep to the youth of this patient, age 18-20, we'll see that he, first of all, lost the diversity of his intestine. He started eating in a Western European style a lot of carbohydrates, a lot of fat carbohydrates. The microbiota of the intestines is losing its diversity, and this always leads to the domination of the flora in charge of the intestinal function, which means that a healthy lifestyle and living in the countryside has a diversity 1,000 species. A person eating unhealthy, living in the city, he has less diversity, visceral fat, gain body mass, etc. This is the last thing when he has these worries. He doesn't notice that he develops the non-alcoholic fat liver disease. It's a protein that disturbs the LDLP destruction, and this patient develops atherosclerosis, and he's still young and he doesn't have hypertension. What's going to happen then? He will gradually move through insulin resistance mechanisms, moving to prediabetes. He will not find out about it because diabetes doesn't hurt, so does atherosclerosis. In women, there will be polycystosis of ovaries. Men will have heart failure, and there will be ischemic heart disease caused by atherosclerosis. These patients have tubular interstitial tissue inflammation because they consume a lot of salt, and so this patient gradually goes into hypertension. Does he know about it or not? We don't know, but he already has atherosclerosis, hypertension, and it will lead him to additional risks. And extravascular non-cardiac risks will be ignited. Let's describe this patient. He has a risk of colon cancer probability 40% higher. He has a higher risk of becoming a second-type diabetes, especially if he's smoking, and he might have vascular outcomes or dementia. We know that this is his way. We definitely know that our hypertension didn't begin yesterday. He came with hypertension, but he came with so many concomitant pathologies, and unfortunately, we have to evaluate it all when we manage our patient. In fact, I'm trying to put our obese hypertension patient in the red triangle. Why triangle? Because a triangle has sharp angles. And our patient is endangered, and the triangle is red. It's a sign of danger. He is the hostage of three things: risk factors, heart failure, and hypertension. In this triangle, we have our patient. Let's try to find a solution. We described it: long-time disease, risk factors, etc., bad forecast. Let's try to break this pathological chain. how to manage the patient. The guidelines say not only you should administer therapy, but also try to convince the patient to modify his lifestyle. And we'll start treating him if the risk is high or it's life-threatening. It is so. Let's try to modify lifestyle of this patient. It's easy. You need to force him to do 10,000 steps a day, do sports 30 minutes 5 times a week, give up smoking, restrict alcohol without any doubt, not because it is full of calories, but also it creates additional vascular risks and pressure jump ups, strictly control arterial pressure, beat the stress, and have healthy sleep. Let me dwell upon sleep. Imagine English letter U. So here it's 7 o'clock and here it's 9 o'clock. Whatever is between them, it's a perfect green area. But if your patient slept less than 7 hours or less than 9 hours, he has increased risk of hypertension, diabetes, obesity, sudden cardiac death among men, and oncology among women. This is the result of sleep study. Well, if you're listening to me, think, how many hours do you sleep? Whatever is below 7 hours increases the risk. Whatever is less than 6 hours is a high risk. A doctor working his night shift is endangered. Of course, body mass index. We control body mass. It's an ambitious goal, hard to achieve, and several diets. DASH diet, Mediterranean, or MIND for elderly patients. Doesn't matter which one. What matters is the entire cascade of recommendations is sometimes given to the patients within 5 minutes. The patient nods. He says, yes, I will comply. Do we believe? Of course we don't. We all know when the patient says, yes, I will smoke less, I will eat healthy. As a result, 96% of the patients don't follow our recommendations. 4% do, and we need to work hard for the sake of them. But the others don't. Patients don't change anything, and they are aging. Grigory Pavlovich mentioned Adam Eve vascular aging. But in Hyperion register, we try to assess the biological and official age of the patient. The telomere is, and its shortening is accompanying accelerated aging. It's a normal process. It's a theory of programmed aging. We know that when telomeres are shortened and it will go down to half-life, the cell won't divide, or it will divide with a mutation. If we look at the figures, then any of us born in time with normal body mass has around 8,000 length of the circular segments. By 37, we lose 5,000 units, and then the telomeres start shortening slower. But the shorter they are, the higher the risk of mutation cascade is. Why am I saying this? I'm trying to look from a different perspective. It's not the disease that accelerates aging, but the risk factors. If we ask ourselves a question, what are the large scientific studies saying? By the way, Nobel Prize for telomeres was given in 2008. So if we look at the risks, it's hypodynamia, obesity and smoking, financial stress, job stress, mother stress, child stress, pregnancy stress, etc. If mother was stressed during pregnancy, the child will have shorter length of telomeres, and chronic diseases will lock up this pathological circle. So the higher the cascade of problems is, the faster telomeres will become shorter. Telomeres are getting shorter. Passport biological ages are differing. You have a 45-year-old patient, but in fact his biological age is 65 years old. He might have a bunch of diseases, and you see what is the difference of passport and biological age? Up to 20 years of difference, factual difference. So when at the age of 55, this man has a stroke, it was not 55, but 85. Simply this age came much earlier. Telomeres become shorter. It leads to a cascade of events, bipolar failures of personality, efficacy of chemotherapy, chance of oncology, and chronic kidney disease. All these events urge us to take a new look at this patient. We focus on risk factors. We spoke about 4 and 96%, but also we are trying to see what kind of medications we can give to this patient. Of course, vascular wall. The patient should be compliant. And of course, we should focus on renal function. We need to start therapy as soon as possible because at least we can impact on the last segment of the progression of chronic diseases that may accelerate the aging process. Let's try to train, educate our patients. It's a theme of one big lecture, but I will dedicate only one slide to it. Unfortunately, there are so many patients with hypertension that we almost consider it as a norm because every second patient has hypertension. The mission is to involve the patient, make him maintain self-controlled diaries. The more involved he is in treatment, the more conscious he is about himself. And so the more he hears about why he is drinking different drugs, the more he is concerned about his own condition. This increases efficacy and compliance. We should make a heavy focus on the kidney function of the patient. We need to clearly understand what's happening with kidneys. We all have a particular number of we all have glomera, but albumin molecules, by the way, these are the heaviest molecules that go through membrane. So it opens way to more heavy molecules, better to micro, better to macroglobulins. The glomera die and they are subject to atrophy. And because they die, the other glomera take their own function. It can't last forever. You can't have an infinite number of living glomera. They keep dying, and chronic kidney failure is progressing. So assess this patient, not without, you need to calculate glomerular infiltration speed, not some other methods. Only CKD, EPI. You can see on the slide that 3 different people with the same creatinine have different glomerular infiltration speed. So please keep in mind that you need to look at CKD, EPI. You assess and then you start treating the patient. What are we administering to him? Of course, we are going to speak about inhibitors or sartans. We will speak about the drugs with nephroprotective effect. But is it enough to administer? Because not always it solves the problem. We found out that the biggest challenge is in premature aging. Just give a drug and it will go away. No, it won't. Because if we look at the reality of arterial pressure control, it doesn't happen in normal conditions. Look, we took a focus group. We showed them different diaries and figures of arterial blood pressure. Deviations that were fixed were explained by any reasons or were neglected, and only there were some significant deviations. The doctor brought it to his attention, but look at the response of the doctor. Didn't take the recommended dosage or overdosed. The option of wrongly chosen therapy haven't been considered. You know, patients sometimes sometimes take drugs for years, but it was a wrongly chosen therapy. We need to change it. We need to revise it. These are European guidelines. We need to choose from the combined schemes. If we have a prone to ischemic heart disease, we choose beta blockers. If not, we give thiazide, diuretics, etc. We can't speak about everything. We're limited in time, but let's speak about calcium agonists. We spoke about kidney. Can we say that calcium antagonist has a nephroprotective effect? Most of them don't show significant reduction, although without any doubt, amlodipine, nifedipine, etc. are expanding the outgoing arteriola, but they do it by 8–10%. But this is not enough. It may lead to hyperfiltration. The situation is different when we are looking at leptinidine because it is capable of expanding ingoing and outgoing arteriola. And lercanidipine doesn't cause glomerular infiltration, it doesn't cause loss of albumin and albuminuria, and DIAL research that showed the slow progression of kidney function deterioration, and ZAFRA that assesses CKD and creatinine clearance and not glomerular infiltration speed. They all show the slowdown of progression. Surprisingly, this drug was administered above the titrated dosage of IBM. There's no problem in combining, and we must combine vercanidipine with IPF inhibitor because one effect doesn't exclude another protective effect. These are the studies available. On this slide, you can see the red label study with additional effects, albuminuria position. We know that this is useful from the perspective of lengthy therapy, and with calcium antagonists, there is a lengthy reduction of the risk of developing cranial cerebrovascular failures. Simodipine is strengthening the atherosclerotic platelet. It is shown in Camelot study. Here are the markers of inflammation. Part of them is going down significantly in the patients taking vercanidipine. And once we reduce inflammation, we cause protective effect on the lesion wall. Why lesion wall? It's important to know what's happening there. Look at this slide. Angio, IVUS, and intracoronary thermometry. You see part of the platelet highlighted in red. Red means inflammation. Imagine the last patient with atherosclerosis that you saw yesterday, a week ago or so. What is in his coronary artery? His platelets. Are they inflamed or not? Is he taking statins or not? This is a very important question because even at a very young age, the platelet may rupture. Old calcified one has less chances to rupture. And second thing is, if we're talking about CKD prevention, we need to focus on the condition of the lesion wall because any hypertension patient has this risk. We're not treating figures of pressure. We are treating the disease. We need to keep in mind that at the age of 36 and 40, the active inflammatory process in the platelet may rupture. A cranial event or any arterial event may happen. This is not excluded. We need to evaluate this patient. How? Of course, we use the tactics of blood parameter assessment. We're not treating figures, but the parameters should be convenient. Triglycerides, LDPDP, etc. LDLP cannot serve as a basis for detailed tactical development of the therapeutic strategy. That's why every patient, at least now and then, requires a detailed lipid spectrum. Remember the high level of lipids with patients with obesity. Once we evaluate it, we will treat the patient. How are we treating the patient? When we speak about beginning the therapy, we always have a choice. All drugs, no, they are not efficient. Everybody will agree. What will we focus on? Most probably we'll focus on statin therapy. Statins will form the basis, but the basis is not always definite. Statins can serve as a basis for therapy, but they might be continuation as well. We might have omega-3 fatty acids, reduction of the ventricular function failure, sudden cardiac death, defibrillators, isotinib therapy, because we know that LDLP reduction figures are hard to achieve on one statin only. These can be antibodies to PCSK9. It can reduce LDLP without causing inflammatory effect. It can be a new class, siRNA or MAO interfering RNA based on monoclonal antibody principle. It blocks, and so injections every 6 months block the PCSK9 protein. In case of true intolerance, there can be bempedoic acid with weak anti-inflammatory effect. We have a huge choice. At least on this slide, you see 7 drugs. Out of 7 drugs, we need to choose the suitable one. We must choose it for our patient. And let me answer the question in the morning. You can't solve the problem with a diet. If the patient develops ischemic heart disease, he will have an increased heart rate, diastole will become shorter, blood flow will become worse. This is not efficient. It's efficient when we are late or when we are in the gym, but it's not efficient in the patient. If we're talking about an event that this patient is likely to face, it's going to be coronary event. So if we conventionally divide his MI into 4 parts, the MI will kill one part of left ventricle. So part of left ventricle dies. So what does it lead? The rest will take the function of this dead ventricle. They take more function, they work harder, and more oxygen, they default. So part of the myocardium around will hibernate. Hibernated myocardium is the myocardium which is alive but is not working. And the load is getting higher, and we know that the ventricular rhythm failure and death are the risks for this patient. What can we do? We can give a beta blocker to the patient. The beta blocker, will it work a miracle? No. In the beginning, we will have a negative inotropic effect, but in a few months of therapy, we will see the effect for the sake of which we use beta blocker. Diastole is getting longer, and we remember that 75% of coronary are supplying diastole. Due to normal oxygenation, part of hibernating cells will become alive. They participate in heart rate, plus we protect the patient from death or sudden cardiovascular event. In fact, we're saving his myocardium, we're saving it in the area it should be in. It doesn't cancel what I was talking about before. It doesn't cancel the need of hyperlipidemic therapy. It goes on, but we strengthen it by the heart rate control. Beta blockers, we can choose any. In every specific situation, we'll choose a specific beta blocker. But keep in mind that obese patients, nebivolol will be of higher advantage for them because it synthesizes nitrogen oxide in the lesion wall. Let me remind you that if our purpose is to normalize vasorelaxation, make sure that the patient reduces the consumption of salt because potassium in the lesion wall can block nitrogen oxide and CMP. That's why administering the drugs doesn't cancel the changing of the lifestyle and restriction of salt consumption, which I didn't mention, but Grigory Pavlovich mentioned it in every detail. I want to say that our obese patient must be under protection of many factors. He should give up smoking, change the lifestyle, control LDLPs, and he must control pressure and renin-angiotensin system. We should administer multi-component therapy, and if there is ischemic heart disease, beta blockers. If there's dyslipidemia, we need to give hypolipidemic drugs. We need to change the geometry. Remember, this poor patient was put in the red triangle with sharp angles. Let's change the figure, the color, and let the red triangle be turned into a green, safe circle. Asylum of therapy the patient can get. It will be quite efficient, and let's keep in mind that this is a burden to be shouldered not by a therapist. It's an equally distributed task between endocrinologist, therapist, and cardiologist. Today, this obese patient with probable diabetes doesn't belong to one specialty. It belongs to the doctor he came to with his problems. And this doctor must start acting right now, administer the therapy right now, because that patient, and we have the tools in place, the tools are available, and the patient must get fully fledged therapy, not because of his blood pressure, but because of the concomitant pathology. The doctor must do it as soon as he sees the patient. So let's start acting and helping these patients today, right now, and in the nearest future. I want to thank you for your kind attention, for patience, and I want to say that we always present the important information on the website of Eurasian Association of Therapists. Here is our website. On top, you can see Instagram of our association. We demonstrate all the state-of-the-art symposium news. And if you can't outreach us now, please contact me on the Facebook. I always respond. Thank you for your attention. Take care. And now it's a Q&A session in just 1 second.
Итак, сейчас посмотрим, какие вопросы к нам поступили. Да, поступило их достаточно много.
Let's see the questions. We have lots of questions. Let me go to the Q&A tab.
Вопрос касательно приносящих артериол. Григорий Павлович, я позволю себе ответить.
Here is a question about arterioles, and let me repeat again. I think I dwelled upon this topic in the presentation. Indeed, all calcium antagonists are capable of expanding the outgoing arteriole, but they do it by 7, 8, 11%. So formally speaking, they're expanding, but formally, lercanidipine is doing the ingoing and outgoing expansion. I showed you 2 pages with the data on amlodipine and niflodipine. And in fact, here we should look at what we need to control and what should be our strategy. Let me repeat, and I will agree with Grigory Pavlovich, there is no perfect combination. There is for everybody. There is a combination. There are combinations that are individually chosen. Grigory Pavlovich, a question to you on the choice choice of beta blocker for the patient with hypertension. How would you classify the patients? How would you choose beta blockers for different types of hypertension patients? I'd start from the word concomitant pathology. Let's evaluate, because concomitant pathology will largely define the outcome of this patient. If this patient has an excessive body mass, abdominal form of obesity, then our mission is not only to make the beta blocker to control the hyperactivity of sympathetic neural system, but also it should help to lose fat. Stimulation of beta-3 receptors helps. The beta-3 receptors are transforming the white fat through beige fat into brown fat. It's when heat is discharged, and so when we know nebivolol is stimulating beta-3 receptors, then the choice for the patient with excessive body mass would definitely be for nebivolol. If we're talking about a patient with expressed failure of vascularization, low ejection fraction, then we have a different problem, a risk of sudden cardiac death. So the strongest effect of beta blocker is the one bisoprolol has. There are no good and bad beta blockers. There is a specific patient that you have with a combined scope of concomitant pathologies or comorbidities or polymorbidities, and he needs a tailor-made approach. But when you choose a beta blocker that you choose, please check yourself 10 times whether or not you have been mistaken and whether or not you know what is the metabolization of this drug. If it's a short period, you won't guarantee 24 hours. Atenolol is a great drug, but it is metabolized during 6 hours. You will hardly administer it 4 times a day, and the patient won't take it either. So the key is how many hours do you have a guaranteed concentration of drug? Second, what is the concomitant pathology? Third question, what is dominant today? Answering these questions, you will choose a beta blocker. The next question is, beta blocker is administered, is titrated, but the target heart rhythm is not achieved, and there's angina. What is the tactics in case of Brody and tactics in case of angina with already administered high dose of beta blocker? What would you suggest to the patient? It's a very interesting real-life question. If we were to honestly titrate the beta blocker and it would be taken to the maximum dosage, and you can't titrate the beta blocker, then we see a technology of giving another drug. It's a ibuprofen. It's very important, and I have to mention a few things before that. You need to control the pulse, should be at least 50. Can't increase the starting dosage, it should be 5 mg. You can't give one-time dose more than 7.5 mg. You can't increase the daily dose more than 15 mg. You do this, nothing happens. Then you think, is there another reason that leads to this stable angina? Start from simple things. What happens to hemoglobin level? Anemia. Anemia is one of the frequent reasons to develop regular angina. What's happening to thyroid gland? Control it, and keep in mind the third parameter. Stable angina is among people with sleep failure, apnea, snoring. The reasons that support regular angina are so many in real life. That's why a therapist is an internist. He will think, analyze, and try to figure out what's happening to the patient. What are the concomitant pathologies? Is the problem only in hyperactivity of sympathetic system, or there are some others? Only this kind of holistic analysis will enable you to control your patient well. What if an analysis detects atrial fibrillation and we can't do AF blockers? Definitely, when you have AF fibrillation, you don't need a blocker, nothing to impact on, there is no material substrate, and in this situation, it's a very severe problem that we're facing. The patient has AF, not sinus rhythm. The heart rate is below 110 strokes per minute. You can't have it. It's much higher. You're alarmed. Beta blockers can't be increased in dosage. Let me tell you that if this angina persists, of course, it will have a negative impact. It will remodel the left ventricle very quickly. Left ventricle will fail, left atrium will fail. And in this situation, you need to at least discuss in a consilium the option of ablation. It might sound excessive, but you can't control the heart rate of this patient. Maybe you should think, maybe your patient doesn't tolerate beta blockers at all, and to change it from more frequent to less frequent administration is arguable. But if you clearly know that you have chosen the right beta blocker and you honestly did a titration, and you reach the highest dosage of beta blocker and angina is way above 110 strokes per minute, long-term prognosis is not good. And you need to undertake tough measures. So I would probably discuss surgical correction. What about an amiodarone or digoxin, giving these drugs to the patient? What do you think about it? Because this study shows that heart rhythm failure is one thing, but then you might have a higher risk of arrhythmic death. DIG study, the entire horror of this situation is that there is no study that has been conducted in the patients with atrial fibrillation. Strangely enough, but this is the way it is. Now there is a study going on. It should be completed in 2023. It's digoxin in the patients with AF. Digoxin can be chosen. But I want to specifically highlight, please be cautious with digoxin. Starting dosage and dosage in general depends on body mass, sex. Women should be lower. Weight below 60 kilos is 0.25 mg. It depends on age, above 80 years old, 0.25 mg, from renal conditions. So many problems. This is not a routine. A therapist should be really knowledgeable to give digoxin. When I was a student, digoxin was administered every now and then in crazy doses. The scheme was if the patient is not nauseous, then you can is nauseous, then you reduce the dose. Thanks God they gave it up because it entails a sudden cardiac death. The maximum clinical effect and the minimum toxic effect is 0.25 mg. You shouldn't increase the dose furthermore. You can always try and give digoxin, but if you have an elderly patient, the probability of intoxication is very high. Digoxin can be considered cautiously. Amiodarone, I would probably add here, I do apologize, I would add here that COVID-19 is a special caution for digoxin because a lot of patients have electrolytic failures if they are treated by digoxin for COVID-19 and potassium level is failed. Keep in mind for pandemics, and Brady that develops a choice between beta blocker and antagonist, calcium antagonist. I think this shouldn't be a choice per se. Beta blocker is administered not only for angina, but also for concomitant pathology, achieving the target level of heart rhythm, heart rate, is what we need to achieve. Antagonist is administered for nephroprotective and blood reduction purposes, but not for heart rate. This is it. This is the entire goal we're pursuing, especially if, as it is mentioned here, we're talking about combined drugs. The time of our discussion is up. Part of the questions were not taken, but we'll definitely do it later. I'd like to announce a 15-minute break. After that, we will have one of the brightest events of today. It's the final session. Final session will be called Future Forum. forum, in this session, 7 well-known specialists from different countries, they will tell us about how COVID-19 pandemics changed what we have been used to. We will have the experience of France, Belarus. We'll talk about the situation there and the changes of cardiology there. We'll speak about myocarditis because we see 70% of myocarditis in these patients. We'll speak about changes of the approach to the treatment of heart failure, experience of Slovenia, changes of the strategy in treating diabetes. Keep in mind that we have restriction caused by COVID-19, of course, prevention of embolic complications. The countries that didn't switch to the high therapeutic doses of anticoagulants had the highest rate of thrombosis. We'll speak about European experience as well. Our mission is to consolidate the efforts, the experience, and use it for further promotion and development of healthcare system. The messages that you will hear after a short break will be interesting, practical, so I urge you to stay for the final session and listen to what the experts are telling us about the changes in medicine in the nearest future. See you in 12 minutes. See you soon.
Но я тогда оставлю маленькую интригу, о чем я буду говорить, а потом вас спрошу, насколько я довел мысль.
Хорошо.
Ахмеджан Бегалиевич. Хорошо.
Я всегда жду от Андрея, я всегда с большим удовольствием.
Хорошо, мы на 5 минут прервемся и в 17 включимся тогда. Я пойду себе еще чашечку чая сделаю. Как вы смотрите на это?
Добрый день еще раз, уважаемые коллеги. Для тех, кто смог присоединиться только в конце, вы подключились к одной из самых интересных сессий сегодняшнего дня. Она носит название Future Forum, или «Будущее современной медицины». Ни для кого не секрет, что сегодня, в октябре 2020 года, мы говорим о будущем в рамках пандемии. Фраза «пандемия изменила мир на до и после» набила оскомину. Она звучит из каждого экрана и радиоприемника. Давайте попробуем разобраться с точки зрения медицины и здравоохранения. Мы с вами практикующие врачи. Что для нас меняется в системе организации помощи, в системе оказания этой помощи пациентам, в ведении коморбидных больных? И для этой цели мы пригласили 7 ведущих экспертов из разных стран мира. Каждый эксперт представляет свою страну. У нас и Франция, у нас и Армения, у нас и Казахстан, у нас и Беларусь, и Российская Федерация.
We've got Armenia, Kazakhstan, the Russian Federation. Each country, each expert will share his experience. Our goal is to consolidate this experience and to pull our efforts for further development of healthcare. This breakout session is very short. There will be 10-minute break. So the first presenter is Aik Vardanyan. Mr. Vardanyan, good afternoon. We know you very well by correspondence. I know that you went to Armenia to fight against the COVID-19. I was unable to go there. Otherwise, I would have met you personally. And I'd like you to share your experience. I know that during the pandemic, you were in charge of the hospital, in charge of the ICU unit, and you also send dispatches about what's going on in each unit. Could you make a 10-minute presentation to sum up this experience in the healthcare system of France? What has pandemic changed in France? Will you have more ICU beds? Maybe there will be different stage of development of the healthcare. Maybe there will be more throat swabs taken. Please, dear colleagues, my name is Aik Vardanyan. I graduated from the Yerevan Medical School, then St. Petersburg University, and now I live and work in France. During the last 8 years, I was in charge of the ICU, Samuel Way. During this period, I saw the prosperity of French healthcare system as well as its problems. I should say that as a Soviet person, I was very surprised looking at the system of French healthcare system. Well, before the pandemic, the healthcare system in France had a lot of different supplies, equipment. It's a very good system of medicine because France is a rich country. There is a lot of money in the system of healthcare, but then the economic problems occurred. Reforms in the system of healthcare started at different levels, and well, at first everything is more or less okay. In March, COVID-19 knocked on our door. This totally changed everything, not just the doctor's attitude, not just healthcare managers, but also politicians, bureaucrats changed their attitude toward the healthcare system. And well, actually, doctors were treated like heroes. Every evening, people applauded us. And at the same time, we were under constant strain. We were not ready for that particular number of patients. Also, don't forget that this pathology was totally unknown to us, and that meant additional strain on doctors. Nevertheless, we managed to organize the system of care for COVID-19 patients. We managed to provide specific services, and that was positive. That we managed to do it relatively quickly, but nevertheless, there were drawbacks in the organization of healthcare detected at the state level in France. The thing is that first and foremost, healthcare managers and politicians realized that we did not have enough reserve to cope with such a huge number of patients. Not just the material resources, but also human resources were lacking. So despite this, and I think this has happened in other countries as well, we managed to reorganize the healthcare system in France to change the situation. But the first wave of COVID-19 left a negative indelible mark on us in terms of psychology. We can say that at the very beginning, there was some kind of a wave of patriotism. People were ready to help each other. People were ready to rush to hospitals to help doctors. But after 4 or 5 months, everything has changed, not just among people, but among medical staff. Right now, it looks like people are very fragile. Doctors are very fragile. Well, people are very careful at looking at what is happening now and what might happen right now. So right now, it's the second wave of the COVID-19 pandemic. Recently, there was a meeting of the crisis committee. The situation is getting more and more serious. Well, of course, we can add more money. Well, we can make companies produce face masks or paracetamol and other drugs, but at the same time, the major problem here is that we cannot, within a short period of time, to train doctors and medical nurses in the field of treatment of COVID-19. So the major problem when the pandemic started and right now when we have the second wave is poor organization. And that is why the medical nurses and the middle-level staff contracted a lot of infection. At the very beginning, we didn't have a lot of doctors infected, but now 10% of medical staff is COVID positive, and that means additional problems for any hospital. What to do with these people? How to continue to treat patients when 10% of doctors cannot do it? Well, you can add more beds to every hospital as well as a state-of-the-art equipment, but there should be a medical nurse, a doctor who knows how to run this equipment, and we are lacking these doctors because many of them, up to 10%, contracted COVID-19. So the question number one right now is how to organize the system of care, how to slow down the number of patients so that our medical staff, which is in a very poor psychological condition, could continue treating patients. How can we triage our patients? So that's very important. That's an important element. And I should say that the pandemic will last for a long time. And unlike the spring and summer period, now we do not have a peak, but we have a slow rise of the number of cases. On the one hand, it's good because we can pull our efforts to cope with this rise, but at the same time, we will have to cope with this for a long time. We got used to it. Well, doctors got used to living with COVID-19 around them, and there are units where patients are COVID positive, units where COVID negative. We have surgical units for COVID positive and COVID negative patients. Right now, I should say that this COVID-19 has probably becoming just an infectious disease, dangerous but ordinary. We treat COVID-19 at the same time. We have cancer patients. We do surgeries simultaneously with that, and this process can be very long in time. And I, as a person who is responsible for such services, I must reserve people, prepare people for that so that psychologically they would not break down. The psychological aspect is It's very important so that they could deal with this situation for a long time. Let's say the government says again that we can cancel vacancies of those medical staff who had the infection, who are psychologically tired, who burned out. That's a serious problem. And obviously, we understand that maybe in 10 days the number of patients will increase, and this process might continue. Everyone should be responsible, and naturally, we should give everyone the opportunity to get specific care. When a person comes to the hospital, when the patient comes to the hospital, we should not have a choice what to do. First treat young patients and then the elderly patients. We should treat everyone equally. And once again, this is just my opinion, and it's important for me. Well, this is a question of choice. Left a negative mark on our psychological psyche among doctors. Well, ICU specialists, resuscitation specialists were ready for this. Other doctors were not ready for seeing so many people die. And again, we should think about how we can improve safety measures and maintain them at the specific level, how we should do so that patients follow doctors' recommendations. And we haven't won this war with COVID-19 yet. We just won one battle, but the war continues, and it will continue for a long time. So that's my main message I'd like to convey. So through concerted efforts, together, we should think not just about what should we do when there is a peak of the infection, but when there is just a constant slow rise of the number of people with the coronavirus. Again, we should not forget about other patients, patients without the coronavirus. We should not here divide between patients with COVID-19 and without COVID-19. All patients should be treated equally. That's my message. Thank you. Thank you so much. Judging by what I've heard, you're talking about the need to prevent the staff burnout because the staff is under the serious psychological pressure during the first one. COVID-19 care services should be integrated into the healthcare system. When we have a cardiac patient or patient with endocrinology problems, he may be COVID-19 not COVID-19 patient at the same time, but if you do the triage, this can help you to elevate the situation. Okay, thank you so much for sharing your views with us. So let's continue our fight against this infection, and I'm sure that through concerted efforts, we'll be able to do it successfully. Thank you for sharing your experience. That was Aik Vardanyan, who worked in this COVID-19 unit, and he sent us interesting messages regarding what was happening in the red zone. That was a French experience. Denis Nikolaevich Protsenko is a little bit late. He will join in later. Now I'd like to give the floor to Andrei Rudoy, who is a professor, a doctor of medical science, and he will share his experience, how cardiology changes. The problem is COVID-19 not just affects kidneys, but also we're talking about the developing myocarditis. It may not be very manifested. Sometimes the picture is quite clear when troponin is elevated. We can see the situation when there is heart arrhythmia, and we can see ST segment elevated on echo. Well, hyperkinesis may occur. All these changes are due to the virus's ability to damage myocardium, and the study conducted in Germany showed, well, I do not know exactly about the percentage of people, more than 70, I guess, had myocarditis. And in fact, we're now in a situation where one disease, but it affects different organs, and the cardiology should also change to respond to myocarditis. It's heart failure, it's coronary diseases, arrhythmia, and so on and so forth. So we'll have to deal with these consequences of the COVID-19 pandemic. Andrei Rudoi will share the experience of the Republic of Belarus, how cardiology is going to change due to myocarditis in COVID-19 patients. Andrei, the floor is yours. Thank you very much. Yes, you have already presented the topic of my presentation, and I should say that up to 63% of patients had myocardial dysfunction. But as for my presentation, the topic is, will cardiology change, bring to bear the recent data. Myocarditis is a very mosaic picture, and of course the diagnosis is very difficult. Everything depends on the etiological aspects. As for the selection of strategy, everything depends on invasive and non-invasive diagnostics. In the first case, I'd like to draw your attention to the European guidelines. So they support the concept of endomyocardial biopsy as the golden standard of diagnostics, as it helps to detect the myocarditis, and we can administer immunosuppressive therapy depending on the status of this patient in terms of virus positivity. So as for guidelines in Europe, it is feasible to do the biopsy only when there are adequate methods of immunohistochemical analysis in the clinic. That's option number one. And option number two, to detect the viral genome. Only in this case, this will change the therapeutic potential of treatment of such patients, depending on their status, positive or negative. In the first case, when it's negative, maybe it's feasible to administer immunosuppressive therapy when patients have the giant cell MC and eosinophil MC. What happens in real clinical practice? Clinicians often administer glucocorticosteroids. So maybe this is the wrong strategy, especially when we're talking about the acute forms, unstable hemodynamics, leading to the threat of life to this patient. Another interesting data are shown here: successful immunosuppression of myocarditis with the chronic cause. The data obtained recently show that we can even worsen the prognosis if there is the drop in the injection fraction. Another question is that myocarditis positive by parvoviruses. In 2013, well, European guidelines did not mention this therapy. In 2020, everything has changed. All European registries in Russia, you can see the green color on diagrams, show about the dominant role of parvovirus infection. This is DNA-containing virus. It's not herpes virus, so it's not an enterovirus. It has a special immunogenicity, and this is a serious problem of persistence of the viral genome. You can see the ESC data of 2020. Every fourth patient with heart failure has the active form of a parvovirus infection, and in many cases may be active. These are our data for the Republic of Belarus. Viral genomes detected when biopsy was taken from 36 patients in 70% of cases. So you can see the positive reaction, and again, this is active infection with parvovirus dominant infection, which is comparable with the European registry. As you can see it here, also parvoviruses contribute a lot to myocardial disease. So how can immunosuppressive therapy change when we take into account enteroviruses and the dominant role of parvoviruses, plus taking into account the COVID-19 infection? Bring to bear the dominance of the parvovirus infection, Professor Blaga came up with unique algorithm of the diagnostics of myocarditis, and myocardial biopsy is needed for the effective immunosuppressive therapy. Well, as for COVID-19, there are a lot of questions. Can lymphocytic chronic myocarditis develop in this case if the patient is COVID-19 positive? Well, you can see Patricia Caforia for a long time was skeptical about it. Well, acute damage, is it possible or not? But again, look at acute heart failure with the clinical form of myocarditis accounts 7%. These are data from our Republic, pathology data, and you can see that here is the classical picture, which corresponds to the classical criteria of myocarditis. The Italian group of scientists came a unique clinical case of fulminant myocarditis after all respiratory symptoms were resolved. You can see there were no patterns of pneumonia, and you can see data of myocardial biopsy with the detection of SARS-CoV-2, and you can see damage to macrophages. We can see the changed localization in the membrane, and again, you can see that there is the process of migration of these infected macrophages from the lung tissues. And another interesting study from the Charité Clinic, detection of viral SARS-CoV-2 genomes and histopathological changes in and myocardial biopsies. Again, patients with low ejection fraction, 33%, and there is the classic lymphocytic myocarditis. And the Russian colleagues from the Sechan University provided data of the development of chronic lymphocytic myocarditis, and you can see it here, TLR type 4, TLR type 9, that's congenital immunity. And again, German researchers show that COVID is related to some damage, maybe the viral damage to the heart. You can see viral RNA was detected in 60% of cases. Thus, the question is, micronization of myocarditis, and you can see at the Charité Clinic, they provided data, coronavirus disease, and the heart. Again, you can see that and I mentioned this at the very beginning. Well, you can see the German data that 2.5 months later, we can see that there is a residual dysfunction of the left ventricle according to MRI, and there is elevated troponin in these patients. So we see that myocarditis can develop in such situations. Well, what happens in patients when they had already had myocarditis? Multivariant immunosuppression can be more favorable in this case. On the one hand, at the top of the slide, you can see the acute situation when myocardium is affected, and there is acute myocardial dysfunction, type 2, or acute coronary syndrome. On the right, delayed effects, arrhythmia, for example, and atrial fibrillation. Well, in this case, we can do the assessment of such events only a year later. Right now, there is no possibility of formulating recommendations to treat myocarditis, but we know cardiotoxicity and when especially lopinavir and other antiviral drugs are administered. Right now, experts believe that as for ACE inhibitors, they should not be canceled if they were administered according to indications. Well, the question is whether the viral myocarditis is COVID immune. Should immunosuppression be used here? Well, plus pulse therapy with prednisolone, but not when the main disease develops. This is still an open question. Thank you very much. I hope there will be questions later, and I'll be glad to answer them. Andrei, thank you so much for this brilliant presentation. But nevertheless, what is your position concerning corticosteroids? A lot of patients like that get corticosteroids to treat the COVID-19, to block cytokine storm, and well, anyway, we cannot say that this patient has myocarditis or not. Well, will you say that this patient should be put on glucocorticosteroids, or should this therapy be stopped if the patient is already on these drugs? Well, again, we should talk about chronic or acute form of COVID-19 or diagnosis of myocarditis with no COVID infection. Of course, when there is COVID-19, acute condition. Okay, naturally, I raised this question concerning the immune or non-immune mechanism of damage or immune and non-immune lesions, and those dosages, 6-8 dexamethasone when we administer immunosuppressants to treat the main disease when there is the suspicion of myocarditis. Soft immunosuppression is indicated here. Well, as an immunologist, I have my own attitude towards cytokine storm. Well, as for myocarditis, well, you know, there is a special inflammation mechanism when inflammasome type of inflammation is developed, and here target therapy should be administered, tocilizumab and interleukin-6, but that's a different kind of immunosuppression. That's a different story. So the moderate dose of glucocorticosteroids, as indicated, is quite necessary. And of course, here we can suspect myocarditis or acute heart failure. I'm sure that in practice, doctors will use also a short course of prednisolone as well. And what is your opinion about the challenges in cardiology in terms of consequences due to myocarditis in a year? Will there be a higher number of patients with heart failure, or maybe there will be a larger number of coronary events due to the plaque destabilization? Maybe not now, but in a year, 2 or 3 years, what are long-term consequences? Thanks for this wonderful question. And we're talking about the systemic response. Obviously, these changes won't be just local, and of course, they will affect the areas of myocardium. There will be arrhythmia. In a year, I think we'll have interesting study. Now, 14% of patients have ventricular arrhythmia. As for long-term prognosis, we expect more patients with atrial fibrillation. As for chronic heart failure, obviously, I think that half a year from now, a year from now, we will have results. And obviously, the diastolic dysfunction will worsen. We have already discussed it. And remember the letter of German researchers and their MRI research, high-sensitive troponin, 2.5 months after all symptoms of COVID-19 were coped and controlled. So this may be a negative long-term prognosis. Andrei, thank you so much for this wonderful presentation. I think there will be more questions. And now I'd like to say that since we talked about myocarditis, the position of the immunologist, well, how the situation is going to change in cardiology, there will be a larger number of patients like this, arrhythmias and heart failures. And if it's heart failure, what changes are we going to cope with? The next speaker is from Slovenia, a cardiologist who has worked with heart failures for a long time and COVID-19 as well. He will share his experience, how therapy will change. We talked about chronic heart failure, but what is going to happen with this patient? Maybe there will be a decompensation. Maybe this patient will require aggressive therapy. And we must understand how COVID changes chronic heart failure, especially when we're talking about patients with a high degree of heart failure or advanced heart failure. Now I'd like to give the floor to Bojan Vertovic, Ljubljana, Slovenia. He is a specialist in the field of heart failure, and I will have to speak Russian, and there will be a translation into English. Nevertheless, I'd like to give the floor to the next speaker, please. Bojan, the floor is yours.
Thank you so much. Thank you for your kind invitation. I'm proud to be able to present at such a distinguished meeting. As you said before, my background is really advanced heart failure. So briefly, just to summarize, I'm working in Slovenia. So Slovenia is a very small country, and there is one medical center that does advanced heart failure therapies, which is Ljubljana. The whole population of the country is 2 million. So this is the medical center I work with. And I work in, and we have an advanced heart failure and transplant program. So as said before, one of the main problems also in the COVID era is really the advanced heart failure patients. So we are focusing a lot of COVID lately, but we have to remember that the mortality of patients with advanced heart failure is very high. So patients with any kind of advanced heart failure, like they have the criteria listed here, have a mortality up to 50% 1 year. So when you compare this to, let's say, COVID mortality in other population, it's still very high. So we need to, despite the problems that we're having with COVID patients, we need to still, try to preserve the program for advanced heart failure, even though it's very difficult to do this. So the guidelines said here, there are a couple of strategies you can do this. And what we have available in Slovenia are a couple of strategies, which is heart transplantation, total artificial heart, mechanical support, and cell therapy. So I will not focus on medical management, obviously, because it has been touched by previous speakers, and there is really no changes in medical management really heart failure patients with regards to COVID. However, there are major differences, I think, in the areas seen here. So heart transplantation per se, this is just the data from the ISHLT level. We have seen the mean plateauing, and we have seen that there has not been enough heart transplants based on the waiting list numbers in Eurotransplant. In Slovenia, we have been able to have a successful transplant program, actually. The numbers per million population have been #1 actually worldwide for the past 8 years. However, we are very worried what will happen, with regards to heart transplant numbers during the COVID era. So at the beginning, our first wave was in March. We were very frightened, actually, because also, when you have heart transplant patients, they are immunosuppressed and they have a very high mortality. There is German data showing that the heart transplant mortality is even 50% when they get COVID. So also you have to realize that even before heart transplantation, these are data in Slovenia, people on high urgency waiting list, meaning the ones that are very sick, wait for heart transplant for, let's say, on average 60 days when they're in hospital. So I don't know about other places, but in Slovenia, it's sometimes very difficult to find patients with advanced heart failure and have them isolated to a certain level so they do not get exposed to COVID. So this is one of the major problems. So not only patients after heart transplantation are problematic, but also patients waiting for heart transplantation. So we try, in our hospital to isolate them in an ICU that's COVID negative, which was possible in the first wave. It's getting increasingly difficult to do this in the second wave since we're facing more and more patients with COVID positive. So our waiting list mortality has not changed in the recent years, and our transplant outcomes are similar to ISHLT. However, we were actually able to increase heart transplant numbers this year because we were getting more donors in the first half of the year. So we have seen an increase. However, this has been changing recently because of the problems that we're having, actually getting on waiting list on time. So what we actually have done, except for isolating patients in our ICU, we are also using telemedicine. I will show this to you later to try to isolate also on the outpatient basis. However, we are facing increasing difficulties. So the other option is really when you have a patient with biventricular failure, you can implant a total artificial heart. In this case, I mean, this is a very aggressive form of treatment, I think. And well, you do not have immunosuppressants, but I do not think that this is something that's going to be very popular in the COVID era. So we have total artificial heart that we use is the only one, which is Syncardia. And we have had eight patients so far, however, none in 2020. So this program is not really working right now with regards to total artificial heart. The other aspect is mechanical support. When you have a problem with, heart failure that's only left-sided heart failure, you can implant an LVAD, which would theoretically be the strategy to go with if you do not have enough heart transplants. So we have done 68 so far, mostly HeartMate 3. Those are the latest developments. But you have seen also that even in LVADs, we have seen a decrease as compared to previous years. Our numbers are not very high. However, still, we have seen a trend towards decrease. So this may be due to the fact that in Slovenia, patients in heart failure, they do not come in early in the COVID area. We had a specialized heart failure transplant clinic. However, patients before this time were able to come on time, so they were not as sick as we see right now. Right now, they come in when they're very decompensated, and sometimes they're even too sick to be able to be considered for an LVAD implantation. So I think it's of paramount importance to tell to the people not only that COVID is dangerous, but also that the other diseases are not going to go away because of this. And, waiting and not going to the doctor with your heart failure is going to be fatal, even if you don't have COVID. And also we have done stem cell therapy, which has been also shown recently to be of some benefit in COVID patients. However, not in our hands, we have not done this. We have only done this in patients with non-ischemic dilated cardiomyopathy with some interesting results. This is just a program I'm showing to you because we were able to keep this despite the COVID for a while now. However, this has stopped, and I think in the future, hopefully, we will be able to continue with this in a research way. We typically do transendocardial cell injections, and in patients with non-ischemic dilated cardiomyopathy. We have seen improvement with this regard. Many centers have been using actually immunomodulatory aspects of stem cell therapy in patients with COVID, just intravenously. I have not seen the results that have been published in a very persuasive way, but however, maybe this would be a way to go. With regards to future of this, we're also doing allogeneic stem cell therapy for ischemic heart failure with preserved ejection fraction, and also LVAD stem cell combination therapy. However, this has all been stopped really this year because of the COVID. So hopefully we will be able to continue this in the future. So maybe to summarize, what to do with patients with advanced heart failure. I would think, number one, we should be committing our resources to try to isolate them from different patient populations. So they seem to be of very big danger of complications with COVID, even the ones that are waiting for transplant or the ones, after heart transplantation. We should do this in hospital and also on the outpatient clinic. If this is not working very well, we can still go and try to do the telemedicine approach. What you see here is really we're giving patients the blood pressure monitoring, saturation. They have a weight, and they actually do this automatically via Bluetooth. So when they are on the waiting list for heart transplantation, they get this gear, and after they are transplanted, they are discharged also with this. So that's how we kind of decrease the numbers of outpatient visits, and we can potentially decrease the exposure to COVID, especially now when we have the second wave, which is, I think, in Slovenia much worse than the first one. So with this, I would just like to thank everybody in our department who has been working very hard, and all the collaborators. And again, thank you for your attention, and hopefully we will be able to fight also for these patients in these difficult times. So thank you.
Уважаемый профессор Боян-Вертовец, возник очень серьезный
Well,
вопрос.
Professor Boyan-Vertovets, there is a serious question. The previous presentation was devoted to myocarditis. What is your stand? Do you expect an increase in the number of patients who had COVID-19, who had myocarditis at the same time, which might lead to the development of heart failure? What is your forecast? In a year, in 2 years, in 3 years, will there be an increase in the number of people with heart failure?
Thank you for the question. So even so, right now, without COVID, there is 50% of people that get to advanced heart failure because of non-ischemic heart failure, meaning potentially dilated cardiomyopathy due to myocarditis. So yes, I do foresee an increase, a significant increase in the future years, because much of this myocarditis will go unrecognized. And we are not as aggressive. We do not do enough biopsies in Slovenia in our center. So a lot of myocarditis is really considered to be idiopathic dilated cardiomyopathy, which is not the case. So we do not diagnose myocarditis in our center on time, and there may be problems with this because of different centers' strategies, whether or not to perform the biopsies, whether or not to do immunomodulatory therapy. So in any case, we do expect this. We have also seen cardiac involvement in our COVID patients that have survived COVID, but then developed heart failure 1 or 2 months after this. And we treat them as regular heart failure patients. Fortunately, so far, they seem to be okay. But yes, I do think that this is going to be a problem in the future.
Thank you so much for your presentation. Thank you for sharing your experience at our conference. I hope this is not our last meeting. I wish you every success in fighting for our patients, especially patients with cardiovascular diseases, and I hope you'll successfully cope with the second wave of COVID-19. Let's move on according to our schedule. Now, I'd like to invite one of the experts who has spoken a lot at the Eurasian Association of Therapists. So that's one of the experts in the field of endocrinology, one of the opinion leaders, that's Juro Matsut, who is a great expert who has been dealing with issues of diabetes mellitus, important questions of endocrinology, and he agreed to share his experience, the treatment of diabetes mellitus. In the era of COVID-19, will there be a growth of the morbidity rate? Well, when doctors work in the red zone, they see patients who have the onset of diabetes mellitus due to the coronavirus infection. We see patients who have significant changes in the glycemic profile. We should know what to do with them. Is it diabetes or is it just the peculiarities of the coronavirus infection? Some medical journals already say that there is a connection between coronavirus and the pancreas. Well, I'd like to give the floor to the expert in this field, and the theme of the presentation is management of diabetes during COVID-19, and what should we do with the development of diabetes mellitus.
Well, Alexander, good day. Hello to everyone. I'm so glad to be again with you and to take participation on this year's conference on the Eurasian Association of Therapists. I would like to continue with this excellent specified session related to the actually outcomes of the COVID on different organs and systems, and to share with you some of the aspects of the diabetes during COVID-19. So what about the prevalence of the comorbidities with the COVID patients? What was really interesting was that we discovered that the diabetes is on the second place after, for instance, hypertension. So it was the most prevalent among the chronic diseases after hypertension with the patients that have COVID-19. And in a huge meta-analysis of the studies, you can see that the percent of the patients with diabetes is almost approaching of 10. If we take a look more precisely into the analysis of those studies, you can see that even more patients, you can see that the numbers are even up to 20 So we have really to think about how can we manage and what will be the outcome of the current therapy of the COVID-19, the therapies that we are used and actually the outcomes on the patient. We have to recall some data about the predictors on the composite endpoints. And you can see that the composite endpoints related to the admission to the intensive care unit, invasive ventilation or death, could be placed on this way. So we have the type of comorbidities on the upper part of the slide. You can see that the chronic obstructive pulmonary disease, diabetes, hypertension, and malignancies could be isolated endpoints or actually the features that are related to the endpoints. And you can see that the diabetes is 1.5% higher in those cumulative endpoints. But if we connect together more of those endpoints, we can see that they are increasing. For instance, diabetes plus hypertension is going even with the 2.5 times more hard ratio for the composite ending of the patient. Taking this into the conclusion or taking this into the consideration, we can see that the patients having diabetes are more prone to develop complications related to the COVID infections. So what will be the associations of diabetes with the actually fatality of the COVID-19? In the center of the slide is diabetes again, and if we take into the consideration models number 3, which is additionally adjusted for the inflammation or inflammatory biomarkers, you can see that the ratio of diabetes is going into 3.6 times more higher, and this is really significantly positive. Even fasting blood glucose is related to the COVID or to the COVID outcome. So we have to consider very seriously glycoregulation with those patients. So what are the predictors for the disease progression and mortality? On the first place, these are the glycemic indexes that are related to the disease progression. So we have hypoglycemia, glycemic variability is very much important, and we are talking a lot in the previous years about that, and the overall glucose control. And these are some studies coming from China and Italy related to that. But the main factors are the HbA1c, so the retrograde glycoregulation markers with the elevation between 7.5 and 10. Actually, we are in relation to the body mass index. So if we have the range of normally weight but overweight patients, so this group of people are more prone to develop COVID-19, irrespective of the type of diabetes they have. And this is turned into the more related hospitalizations, and that is more frequent with the patients with having poor glycoregulation. Overall mortality is also important, and it is higher in people having type 1 diabetes in comparison to type 2 diabetes that we have to take into the consideration. So having the patient with type 1 diabetes with the HbA1c over 10 showed us an independent association with the outcome. On the other side, diabetes ketoacidosis and severe form in children and youth could be also related to the poor outcomes with the infection. If we take the risks for the mortality of COVID-19, we can see in this Chinese study that the mortality is quite high. So 7.3% on the mortality is related to diabetics in comparison to less than 1% in the patients without this type of comorbidities. So diabetes is appearing as one of the leading factors actually predicting the poor outcomes. So what could be the reasons? On one side, we could have the irregular dieting, reduced exercise, problems with the gastrointestinal, fluctuation of the glucose, but also the use of glucocorticoids that is making the gluconeogenesis with the patient and deteriorating further the levels of glucose. But on the other side, we could have also the anxiety, tension, stress, with those patients that is again making problems with the glucose and actually at the end producing inflammatory cytokine storm that is directly putting the patient into the life-threatening condition. So now how to help? Medications are quite important. And today we are talking a lot about the ACE2 protein, which is one of the most principal receptors that is SARS, that is COVID actually entering into the cell. So with the therapies having the composition of DPP-4 inhibitors, we can say that these patients are less prone to develop disease or to be affected and to have the outcomes with the relation to the COVID. If we take a look onto the onto this table, we can see that we have on the first place the insulin treatment. That is the first choice in diabetics that have complications of the COVID. But on the lower part of the slide, you can see that different drugs could be used differently. For instance, we do not have the clear idea about how to use the DPP-4 inhibitors, but we have the clear against for the SGLT2 inhibitors. On the other side, glitazones could be used in the patients that are not severely affected by the COVID. And at the end, some little bit forgotten therapies like the alpha-glucosidase inhibitors could be used also to control the postprandial glucose. So according to the patient profile and according to the severity of the disease, we can select the type of the drugs. For the summary of this part, we can say that we have differences between type 1, type 2 diabetes and some glucocorticoid-related diabetic outcomes. For the type 1, the insulin pumping or the application of the basal bolus regimen could be the most optimal one. Recommendation for the insulin analogs is on the first place, and the tailoring direct to the patient or the patient-related tailoring should be always taken into the consideration. With type 2 diabetes, for patients that have mild forms, we can actually continue with the non-insulin drugs. So we can continue with the present therapy, but with patients with a more severe or critically ill, intravenous insulin therapy is an asset. On the other side, if we have the glucocorticoid-induced diabetes, then we have to monitor this glucose very tightly, and we have to introduce insulin therapy at that very moment. What to expect with the patients having diabetes and COVID? So it is supposed that there is a rise of daily glucose levels and deterioration of the HbA1c in diabetic patients. The worsening of glucose regulation is in line with the known data on the increased death rates in patients with diabetes. But the declining number of outpatient controls of diabetic patients in our everyday outpatient clinics, especially in the last 6 months, is coming as a boomerang to us, because it is coming into the sharp increase of impaired glucose regulation and really not acceptable regulation of those patients. So we should have a load of patients in the next few months, because the curve of infection is going upside down and we are in a new wave of the infection worldwide. So to conclude, we can say that the glycemic control must be optimized and tailored toward the patient, but especially in the hospitalized subjects with diabetes, the medications must be adjusted to each patient, and the insulin must be the preferred therapy in the attempt to lower the level of glucose with the present patient. Thank you so much.
Professor Gianmarco, thank you so much. What is your view? COVID-19, patient had COVID-19, but the patient had no diabetes. Can COVID-19 be the reason for an increase in the number of cases of diabetes in the next years? The virus itself, or no? Or we just see the onset of diabetes due to the viral infection? What is your view on that?
Exactly, you are completely right. So if we still continue with this telemedicine approach, I'm not against, but we must be realistic. If we do not see the patient, if we do not examine the patient, and if we not address the patient on the proper way, we should have an epidemic of diabetics and the patients with non-regulated diabetes. So this is really a big danger for us, and we should be, I think, overloaded in the next year with the complications. So as a joke, we are telling that the first few months of COVID, we are treating the patients with COVID, but then in the rest of the time, we should treat the chronic diseases, and we should treat the outcomes, poor outcomes of the chronic diseases, and the diabetes is really concentrating a lot of chronic problems. So I think that we should have really a huge number of not good treated patients in the next 1 or maybe 2 years even.
Thank you very much for your presentation, for sharing your experience. We treasure your expert opinion. Let's move on. According to our agenda, I'd like to give the floor to the final presentation. Akhmetjan Surgaliev is an expert in the field of thromboembolism and thromboembolic complications. Mr. Surgaliev worked in the red zone. We know that COVID-19 leads to embolic complications. And again, the situation is being aggravated during this symposium. We say that COVID will lead to an increase in the number of myocarditis. COVID-19 will lead directly or indirectly to increase in the number of heart failures. COVID-19 will lead to increase in the number of cases of untreated patients with diabetes mellitus, and COVID will lead to an increase in the number of comorbid patients with comorbidities. So we should take into account also patients who will have venous thromboembolism. Mr. Surgaliev, the floor is yours. Well, good afternoon, distinguished colleagues. I hope you can hear me. Yes, we can hear you very well. Well, good afternoon once again. Good evening, depending on where you are. And thanks for the opportunity to share our experience in Kazakhstan regarding thromboembolism and complications due to thromboembolism in the era of COVID-19, and what are the lessons learned. This picture shows the incidence rate of VTE, DTV, a deep vein thrombosis in Sweden, DVT in Sweden, 162 cases in Sweden per 100,000 of the population. As for pulmonary thromboembolism, it was 115 cases per 100,000 people in the United States, which is about 0.115% the number of pulmonary embolism in the United States. Let's say 0.1%. But during COVID-19, as you can see, and red color shows different figures presented by our colleagues in Italy, in China, and of course in the European region. This figure increased a 20% indicator, the number of DVT, deep vein thrombosis, and pulmonary embolism, especially. Well, you can see that right now we encountered a high prevalence rate of thromboembolism in the era of COVID-19. As for pulmonary thromboembolism and the deep vein thrombosis. It's number 3 after myocardial infarction and stroke in terms of cardiovascular death. Right now, we're thinking about the following thing. During COVID-19, venous thromboembolism is number 1 in terms of cardiovascular death. And naturally, the pandemic has increased the number of venous thromboembolism. And I should say that when we watch different talk shows on TV or news on TV, there is panic on TV among people. And in Kazakhstan, people also began to panic. They ran to the pharmacy and bought a lot of oral anticoagulants, and that led to different complications such as bleedings after watching TV. What can I say? The pandemic has shown that doctors can assess venous thromboembolism, but it did not correspond to the international level. I should say that many doctors in Kazakhstan did a lot of tests to assess the risk of thrombosis, and we know that in order to assess thrombosis, tests should not be done. Instead of that, scales should be used. But as for safety, it should be taken into consideration. I should also say that we carried out a lot of educational programs during the pandemic, and this allowed us to increase the level of knowledge among doctors in Kazakhstan regarding the importance of assessing the risk using international scales and to assess the risk of bleeding or hemorrhage. I should say that in many clinics, our colleagues, I think, unjustifiably used the therapeutic dose of anticoagulants, which increased the number of bleedings. If you look at the risk factors of venous thromboembolism, VTE, the red color shows the dangerous risk factors. You can also see moderate risk factors shown in blue and weak risk factors shown in purple. And dear colleagues, I added 2 more factors. That's D-dimer level and, of course, the presence of COVID-19 virus, which, like the Ebola virus and other viruses like dengue fever, can have the thrombogenic potential, direct thrombogenic potential, which led to a lot of thromboembolic complications. If we look at the experience of our colleagues in France, and they published the results of multi-center cohort study, they mentioned the fact that the risk factors for the development of pulmonary embolism in COVID-19 era is slightly different. The classical risk factors exist, but there are also additional risk factors, such as male gender. We know that men with pulmonary embolism died more from COVID-19. Also, a family history of a stroke as well as atrial fibrillation led to the development of pulmonary embolism and complications. Also, later presentation of the patient since the onset of pulmonary embolism and the risk of pulmonary embolism correlated with the degree of inflammation, in particular with the level of C reactive protein and with the level of D-dimer. At the end, they also mentioned severe lung damage. At the same time, it was noted that those patients, in particular patients with atrial fibrillation, who got the recommended dose of anticoagulants, had a lesser number of thromboembolism and a lesser number of thrombotic complications were in those patients who got the prophylactic dose of low molecular weight heparin in hospitals. In this case, patients had a lesser chance to get to ICU, which is a positive thing. Right now, we know the results obtained in the United States who compared and published the data. Is there any difference between therapeutic and prophylactic doses of low molecular weight anticoagulants? You can see there is no difference here, but there is a difference between those patients who got anticoagulants like low molecular weight heparin and patients who were not on heparin. So you can see those patients who did not get anticoagulation therapy, the mortality rate was much higher. And recently, we got the WHO data, World Health Organization data, and when they said that the WHO that the only drug which can have an impact on such patients is steroids, well, I was a bit upset that they forgot about anticoagulants. Some more information concerning COVID-19. Of course, stroke in patients with atrial fibrillation. Our colleagues in the United States say that stroke has gotten noticeably younger. We had a patient who had the bilateral thrombosis vertebral arteries, and well, you can imagine what kind of condition this patient had. Stroke has become more severe, as you can see it here, as compared to the era before COVID-19. This patient had a high level of D-dimer, and there was a need to use anticoagulants. And obviously, there has been a rise in the number of cryptogenic strokes. And as you can see it here, and the last thing is the high mortality rate after the discharge from the hospital. Of course, with the risk of development of thromboembolic complications, which often occur after the discharge from the hospital, and this happens during the first week after the discharge. What else did we encounter? We encountered the imperfect scales that we used for assessing the risk of thrombosis development. Well, according to international recommendations and according to our Kazakhstan protocol, all patients, in order to assess the risk of thrombosis development, they should be used PAD-2 scale and IMPROVE scale. You can see PADUA and IMPROVE do not have the D-dimer levels, and we also discussed it with our colleagues, Akhmetjan Begalievich. Well, we needed to add one more marker, D-dimer level, to assess the risk of the development of thromboembolic complications. Hopefully, this work has already been done as part of a MARINE study, and they used a different scale called IMPROVE DD, and they added the D-dimer level to the scale if it is more than 2 upper norm. They added 2 more points as the risk for the development of thrombosis. At the same time, the MARINE study showed that the importance of markers that can lead to the development of the higher risk of bleeding. And here you can see its active forms of cancer, the use of DART, bleeding, well, and also cavities in the lungs and bronchoectasis. I participated in different webinars in our countries, and of course, there were patients who, after COVID-19, were discharged with the signs of lung cavitation. Those patients, of course, will not benefit from the use of anticoagulants. It might be very dangerous for them. Nevertheless, COVID-19 patients, like patients with atrial fibrillation and COVID-19, at the same time, these patients who are discharged from the hospital after treatment, they have a high risk of repeat thrombosis. Although there is one study from Ljubljana University saying that the risk of thromboembolic complications in patients who had COVID-19 is not very high. Probably it's due to the profile of patients. And in this connection, I would like to remind you about the recent recommendations regarding the profile of patients who should be on long-term anticoagulation therapy, especially patients who are under high risk. And here you can see rivaroxaban as an oral anticoagulant can be very efficient here, and factor 10 inhibitors, they will play an important role in prevention of recurrence of thromboembolic complications in patients who had COVID-19. I think I can end on this note because I can speak volumes, but I know my time is up. Thank you so much for your attention. If you have questions, I'll be glad to answer them. Thank you.
Ахмеджан
Begalevich, thank you very much for sharing your time. Thank you for your presentation. Could you comment on the following question? How should we select patients, who have the light form of COVID-19 or patients, who have just the light form of COVID-19. Those who get DOAC, as indicated, should they stay on DOAC, so they should be switched to low molecular weight heparin? Well, they can stay on anticoagulants. Those patients who are on oral anticoagulants, in some cases, there may be more severe forms of COVID-19, but you're talking about mild forms of COVID-19. Well, in this case, anticoagulants therapy should be continued. There should be no switchover. Thank you. And moreover, I'd like to say, moreover, yes, please go ahead. Moreover, I'd like to say there are publications showing that oral anticoagulants, when they were used on patients with even severe and intermediate forms of COVID-19, the results were quite good. Yes, that's really so. Well, except for those patients who earlier had been on antiviral drugs. Right now, they are excluded from the list of drugs that can be administered to patients with COVID-19. At the same time, there is an opinion of world experts who say that those patients who have severe forms of COVID-19 who are on low molecular weight heparin in hospitals, when they are discharged from the hospital, we must think about switching those patients from low molecular weight heparin to oral anticoagulants, preferably factor 10 inhibitors. That's what the situation is indeed. Thank you for your presentation. Thank you for your time. We understand it clearly that the use of anticoagulants has increased multifold this time. I don't want to sum up on a sad note. Yes, we said there will be more myocarditis, more embolism, more VTE, more patients with diabetes, more patients with heart failure. At the same time, we continue to develop algorithms of treatment of such patients. So we continue research. We have scientific programs. Through concerted efforts, we'll be able to cope with this situation. I'd like to end on as an optimist. Tomorrow there will be an interesting day, interesting sessions, and there will be breakout session devoted to the use of anticoagulants. There will be symposia devoted to more detailed discussions of COVID-19. There will be pulmonology and endocrinology workshops. On Friday, we'll also have a lot of interesting breakout sessions. And right now, I'd like to end on an optimistic note. Well, thank you for your patience. We are going to show you a video clip prepared by those doctors who worked in the red zone, and maybe we will be able to show this video in other countries. Thank you very much, and bye-bye.
Труд в медицине, поверь, не мед. Славы в ней нету и нет банкнот. Только готовность помочь всегда. Нас вспоминают, когда беда, беда. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без роздыха и нету воздуха, давят очки. И рот пересох, но ты же знаешь, зато тебе с небес улыбается Бог. Слились работа и сон в свой слились работа и сон в свой круг. Редко проводим с семьей досуг. Редко проводим с семьей досуг. Но тяжелеет больной. И вот тяжелеет, и вот долг наш врачебный опять зовет. Снова работаем, снова с заботою, снова идем к нашим больным. В красную зону держать оборону. День простоим, ночь простоим. Сутки без роздыха и нету воздуха, давят очки. И рот пересох, но мы же знаем с тобой, что нам с небес улыбается Бог. Всюду со смертью идет война. В каждой победе своя цена. В наших сражениях всего трудней. Что мы теряем коллег?